a journey fueled by our shared commitment to healing and improving lives. Welcome, and let the symphony of knowledge begin. Just as lungs inhale life-sustaining oxygen, let this conference infuse hope into our endeavors. May our discussions ripple outward, touching patients, families, and communities. Together, we breathe into lung rheumatology, one profound exhale at a time. Ladies and gentlemen, we are about to commence our event by lighting the lamp of knowledge and wisdom. May I request our esteemed chief guest, Professor Dr. Alakendu Ghosh, First President IRA. Then I invite Dr. S.N. Swai, Chairman API, Odisha State Branch. May I now request Dr. Ranjan Gupta, Scientific Chair, Oarc Update III, and Organizing Secretary, Professor Dr. Jyoti Ranjan Parida. Professor Dr. Banani Jena will be joining us shortly. May I request Dr. Jyoti Ranjan Parida to please felicitate our esteemed guests. May I now request you to kindly light the lamp? As the lamp's light continues to radiate throughout the day, let it remind us of our collective commitment to knowledge, harmony, and progress. With this luminous start, we now officially declare the event open and proceed.
जगन्नाथ नमो नमः श्री जगन्नाथ नमो नमः जय जगन्नाथ नमो नमः जगतरनाथ नमो नमः ओम जगन्नाथ नमो नमः श्री जगन्नाथ नमो नमः जय जगन्नाथ नमो नमः जगतरनाथ नमो नमः
ओम जगन्नाथ नमो नमः श्री जगन्नाथ नमो नमः जय जगन्नाथ नमो नमः जगतरनाथ नमो नमः
ओम जगन्नाथ नमो नमः श्री जगन्नाथ नमो नमः जय जगन्नाथ नमो नमः जगतरनाथ नमो नमः
ओम जगन्नाथ नमो नमः श्री जगन्नाथ नमो नमः जय जगन्नाथ नमो।
With this luminous start, we now officially declare the event open and proceed with our planned schedule. I kindly request everyone to stand as we sing the national anthem.
जन गण मन अधिनायक जय हे भारत भाग्य विधाता पंजाब सिंध गुजरात मराठा द्राविड उत्कल बंगा विंध्य हिमाचल यमुना गंगा उज्जल जलधि तरंगा तव शुभ नामे जागे तव शुभ आशीष मागे गाहे तव जय गाथा जन गण मंगलदायक जय हे भारत
May I now request our organizing secretary, Professor Dr. Jyoti Ranjan Parida, to kindly come forward and deliver the welcome address.
Good morning, all. Respected chairpersons, our today's chief guest, Professor Dr. Alkendu Ghosh sir, who is the past president of Indian Rheumatology Association, and he has shaped the rheumatology in West Bengal, the training of rheumatology in West Bengal, I think, has started, and I think the total Eastern India, not only Calcutta, I think total Eastern India, he is the beacon of light, and he has started the this rheumatology forum, I can say. Then we have the respected guest of honor, Dr. S.N. Swain sir, who is the chairman of API Odisha State Branch. Professor Banani Jena, ma'am, she is the president of Odisha Chess Society. She is joining us very shortly. And Dr. Ranjan Gupta, I want everybody to put a big hand of applause for him, because in spite of having viral fever yesterday, he postponed his flight, but he make it a point to get up by 3 o'clock today morning and will join us in the inaugural session. So I think his commitment and everything is something to be lauded for. So coming, first of all, I think I thank all the speakers who have come from such a long distance to discuss a very important interface meeting today. I thank all the delegates here who have taken time to join us, because without their presence, I think this update would not have been possible. So I welcome all of you from Odisha Arthritis Rheumatology Foundation Trust. This trust started 3 years back, and the concept started when one patient, 10-year-old boy of juvenile arthritis, referred to me, was having severe pain. He was in a wheelchair, and there are 7 siblings, and the father was a drunkard who left the family, and the mother was a daily wage worker. She has to take care of 10 children and 7 children, and this guy is having juvenile arthritis. Bilateral hip is severely painful. Patient is not able to sit either. So I thought there is a chance of reversibility, so I arranged 4 vials of etanercept injection, and after 1 month, miracle has happened, and that guy is now going to school, playing cricket, and completely fine. And after that, we found this concept, or we thought of this concept of this trust, and till now, almost 45 to 50 patients we have adopted by this trust, and we are taking care of all their expenses, medical expenses. But going to the next stage, we thought we cannot go beyond a point in sponsoring these kits, but what is more important is to create awareness about rheumatology in our society, and particularly among the healthcare providers. Because what we thought, when we talk of rheumatology, usually we are pertaining that to a particular branch of people. We are discussing always among rheumatologists. But you will see this is a very broad specialty, and cross-specialty discussions is a must, because when you refer somebody to any other department, or any other department refers to you, if you don't have that basic understanding, you cannot form a team. And without interdisciplinary management, these patients cannot improve. So with this concept, in 2022, first we thought of an interface meeting, and something catches our eye, that is, we have taken uveitis and retinal vasculitis as our first interface meeting, and the theme was catching eye in rheumatology. And because initially we are skeptical, because you don't know how to interact with a completely other society and other department and bring them to a same table and discuss things and how things will happen. But that meeting actually has motivated us and given us that confidence that these kind of meetings are actually required, and people are really interested for these kind of meeting. So last year we had done looking through the skin into rheumatology, which is, again, there are around 200 delegates. And then this year we thought we have to now actually go to the vital organs, and I think pulmonary medicine is something that all rheumatologists have to manage, interstitial lung disease patients. And when we approached the Odisha Chess Society, I must thank Professor Manoranjan Das is there, head of the department, respiratory medicine, SCV. He was more than a guide, mentor throughout this preparation of 2 months. I think he has a huge support and role. Professor Dr. Banani Jena, who is their president, Odisha Chess Society. And today I can tell there are around 200 delegates who have already registered, and there are 25 quiz team who are appearing for the quiz competition, and there are 20 papers, out of which 7 have been selected for the oral presentation, and 14 is for the poster presentation. So there is a huge response, and I think this is motivating us to go ahead and ahead. I hope you all will enjoy this meeting. And now, without wasting much time, I invite our guest of honor, Dr. S.N. Swain sir, who is chairman of API Odisha branch, to deliver a short speech.
Dear friends, it gives me an immense pleasure to be here amidst the youngsters that is gradually rising in the conference. Today, I think it is 75% youngsters are here. But previously in all conferences, the elderly people, above 55 to 75 API members were more. They were around 75% of the conference, but today it is 15%. I'm really sorry, because maybe that our physicians, because of lot of rheumatology conferences, CMEs, quiz and everywhere, probably they have been enriched with the knowledge of managing rheumatology cases. But today, Dr. Jyoti Ranjan Parida, a gold medalist, an eminent rheumatologist of India, has started his own institute of Odisha Arthritis and Rheumatology Foundation Trust. Long back, Dr. Pratap Reddy had started Apollo, and now Dr. Jyoti Ranjan Parida started a rheumatology, so the institute in India. In one roof, he has done everything, the diagnosis, the investigations, and the management, everything, and treatment in OPD and IPD basis. So this is a great honor to Odisha that the patients of rheumatology have not to go outside to Sanjay Gandhi. Maybe that when it's difficulty, they will go to Amita. Amita has taken the seat of the professor head of Sanjay Gandhi Memorial, which my friend have occupied 10 years back. Dr. Ramnath Mishra, probably he's not here. And so Amita has come since a long way. And Alakanda Ghosh, one of the giant of Eastern India, all over India also, he has chaired as the chief guest. And so therefore we are honored because I'm on his left side. Anyway, on behalf of API, I congratulate everybody, the young PG students. Most of them come, and some have also late risers, probably they are on the way. And there are so many, because already 200 registration has been done, but only 120 people are here. Another 80 are coming on the way, maybe because of the late night sleep in the youngsters on video calls or messages on the mobiles at late night with their girlfriends. So please, I think if the younger students, postgraduates, interns and everybody, if they will not stop their timing of sleep, because I asked everybody, they are telling I am sleeping at 2 a.m. Arey, what is that? Because I am not getting sleep. My colleagues are always all on move with the messages and all that. So you must sleep at around 10 to 11. Otherwise, after 10 years, everybody will suffer from hypertension, diabetes, and CAD. So after 10 years, so you reduce your timing of sleep and go into the lifestyle measures of diet and exercise, which they are not following. Because at 2 a.m., they are sleeping and getting up at 9, 10, 11. So one day will do the exercise. And everybody's lipid profile is high, and most of the people are going hypertensive and diabetic if they have genetic predisposition is there. So my advice to the youngster, go sleep early, switch off your mobile at 11 maximum. Tell everybody that whatever messages you have to give in the daytime and before 11. so that I can sleep and in after future I will not suffer from the metabolic diseases. So this is a great endeavor of Dr. Parida. He is the most dynamic person, most knowledgeable person, and he has established a remarkable, a momentous hospital where everything is available. And so that conviction, leaving the head of the department of some hospital, he has done this, and this is definitely an enthusiasm, courage, and responsibility, dedication to do something for rheumatology. Therefore, lot of speakers from all over India has come here, gathered, and they will give you a useful speech. So let us listen, not delay. Thank you very much for your gracious presence, the speakers and the other listeners or the delegates. Thank you very much.
Now I request Professor Dr. Manoranjan Das sir to tell us few words from the Odisha Chess Society, because Professor Dr. Banani Jana is, she couldn't join us in time. So please, sir.
Very good morning to everyone. Respected chairpersons, my dear Dr. Jyoti, and my teachers and my colleagues, students. On behalf of Odisha Chess Society, it's really a pleasure for us to be involved with you. The story begins 3 months before when Jyoti given me a call, sir, I want to talk with you. I told Jyoti, I'm Junior Manoranjan, I'm not your sir, I'm your bhai. Because 10 years before, we came to know each other. Okay, bhai, we want to discuss something regarding a conference that we want to involve you. We want to breathe deep into the long rheumatology. Initially, you could not get the point. I told, please give everything to me. Let me discuss with my teachers and students. So, in the same evening, I discussed with Banani madam. He has also approached to Banani madam. Madam told, you go ahead, Manoranjan. We will give our maximum academic support, because they don't any support from, they are such a huge society. So, they don't need any other support. They just wanted that academic support from our side. You tell your students to involve in our society. Let them to present cases, present papers like that. So everything, and after that, I discussed my teachers and my students. Everyone appreciated the concept. Really, Jyoti, we are very much thankful to you for bringing this kind of conference and get together in this forum. So finally, the day started. Every third day, fourth day, we discuss how to do the things. Regarding the pulmonologist part, I told these are our esteemed faculties. Jyoti, you make them involved. He told, sir, definitely I will try to accommodate most of the faculties. Even some outside speakers, he has requested me. I have approached Dr. Talwar, Dr. Rajadhar, Dr. Khushbu Pilania. I have arranged and I have convinced them. They have given their consent to come here. Finally, Jyoti told me, bhai, thank you. I have given you this responsibility. That also being done. So I think with all our efforts, from rheumatologists and pulmonologists, this conference will be a great success. Let's we enjoy this conference. Let we learn. Even any queries, any doubts in near futures, you are now got the platform to interact with many rheumatologists in Odisha and outside Odisha. We can have a discussion. ILD is a very difficult topic. Each day, each case is a learning point. So I request my students to listen and learn something and apply this knowledge for the benefit of the patient. Thank you all.
Thank you, Bhai, for your kind support and kind words. So now I request our chief guest of the occasion, Professor Dr. Alkendu Ghosh sir, to deliver his speech.
Education is the manifestation of perfection already in man. Two important words, perfection, another is already. So how do you define perfection? Perfection is how much you don't know you should know. So I feel for any meeting, conference, crosstalk like this one, should be the objective to identify your unknown component rather than your known component. And that will give you an impetus fearlessly and with pleasure to move forward. And ultimately at the end of the day, you will gain. And after each meeting, I think everybody should audit how much you have identified your unknown component, and so that gives you the fulfillment of so-called academics which we are performing every day. Thank you very much.
Thank you, distinguished speakers, for your support and for sharing your valuable insights today. Ladies and gentlemen, esteemed guests, it's time to unveil a cherished memento, a souvenir that encapsulates our transformative journey. As we lift the veil, let its significance resonate, a token of remembrance, a bridge between the past and present, and a testament to our collective spirit.
So before moving ahead, I think I request Professor Dr. Banani Jana ma'am, please come to the dais.
Thank you so much. May I now request Dr. Ranjan Gupta to kindly address the August gathering.
Good morning to all the respected dignitaries on this dais and off the dais. As the chairperson of the scientific committee, I welcome all the delegates and the speakers to the city of Lord Jagannath and to the third edition of the annual meeting of OARF. As we all know that rheumatic diseases are usually multi-system diseases, and in the last two editions through OARF, we have tried to catch the eye and look through the skin to delve into the rheumatic diseases. Now, during this edition, Dr. Jyoti Ranjan Parida had given me the responsibility to make a program which delves into the crosstalk between the rheumatic diseases and the pulmonology. So we have tried to make a program that would interest people from both the specialties. We have esteemed speakers coming from all over India as well as from abroad. We thank all the speakers who have spared their time to come and grace this meeting for the benefit of all the audience. Coincidentally, we also have the World Joint and Bone Health Day today. So I think there is no other better way to celebrate this day rather than attending a CME on rheumatic diseases. I thank all the speakers and congratulate the team OARF for organizing this successful CME and wish all the delegates that they have a great learning and enriching experience. Thank you very much.
I think this is the end of inaugural function, so now we'll start it. Okay.
Thank you, sir. Thank you so much. So without much ado, we begin with this intriguing journey. May I request our chairpersons, Professor Dr. Anupam De, Head of Department, PG Department of Medicine, AIMS, Bhubaneswar; Professor Dr. Gitanjali Panda, Head of the Department, Respiratory Medicine, PGIMER and Capital Hospital, Bhubaneswar; Dr. Debashish Maikap, Young Dynamic Rheumatologist from KIMS, Bhubaneswar, to kindly grace the dais.
So at the outset, I must congratulate Professor Jyoti Ranjan Parida for putting up this beautiful concept of breathing deep into lung rheumatology. The first speaker is Dr. Avinash Jain. He is DM Clinical Immunology and Rheumatology from SGPGI and currently Assistant Professor at SMS Medical College, Jaipur. He is a has received Young Research Bursary Iraqon 2016 and ICMA Travel Grant 2018, Best Oral Paper Iraqon 2018, National DM Quiz Winner 2016, is a gold medalist in biochemistry and Ratan Tata Scholarship Academic Excellence. And he has many publications and academic invites, more than 30 numbers. So over to Dr. Avinash for his deliberation. He'll be speaking on CTD, ILD, pathogenesis, advancing therapeutic frontiers. Dr. Avinash, please.
Yeah. Thank you, sir, for the kind introduction, and thank you, OARC team, for inviting me here. Some of, mentioned in the morning, some are still happily speaking and some might sleep off now, as we are starting with a little difficult topic, CTD pathogenesis. I'll be focusing on what's new, what's old, and how we can really apply. These are the disclosures. Travel, stay, and hopefully food will be sponsored. And let me tell you, the precise mechanisms we are still trying to understand. So it's still, it's a line that we have still not completely understood is really helpful. And what I feel is, pathogenesis is like marriage, right? Do you really want to understand about marriage? No. The first question should be, do you ever want to understand it? Probably we will never understand, but it's important, right? We won't last if we don't understand each other. If we don't understand pathogenesis, we won't be able to learn or develop new medications. And why that is important is because if you look at the mortality, very high figures, as high as 60% in rapidly progressive interstitial lung disease. So if we don't understand what's going on, we will not be able to save different patients with different connective tissue diseases who have interstitial lung disease. If you look at the mortality, it goes from, I would not say as low as 8%, it is still a very high figure, but as high as 60%. And if you understand the pathogenesis, probably we will also understand the ideal place and timing when to introduce these drugs. What is the right time? Are we over-treating it? Are we under-treating it? This understanding will only come if we understand the disease pathogenesis, correct? And this is how I'll go about in next 12 to 14 minutes, hopefully. The old and the new mechanisms, the various pathways. Then we will delve into key mechanisms, the factors which are driving it, and then we will end with some applied aspects. And these are the heroes. You will hear a lot about genetics, the epithelial cells, the endothelial cells, the innate cells, cytokines, chemokines, signaling pathway. And this also reminds me of a very interesting line from Dark Knight, कि you either die a hero or you live long enough to see yourself become the villain. That's what happens with the epithelial cells when they undergo mesenchymal transition. They start from inflammation to fibrosis. That's what happens with them. And this is before marriage. How clean, tidy the alveoli is looking like, all in harmony with each other. And then let's see what goes wrong. The sequence of events in next 1 minute. So obviously in a genetically predisposed individual, when these environmental factors, they cause an injury, which is actually the starting point, the injury to the epithelium or the endothelium, so-called the vascular hypothesis. The body tries to repair it. Sometimes it manages well, but sometimes this goes unchecked, as a result of which what happens is there is lots of influx of these cells, the macrophages playing a central role, the lymphocytes, the neutrophils, they producing their nets, resulting in inflammation which is called as alveolitis, and once it goes unchecked, it results in activation of the macrophages and ultimately culminating into fibrosis. So if we understand what is happening at each step, we might be able to give them targeted therapies and stop the disease progression, maybe at alveolitis state or thick septum, or if there is a fibrotic state, we have different medications for them. So let's go into the key mechanisms. Environmental factors, this list is, I think, ever expanding, from infections to tobacco to smoke, drugs. All of these have been implicated in CTD-ILD pathogenesis. There are multiple genes which have been implicated, including the MSC loci, the telomere, so-called the immunosenescence, the epigenetic changes. Let's look at them one by one. So looking at the telomere, a lot of papers, including papers on RA-ILD, have now been published, including whole exome sequencing, where they have shown very beautifully a phenomena of genetic anticipation. So these are all proteins or RNAs which are associated with telomere. With subsequent generation, you will see the age at which these patients are presenting is decreasing. That's probably something to do with the telomere. Looking at the TERT gene, the RTEL gene, the PRN gene, these are all associated with telomere lengths. And as a result of, with the subsequent generation, the length of the telomere getting shortened, they are manifesting early. Researchers have also shown that short leukocyte telomere length means there would be a faster decline in lung function, and there will be a shorter duration of transplant-free survival. Even in the Senesis trial, inbuilt trial, they have tried doing a subgroup analysis looking at the telomere length. Though we need dedicated studies to understand that which subset of patients may or may not respond and whether the telomere length has got anything to do with it. There are whole exome sequencing results available in rheumatoid arthritis, where they have shown that genes associated with this telomere are associated with an odds ratio of almost 3.17. A very important gene, I think, which a lot of you might have come across whenever you are trying to turn those pages of pathogenesis, is MUC5B, something to do with mucociliary clearance. Once, if there is a genetic mutation which has been shown in rheumatoid arthritis, this paper was published in 2018 in NEGM, irrespective of ethnicity, if you look at the red line, the odds ratio is quite high. So these subset of patients who had ILD, if you look at the panel C, patients with ILD had higher mutation in this MUC5B promoter region, and then they compared the various subsets, that is UIP without ILD and UIP with other non-UIP ILDs, which means NSIP pattern and the other ILD pattern that we see. They found that this MUC5B promoter variant mutation is associated with interstitial lung disease. I think another important thing, probably this will help us to understand or go deeper into precision medicine. However, they have no role in systemic sclerosis associated ILDs and myositis. And then there is a whole list of number of genes which have been implicated with an odds ratio of 1.38 to as high as 4.69. The HLAs which have been associated in SSC-ILD, similarly RA-ILD, these are the telomere genes that we have talked about, the MUC gene, surfactant protein C, ATP binding cassette 3 transport gene, they all have been implicated in the disease pathogenesis. The concept of epigenetics is coming to all diseases: DNA hypermethylation, hypomethylation, acetylation, deacetylation. So if in an experiment which was done on the lung tissue which was extracted from patients who had ILD, they ran a PCR and they showed that the DNMT3A and DNMT3B expression was higher in patients who had ILD. Now, what this was doing was, it was inhibiting, it was silencing the pulmonary fibrosis suppressor gene and predisposing these individuals to increased risk of ILD. Similarly, histone modification has been looked up. HDAC inhibitors have been tried in animal models, where they have shown that if HDAC inhibitors are given, it restores the fast-mediated apoptosis, it mitigates the bleomycin-induced fibrosis in the animal model, another important pathway. And the non-coding RNAs, some are down-regulated, some are up-regulated. Each of them have their own function, very difficult to remember. For example, this miRNA21, it inhibits SMAD, which is actually an inhibitor of TGF-beta, a complicated loop. If this is upregulated, there will be a lot of TGF-beta. And now there is one trial ongoing looking at miRNA-mediated therapeutic approach to treatment of IPF. Now let's look at these cells individually. TLR2 and 9 are pro-fibrotic among the innate players. TLR3 is anti-fibrotic. TLR4 is like husband. Wife yes bolti hai, to pro-fibrotic, no bolti hai, to anti-fibrotic. And this is how the story unfolds. Once they are genetically predisposed, there is an injury to the endothelial cells and epithelial cells, they start secreting these chemokines, TGF-beta, PDGF. And what evidence do we have? If you do the gene profiling, you will realize that this pathway is getting activated, including increased expression of lysophosphoric acid receptors, which stimulates TGF-beta. And then ultimately it comes down to innate and adaptive immunity, where the neutrophils are getting activated. They will convert the latent TGF-beta into active TGF-beta. The Th1, Th2 cells, gamma delta T cells, which are supposedly anti-fibrotic, they promote inflammation, but they are anti-fibrotic. They will stimulate the M1 macrophages, which have which secrete inflammatory milieu. Then there is a Th17, Th2 and M2 axis. Due to prolonged inflammation, continuous insults, genetic predisposition, there is conversion of this M1 phenotype into M2 phenotype. And the M2 phenotype secretes IL-6, PDGF-beta, TGF-beta, and tissue inhibitors of metalloproteinases, as a result of which there is fibrosis. There is conversion of these circulating fibrocytes, the epithelial cells, and the tissue fibroblast into myofibroblast. Let's not forget the B cells. One of the favorite medications that we use is rituximab. The antibodies there is ongoing evidence of lots of antibodies being implicated. We have a talk on that, which are responsible for this disease pathogenesis. And these are the evidences, right? If there is an epithelial injury, there is increased surfactant proteins being expressed. There is increased KL6. There are markers for alternatively activated macrophage, that is the M2. And there are markers which indicate that there is fibroblast and myofibroblast proliferation. So beautifully, what we have understood is, in a genetically predisposed individual, how these epithelial cells and endothelial cells come into play. They bring in these cells with different cytokines being expressed. And you will see that when we are doing the applied aspect, that some of these cytokines are being targeted to take care of the inflammation in ILD. There are certain differences. For example, the BAF, IL-6 is being more implicated in patients who have SSc-ILD rather than the idiopathic IPF. So I tried throwing this figure to AI, कि उसको कितना समझ में आ रहा है, and let's try synthesizing a figure out of it. And this is what I got, very confusing. So I think a difficult topic, but yes, if we understand each step one by one, we might be able to analyze patients better, and the researchers might be able to understand things better. The talk would be incomplete if I don't touch SSc-ILD. This is, the same thing which I said, but in a very beautifully put up, published in Lancet. Starts with epithelial injury. This is the proof. Once there is epithelial cell injury, they lose their polarity. In presence of fibronectin and fibrin, they become fibrotic. There is vascular injury because of the antibodies which are being targeted against the vascular endothelium, and they release thrombin, which is a pluripotent effect. Again, the TGF-beta, the platelet-derived growth factor, connective tissue-associated growth factor will come, and ultimately there will be proliferation of the fibroblast. And these are the proof. If you do a biopsy, you will find gaps, vacuolization, supporting the vascular injury hypothesis, which was proposed way back in 1970. And these cells will come into play. The M2-Th2 pathway with their own mechanisms by which they are acting. Ultimately, this is the main villain. This is what happens. as a result of the entire cascade which we saw previously, these fibroblasts are resistant to apoptosis. They express less of pro-apoptotic BCL-A2 associated genes, more BCL lymphoma 2 genes, and X-linked inhibitor of apoptosis protein, as a result of which we go into fibrosis. The role of antibodies too have been shown in this paper which was published with 403 patients. If you look at these figures, the survival was worst in those patients who were positive to anti-topoisomerase antibody, who had anti-topoisomerase antibodies. Similarly, the decline was highest seen in those who had anti-topoisomerase in presence of diffuse cutaneous systemic sclerosis as compared to the limited one, highlighting the role of these antibodies. There is cross-linking of antibodies to the angiotensin 2 type 1 receptor and endothelin type A receptor, which stimulates the downstream pathway, ultimately again results in increased collagen synthesis, more fibrosis, and the fibrotic phenotype that we were talking about. And there are papers which talk about these antibodies and their role in pathogenesis of RA-ILD, anti-SCL70, presence of IG, anti-CCP in the sputum, and a long list, anti-fibroblast antibodies, anti-PDGFR antibodies, with their own role. So this is the role of antibodies. Now, just to ensure that everyone is awake, a small question. Can you identify the molecule here? I think there is a prize also. Which one? BLA2. ये तो मैंने भी नहीं पढ़ा. Any other wild guess? The main player, which orchestrates, which everywhere if you see downstream, this is there. Sorry? Correct. Acha, phospholipid is A2. Okay, right, sir, right. Nahi, yes. Right. All right, sir. I heard BLA2. Okay, yeah. Nahi, that's very correctly said. Correct. Exactly. So, sir has very beautifully actually picked up the one of the starting targets, which results in activation of this TGF beta, the canonical and the non-canonical pathway, ultimately resulting in this collagen synthesis, type 1, type 3, inhibition of degradation. Now let's spend some time here, because I'll also try to cover the applied aspect here. So where to start from? So latent TGF gets activated into TGF beta. As sir mentioned, there are various ways by which it can get activated. One of the mechanism is this alpha 5 class integrin. There is a trial ongoing where they are trying to block this pathway. शुरुआत में ही problem solve कर दो. The interesting thing is, this increased expression of alpha 5 integrin has been shown in patients with lung fibrosis, and it is localized. So that way, if you give a pan TGF inhibitor, TGF beta inhibitor, this might be a better choice to inhibit the alpha 5 class integrin. That's what the theory says. So once the TGF beta is activated, the TGF beta receptor 2 and 1 come into play. They will activate the canonical pathway, the non-canonical pathway, and ultimately the downstream there will be formation of extracellular matrix components. There will be more TGF beta because this becomes like a loop. And then we have other cytokines here. The IL-6, which is through JAK1, 2 and TYK2, will in a STAT3 dependent fashion will activate. See, ultimately everything is coming down to this nuclear matrix where all these are getting synthesized. IL-6 is doing it via JAK1, JAK2 and TYK2 in a STAT3 dependent fashion, which we saw here was in a SMAT2 or 3 dependent. People have shown that if you knock out SMAT2 or 3 in the mice, they do not develop fibrosis. Similarly, if you block this LPA, which actually activates TGF beta, you might be able to take care of fibrosis, and so on and so forth. IL-4, IL-13, we saw that Th2, M2 axis. So if you inhibit IL-4 and IL-13 using a drug like romilcumab, you might be able to take care of the downstream pathway. But the biggest challenge is why these drugs still don't work. You know, very easy, let's target TGF beta. Why doesn't it work? Anyone? This is again AI generated. They are also confused, समझ ही नहीं आ रहा है. कभी हाँ बोलते हैं, कभी ना बोलते हैं, कभी सेम सिचुएशन में हाँ बोल देते हैं, कभी सेम सिचुएशन में ना बोल देते हैं. So something similar is happening. Problem is because of the multiple pathways which are getting activated. Canonical pathways, non-canonical pathways. Another beauty about TGF beta is where it is getting expressed. In lymphocytes, when it is getting expressed, it actually might be anti-fibrotic. But once it is expressed in the epithelial cells, endothelial cells, it might be pro-fibrotic. So that's why it becomes challenging to target these molecules. It's not that straightforward. और जैक तो पीछे छोड़ ही नहीं सकते, they are everywhere. So there are trials coming up which, you know, that's why we need to understand, become wiser when and what we should target with. During the inflammatory stage, it will help. During the fibrotic stage, it should theoretically help because all these JAK inhibitors are there downstream of these receptors, the interferon gamma, IL-6, IL-4, 13, TGF beta 1. And again, long list, I think I'll skip this, these chemokines. But picture abhi baki hai. Abhi ek cell aur baki hai. Which one? Which we have not discussed in detail. That's the macrophages. So again, a very interesting paper published recently. You know, they have looked at the role of macrophages, what is happening in dermatomyositis associated ILD, what is happening in MP associated ILD, and what is happening in rheumatoid arthritis associated ILD. Increased resistance results in increased NF-kappa. This is basically a loop. These macrophages are secreting resistin, also secreting these cytokines, and there is increased NF-kappa beta signaling, which results in inflammation and fibrosis. In MP-ILD, it is increased CCL2. In RA-ILD, there are 3 mechanisms, and there are as many as 6 mechanisms which have been described when considering these macrophages and interstitial lung disease. Starting with increased expression of CCL18 to YKL40, ultimately what happens is there is fibroblast proliferation, fibroblast proliferation, fibroblast proliferation. MPO-ILD also something similar, the neutrophils, the MPOs, they cause endothelial damage, and that's why we get in a subset of patients interstitial lung disease. And telomere genes have also been implicated in MPO-ILD. IM-ILD, as we saw, there are certain differences, but we still have not completely understood why a subset of patients are rapidly progressing. But there is definitely higher interferon signature. So just another 2-3 minutes. Now,
Dr.
people are trying.
Requesting you to please wind up.
Yeah.
It's already time.
Yeah. So just 2 minutes or more. So people have again tried differentiating different CTD ILDs, did proteomic analysis, which is probably beyond the scope of the lecturer and the lecture, a long list in different subset of ILDs, and they have identified different proteins. And this I think we have already discussed. These are the drugs, depending on the pathogenesis, what part which are being targeted. Again, endless list. There is a long list, but that means there is more hope. There is a focus on fibrotic pathway as well, as we understood that these molecules, if we target them, particularly when they are in the fibrotic state, it might help. CAR T cells, again this is something new. The engineered T cells against targeting the fibroblast activation protein is probably in the pipeline. CTGF inhibitors are in the pipeline called as pembrolizumab, phase 3, they are still recruiting. And this is the macrophage. What all you can target. Some phase 2, phase 3 trials are already ongoing. So very interesting. So this is how I would like to summarize. In a genetically predisposed individual, these environmental factors come. There is injury, there is inflammation, there is fibrosis. Some stabilize, some regress. However, some progress. Thank you. What we need probably is more genetics and epigenetics. If you have questions, I have 2. What is this? Dasatinib with quercetin.
Thank you, Dr. Avinash.
Yeah, thank you.
For a very nice presentation of such an important, basic, and at the same time complicated topic. Now the topic is open for discussion.
So those who have understood, they can attend this TGF beta conference I came across. मैंने कहा इसका भी अलग से conference हो रहा है. This is very interesting. Yes, sir. Yes, sir.
It is a helpful in this position, or it is a harmful in?
So a very good question. That's why, sir, targeting TGF beta has not been easy, because initially it is helpful, When it is expressed by the lymphocytes, what it is trying is, whatever injury and inflammation it is occurring, it is trying to close it down. But in patients who are genetically predisposed, this does not stop here. TGF beta overexpress होने लगता है.
I think,
Yeah.
TGF beta, if you are giving with interleukin 17, it will increase the T17.
Yes.
So it is for acute inflammation, it is better for attracting neutrophils.
Correct.
And if you IL-10 and TGF beta you are giving, you are promoting M2 macrophage 2 as well as T-reg cells. So it is beneficial for chronic inflammation. If you target the TGF beta, it will reduce the chronic inflammation. It may be necessary because acute infection only to recent bacteria and virus, all this.
Correct.
So it will, if you will target improve the TGF beta, that will help you in reducing the acute infection by process,
Correct.
that acute infection by taking neutrophil to that sites, and it will prevent also macrophages because interleukin
Polarization.
is macrophages, it will reduce the macrophages. TGF beta also reduce the macrophages. So chronic inflammation will reduce. So targeting TGF beta is a better sense of treating ILD because it will reduce few chronic inflammation.
Yeah.
As well as it will increase the acute inflammation.
Correct.
So it is as a dual role. So this should be first. And second, IL-10 should be targeted. Because the IL-10, if you increase the number, it will decrease the macrophage activities and reduce the macrophages in that, which is the most dangerous part in this chronic inflammations. Actually, all roles are taken by macrophages. Initially and last,
Yeah,
till
last.
to the last. So these two, if we increase the level of tissue growth factor, transforming growth factor beta, and IL-10 increase, and they will take in good ways because it will T-reg cell will increase, macrophage will down-regulated, and acute infection will be also treated by improving neutrophil to take the sides, and macrophages will be reduced. So it will be better. I think it should be better.
Could be a potential target. The only problem is the redundancy in the pathways. The other pathways getting activated.
Since we have crossed the time, we should close this session.
Okay.
Thank you.
May I request our Honorable Chairpersons and Speaker to please move towards the Felicitation Center. For the next talk, may I request Professor Dr. Prasant Pradhan, Professor Rheumatology KIMS, and Dr. Samir Sahu, Senior Consultant, Critical Care and Pulmonary Medicine, Manipal Hospital, Bhubaneswar, to please kindly grace the dais as chairpersons.
It's my pleasure to invite Dr. Padmanabh Sinha for the next talk. I think this talk has been preponed, and I know Sinha for a very long time, and very nice to see you again.
Yeah.
And I know him when he was doing his post-graduation in medicine in JIPMER, and his enthusiasm for the subject has grown since then, and he had many awards and other things, but I would highlight that you are the first one to give a plenary session in this ACR Congress. So that is probably the best achievement, and over to you, Sinha.
Thank you. Good morning, and at the outset let me thank Jyoti and the entire team for inviting me. And straight away, going to the topic, how can we improve the outcomes in scleroderma interstitial lung disease? Slide is not changing. Okay, fine. This is working. So, in this case, a 30-year-old lady who is symptomatic for 4 years with a dry cough, and she had breathlessness of functional class 2. Her FVC is 56%. HRCT shows mild ground glassing. So, you will say she has a mild interstitial lung disease. and the diagnosis is not in doubt. Her anti-SCL70 is positive. Her face tells you that she has scleroderma, so she has scleroderma with interstitial lung disease. So if I ask you, how severe is this disease and how severe is the mortality, especially for the pulmonologist who see this interstitial lung disease, where will you put her mortality? Among the cancers, I have put the things which are very bad cancers. The problem is, we never realized that this lady is going to have a bad prognosis, even bad prognosis that a colonic cancer or Hodgkin's lymphoma. We never realized that when she walks into our room. The 5-year mortality is something around 30 to 40%. And this is from a large data set, and scleroderma interstitial lung disease has the highest mortality among all the CTDs you take. SMR of 5 to 7 for scleroderma, standardized mortality rate. When lupus nephritis, when we think this lupus nephritis is very severe, the mortality is around 2.2. So this kills, and we have to realize very, very clearly that we are dealing with a disease which has higher mortality than many of the cancers. And why scleroderma people die? It has been very clear. It's the lung and the heart which kills these people. Either it's interstitial lung disease or pulmonary hypertension. So we need to see that. And what predicts mortality? Again, very clear data. FVC less than 80% is one of the key drivers. Tells you that the patient is likely to die. And so this brings us to the point that evaluation of lung is one of the most critical elements in the treatment of scleroderma and improving the mortality of scleroderma patients. Lung and heart, but today we will focus on lung. So first thing, don't rely on symptoms. They are totally unreliable because patients are debilitated, they are not walking fast, they will never come and tell you that I am feeling breathless until the FVC is very, very low. That time you must have lost the game. So what we do? We do pulmonary function test, right? That is the first thing what we do. So if this is a paper which was published in Arthritis and Rheumatism, 2015, what it showed, one very simple study. They took 100 patients with scleroderma, 60, and did CT for everyone. And 64 of them had interstitial lung disease on HRCT. Only 24 had FVC less than 70%. So majority did have a normal FVC. Despite having normal FVC, they had a interstitial lung disease on CT. So a lot of people will say, okay, mild ILD, we are missing. What is the problem? Let's miss the mild ILD. We can keep doing the FVC at a later date and pick up when the ILD is significant. The problem was that, look at the sensitivity. Sensitivity of FVC less than 80 is around 37%. So 70% it is missing. 60-65% is missing. Even if you take multiple cutoff, the burst sensitivity is around 60%. So it is not as sensitive at all. But again, I told you, mild ILD we are afford to miss. The problem was, out of 5 out of the 40 patients with normal FVC, some of them had a severe interstitial lung disease. So it is not that FVC less than 70% cutoff, we are missing only mild interstitial lung disease. No, we are missing even severe cases. So PFT should not be used to screen for interstitial lung disease. PFT is not a good tool, especially for the initial screening in high-risk patients. I will come what is high risk. HRCT, very sensitive and specific, is a must in every CTD patient whom we at high risk of interstitial lung disease like scleroderma, very sensitive, very specific. I am not going to details of this because people are going to talk about it, how to differentiate NSIP and UIP. Only thing is that it will help us to do two things. One, extent of interstitial lung disease. It will give you 10%, 20%, 30% involvement. And second thing, it will tell you what is whether it's NSIP or UIP, or sometimes it can really throw in surprises like COP or other stuff also which is associated with scleroderma. So another very, very important thing, so we have diagnosed, we understood that scleroderma interstitial lung disease is deadly. We know how to diagnose them. How do you diagnose? Doing a CT is a must in most of the patients. Second thing, very, very important to understand that not every scleroderma interstitial lung disease progress. We need to stratify them. Why should we treat? Why should we stratify? Because we need to treat those who progress. But the problem is that waiting for progression means the lung will destroy. So what should you do? We should identify those who are likely to progress. That is the key. We should identify scleroderma interstitial lung disease patients who are likely to progress. So treat those who progress. That's what I do. What is progression? This is a very, very important slide again. This is called composite categorical decline. That is, you do a PFT on a serial way. You do PFT today, and if you do PFT after 1 year, if the FVC dips more than 10%, what is 10%? That is extremely critical again. If somebody has FVC of 70, what is the 10% decline? 7%. So if the FVC becomes 63, that is composite categorical decline, or you have a dip of FVC to 5 to 9% and DLCO dip by 15%. So if there is a dip, what you have to understand, the 10-year mortality you see, it's around 70%. It's a huge mortality, 10-year mortality of 70%. So what is progression? 10% dip in FVC over 1 year. But waiting for progression is allowing to destroy. So we need to predict. How do you predict? One is we will look at the pattern. Does the pattern really help? NSIP and UIP, there is a lot of data suggesting that in CTD ILD, be it NSIP, be a UIP, there is not much difference. Only thing is that in UIP, the antifibrotic may be slightly more efficacious. This is just a theoretical proposition. There is no evidence to suggest this. One very, very clear data, this is a very old paper from Virginia Steen's group published in 1990s, very clearly showing that lung volume loss is maximum during the initial years. 0 to 2 years, the initial years, the lung volume loses. Maximum 6.5 to 7%. So identify them early. Other way, if the patient is present in 1 to 2 years, there is ILD, the chance of progression is high, treat them aggressively during those years. Second thing, antibodies. Again, the scleroderma classification is going to change, may change. We are going to diagnose based on antibodies. What is the antibody which is significant? Anti-SCL70. If somebody has anti-SCL70 positivity, chance of progression of interstitial lung disease is very, very high. And if it's anti-centromere positivity, the chance of ILD progression is very, very low. Gone are the days when we talk about diffuse and limited. Sometimes in our own registry, Vinitha Madam will agree, a lot of limited patients have SCL70 positivity. It is not the type of scleroderma which is important, it is the antibody which is important. So anti-topoisomerase or anti-SCL70, they have high risk of progression. Anti-centromere has low risk of progression. Third, so we can identify those at risk of progression. One, early disease. SCL70 positivity, baseline presentation of FVC less than 70%, or CT showing more than 20% lung involvement. These are high risk of progression. Other factors, age, very, very important. If somebody is young, we will treat it very aggressively because they have a long life to go. If somebody has FVC 55% at 15 years of disease, they have lived for 15 years, FVC is still 55%. The other person, within 2 years, the FVC is 55%. Which one will you treat aggressively? Those who are early disease. If somebody has a CKD, I am sure that if FVC is 70, the patient has CKD, I won't aggressively immunosuppress because his lifespan, we understand that is not very long. Lung volume at presentation, if somebody has a FVC of 25%, I will be very, very hesitant to treat because they may develop infection for following immunosuppression and they may die. So we have to be very cautious whom we are treating, and there is no hard and fast rule. And looking at all these factors, you take a decision whom to immunosuppress aggressively. And again, type of ILD does not really matter in these patients. So there has been a huge jump from 2010 to 2024. When we were doing DM in 2010 and all, when I started my practice, there were not many options available, only steroids and cyclophosphamide. Now there are plenty of items. 2024, we have steroids, cyclophosphamide, mycophenolate, tocilizumab, rituximab, tofacitinib, nintedanib, and what more. We are part of 3 clinical trials, and there are a lot of molecules in pipeline which are going to come in the treatment, which hopefully will be successful in the treatment of scleroderma. These are the 2 most important drugs. One is mycophenolate on one side and cyclophosphamide on the other side. This is our own paper which we published in 2016. Ours was a retrospective study, and other was a SLS2 landmark study from US, SLS2 study randomized control trial. Mycophenolate versus cyclophosphamide. Very clear data showing both cyclophosphamide and mycophenolate are equally effective in improving the lung volume. Again, I want to stress improving lung volume. It is not the stabilization, improves. You can see 5 to 7% improvement in both the studies. Look at the charts. So, scleroderma interstitial lung disease, if you treat them well with immunosuppression, your lung functions improve to 5 to 7%, especially in those who have early disease. So, either is fine, mycophenolate 2 to 3 grams or cyclophosphamide monthly infusion. Both are equally effective in treatment of scleroderma interstitial lung disease. Only thing is that mycophenolate is slightly better tolerated because of less cytopenias and other long-term side effects associated with cyclophosphamide. So mycophenolate is slightly better tolerated when compared to cyclophosphamide. And always remember, mycophenolate has to be given at empty stomach, otherwise it won't get absorbed. And third thing, never forget, don't give mycophenolate along with acid suppressants like proton pump inhibitors. They decrease the bioavailability of mycophenolate to less than 50%. So if you combine mycophenolate with omeprazole, pantoprazole, your effect is going to be just half. And so mycophenolate and cyclophosphamide is very good. Around 70% of the patients respond to them. What do you do if somebody is not responding? One is switch. Switch means you switch from mycophenolate to cyclophosphamide, or you switch from mycophenolate to rituximab, or add rituximab. And last but not the least, hematopoietic stem cell transplantation in our country also now it is being done, although in a limited numbers. So what about rituximab? What is the rituximab data? This is from Indian data again showing rituximab vis-a-vis cyclophosphamide in scleroderma interstitial aneurism, Calcutta. Alakindu sir is here. So FVC levels, you can see here at the baseline group, baseline FVC is around 60%. So they have taken a high risk group which is likely to progress. And what very clear data shows that rituximab improves FVC while cyclophosphamide stabilizes it. So this study shows that rituximab is slightly superior to vis-a-vis cyclophosphamide in treatment of scleroderma ILD. Then this is a recently published recital study from UK which included not only scleroderma interstitial lung disease, they have taken patients with inflammatory myositis and everything else. So what they could show was that both group, rituximab group and cyclophosphamide group, both groups showed improvement in FVC. So, and it was more or less similar. But again, same thing, it is improvement, not stabilization, was achieved in this recital study also. So rituximab is equal to cyclophosphamide. What did they say? Mycophenolate is equivalent to cyclophosphamide, and now rituximab is also equivalent to cyclophosphamide. So all these drugs, as a first-line drugs, all of them act almost in a similar way. Now tocilizumab is interleukin-6 blockade, and this is the landmark focus study where they compared tocilizumab vis-a-vis placebo. As you can see, the red line is the tocilizumab and the blue line is the placebo. Very clear. Tocilizumab stabilizes FVC, while in the placebo arm there is dip in FVC. So tocilizumab is in this is early scleroderma data. Within 1 year, 2 years they have taken this patient. So tocilizumab prevents the loss of lung volume and stabilizes lung volume. And this is the long-term extension. What you want to see here is the moment the open label extension starts, see the blue line on the below. The FVC was dipping. Then what happened? The moment you start on tocilizumab, the line became flat. Or again proving the point that tocilizumab stabilizes lung function in early scleroderma. Tocilizumab, in my practice, I use it very less because of the cost. And second thing is, most of the time patients do well on mycophenolate and cyclophosphamide or rituximab. So I use very less, but tocilizumab is a very good drug, especially in early disease when you have very high CRP, associated arthritis, or a lot of skin itching and inflammatory features. Coming to stem cell transplantation, the SCOT trial, where they have taken, this is a New England Journal publication which was published 5 or 6 years back, a landmark publication from US again. They have taken severe scleroderma, half of them they did stem cell transplantation, other half they gave cyclophosphamide. You can very clearly see what happened here. Cyclophosphamide arm did much worse when compared to hematopoietic stem cell transplantation in terms of FVC, in terms of survival. This is a hard data, death data, very clear showing that transplantation is way better. So is this the end of immunosuppression? I wrote this with Amita ma'am, which got it's a correspondence. We told that this is not an end of immunosuppression in scleroderma, but no maintenance given in cyclo arm. What we should understand that in the cyclophosphamide arm, after 1 year, the patients were not given any maintenance therapy. That is the reason. And if you see here very clearly, you can see here the difference started after 4.5 years. So they gave cyclophosphamide initially and just observed them. Most of them were not given any follow-up immunosuppression. And so we need better studies comparing long-term immunosuppression vis-a-vis stem cell transplantation. I am sure there may be minor difference, but immunosuppression has definitely a role in these patients. Nintedanib, the antifibrotic, there is going to be a debate now after a couple of talks. So this is one of the landmark trial where they studied scleroderma, 576 scleroderma ILD patients, nintedanib versus placebo. And we can see here those where placebo had lost much more lung volume when compared to nintedanib. But what is more interesting to me was immunosuppression versus MMF with nintedanib versus no MMF for nintedanib. Neither MMF nor nintedanib. If you see here, because of the subgroup analysis, you can see here, if the patient was on mycophenolate and nintedanib, they lost only 40 ml of lung volume. But those were neither on mycophenolate nor on nintedanib, they lost around 120 ml. So it is around 80%. And you can see here, 5% of FVC was lost in 1 year. So it's a huge amount of lung volume. This was the rituximab versus this was almost a recent study which was published, ever ILD study. What they did study? They compared mycophenolate versus rituximab plus mycophenolate. So what is the data again showing? Rituximab plus mycophenolate is more effective when compared to mycophenolate alone. So the combination therapy, that's what we have been practicing in our day-to-day life, that combining rituximab plus mycophenolate is very, very effective in these patients. And this is our own small study or retrospective study showing that long-term maintenance prevents mortality. Jyoti has been always signaling me that I have to wind up, so I'm just not going to details of this. Long-term maintenance is a must, at least for 5 to 6 years, or most of the time lifelong, has to be given, whichever way you give. So I have told you the broad outline, what are the drugs available, how to diagnose. So how do you manage these patients in real life? First and foremost is regular pulmonary function test from a reliable lab and get an optimal outcome. So what is the target? Target is stabilization. So what is if you know what is progression, then only you can stabilize them. What is progression? FVC more than 10% dip. If somebody comes to with 50% FVC initially, if the next time after 1 year is 45%, the patient is progressing. That we have to be very, very clear. Or progression by HRCT, or worsening of their 6-minute walk distance. Keep doing this religiously, at least pulmonary function test every 6 monthly, and CT whenever is required. So you give the first choice. What I give in my practice is mycophenolate bar rituximab, looking at the safety profile. If the patient is not affording, I give cyclophosphamide. But most of the time, mycophenolate is my first choice. And if the patient stabilizes, we go for maintenance. If the patient is progressing, either you can switch from mycophenolate to rituximab or add mycophenolate to rituximab, depending on how much convinced you are and how much fast the patient is progressing. Or another option is adding an antifibrotic. I don't add antifibrotic initially because of the cost and the tolerance issues. And most of the patients, as I told you, 70% of them do only with immunosuppression. Regarding maintenance, after the maintenance, what happens? We will slowly try to taper off. Sometimes what happens, the patient progresses, then you may have to switch back to the original therapy. So what the basic is, these are the 3 or 4 drugs available. You do a pulmonary function test very regularly, watch for progression and aim for stabilization, and switch the therapy within 6 months or 8 months when the patient is progressing. That is critical. It is not that mycophenolate de diya, then you take mycophenolate for lifelong and you are stabilized. No, some patients, 30% of the patients will fail on mycophenolate or whatever drug you give. So how to improve the outcome? First thing, realize in your brain that scleroderma interstitial lung disease is a killer disease. It is worse than CA breast or CA colon. Please drill into your brain. Most of us keep forgetting this. Identify interstitial lung disease at the baseline. HRCT at baseline has to be a must in most of the patient, high-risk patients, especially CL70 positive patients, or whenever FVC dips in follow-ups. Which have very good drugs, effective in 90% of the patients. The problem is avoid underdosing. That is mycophenolate 1 gram, people give 1 gram of mycophenolate. That is not effective. Cyclophosphamide 500 milligram intravenous dose, not effective. No targets we set. We don't set targets. And we need to set one. What is it? Stabilization of FVC. And if there is progression of interstitial lung disease, that is FVC less than 10% dip, you change immunosuppression or add antifibrotics. There are multiple tools you can add based on this. And treat to target. That's the most important. If you could get this, and my job is done. Stabilize FVC, preserve lung, and prevent mortality. And the good outcome depends on optimal investigations, optimizing treatment, and optimal monitoring. If you have these 3, definitely your survival rates are going to be much higher. We recently analyzed in IPSSR cohort, our 4-5 year mortality is around 10%. It's not very high. So in our center itself, it is 7 to 8% over 5-6 year mortality, which is reasonably good in terms of scleroderma. So it is achievable. Only thing is we have to be really dedicated monitoring these patients. And this is the team which my team in Kochi. Thank you for patient listening.
Thank you, Dr. Sinai. Any questions? Quick questions? Mike.
Sir, I wanted to ask, in patient of systemic sclerosis with ILD, if we start on MMF or Ritux, if we follow the patient and if we see there is progression, definite progression, on CT as well as the FVC is declining, what is your choice then? Or if the patient is deteriorating on MMF, what will you do next?
If the deterioration is rapid, add rituximab. That is the current evidence says, or add rituximab plus nintedanib. Depending on how much fibrosis is there, how much NSIP pattern is, the patient has a downglassing or fibrosis, I would give rituximab and add nintedanib if the progression is really fast.
Okay.
And if that is still working, I think in the current scenario, hematopoietic stem cell transplant is one option if the patient is in early stage of disease.
Thank you, sir.
Question from my side.
Yes, ma'am.
Go ahead. Please.
पूछ लीजिए सर, then he'll.
Sir, Thank you for the lecture, sir. Sir, what is the dose of oral glucocorticoids you prefer in patient of SSC-ILD symptomatic HRCT showing GGOs?
Usually scleroderma intestinal role of steroid is minimal. Even if you want to give less than 10 milligram, don't give higher dose. And most of the time I give scleroderma ILD steroids for arthritis, they have arthritis or severe skin itching and inflammatory for the skin. I usually don't give steroids, but Vinita madam is a strong advocate of low dose glucocorticoids. So you can give steroids, but at a lower dose. I usually don't give higher dose because what I think is scleroderma is a marathon, it's no 100-meter race. So you have to go long. But what we can do initially, whether how much it can really translate to long-term outcome, I am not very sure. So I don't give high dose of steroid, but there is a difference of opinion. People give, some of them give steroids. I usually restrict my steroid dose to less than 10 milligram. I don't give higher dose. And try to taper it off in 2 to 3 months.
Thank you, sir.
Yeah. My question is, when did you start antifibrotic? Do you look at the CT for fibrosis or you start at NSAID also?
Sir, that's a very good question. When do you start antifibrotics? The problem with scleroderma interstitial lung disease is the pill load is very high. Most of the time they will be on vasodilators, they will be on mycophenolate, then you add nintedanib. The problem with adding mycophenolate and nintedanib is a lot of them don't tolerate GI because scleroderma itself has a lot of GI issues. So I don't start nintedanib up front, although the evidence says that mycophenolate plus nintedanib is better than mycophenolate alone. There is a flimsy evidence. I can't say that it's a hard evidence, but there is evidence suggesting this. So what I do is I give mycophenolate. If the patient is progressing and there is lot of fibrosis in the CT, I add nintedanib. Or even if there is no fibrosis, still I add nintedanib if the patient is progressing. But there can be other ways also. You can give upfront also. There's evidence says that. But the problem is nintedanib. A lot of people develop very deranged liver function test, diarrheas, and GI upsets, and the patient may completely default.
Okay.
Thank you, sir.
Thank you. Thank you, Dr. Chana.
Thank you.
Thank you so much, sir. My request our esteemed chairpersons and speaker to please move towards the felicitation arena. For the next talk, may I request Dr. Bikash Agarwal, ex-HOD Department of Radiodiagnosis, Apollo Hospital, now the Director and Head of Genex Diagnostics, and Dr. Satish Pradhan, Director, Railway Hospital, Bhubaneswar, to kindly chair the session.
Good morning, everyone. The next topic is imaging, basically imaging in ILD, interstitial lung disease, which is probably we have not heard to Dr. Sena. He has told that for diagnosis of ILD, this is the cornerstone, imaging is the cornerstone of the investigation. So now to give this lecture, I will invite Dr. Khushbu Pilania. Dr. Khushbu Pilania. He is a member of Indian Radiological and Imaging Association, Society of Chest and Imaging Intervention, Joint ILD Guideline Committee, Musculoskeletal Society of India. He has a lot of publications to her credit, and his special interest in chest radiology, musculoskeletal radiology, MRI. I welcome you, madam, to give your lecture.
Good morning, everyone. Thank you, sir, for that kind introduction. And at the outset, I would like to thank the Odisha Rheumatology Committee, Dr. Jyoti Ranjan and Dr. Manoranjan, for having me here. What I'll be talking over the next 20 minutes is CTD-ILD, or as we start calling it nowadays, the SARD-ILD. We've already had an understanding of why it is important to do a CT scan. And so we'll be trying to address the various questions that come to your mind as. So I would begin with understanding a few questions that come to your mind when you see a CT scan? So this is the CT scan which is presented to you, and obviously as a rheumatologist or as a chest physician or even as a radiologist, a lot of questions come to our mind. The few questions which we will be addressing in today's agenda is, number one, when we look at a CT scan in a patient with my volume is low actually. I'm sorry for that bad throat and voice. But is it better now? Okay. So the few questions that come to our mind when we look at a CT scan is, especially in a patient with rheumatic disease, is there an ILD? That's the first question. Is it an ILD or is it something else that we are looking at? Now, if yes, there is an ILD, is it a SARD ILD? Is it cellular versus fibrotic? And then what is the pattern? So this will be the agenda. We'll try and address these questions by the end of this talk. Before we go ahead, before we try to discuss more on how to read an HRCT, the one thing which is must is to get your scans right. So a half-heartedly done scan will serve no purpose. It's better to repeat it, get it done again, because we've realized how important it is to diagnose an ILD, then to also characterize the ILD, to give answers like whether there's fibrosis or not. So how do you do that? There is an ideal HRCT protocol which encompasses the need of a full volume inspiratory scan from top to bottom, followed by a complete volume expiratory scan, again top to bottom. So these two are a mandate must, followed by a prone scan, which should ideally be done in every patient who is being scanned for ILD for the first time. Especially important is in rheumatic diseases, because we are currently looking at an era where we are trying to diagnose the ILD before it manifests clinically. So in these cases, there are very subtle opacities towards the bases, which are often passed off as gravity-dependent opacities. And believe me, prone scans are an eye-opener. You diagnose these ILD much before they have destroyed the lungs. The documentation should always be on a cloud share or a CD or a USB. The important reason is because when you start reading the films, at the most you will get 15-20 images on a film on which you'll be trying to make your diagnosis, wherein in effect we are taking up to 1,000 images of the patient, which it's not possible to give across in the films. So always insist for the data on a DICOM set, whereby your confidence of diagnosis will increase much. So going ahead with SARD ILD, we say SARD ILD is evidence of ILD demonstrated on CT scan, that is a combination of reticulation, ground glass, traction bronchiectasis, honeycombing or cyst in the setting of an established CTD or a SARD. So that is very simple. If a patient is a known case of rheumatic disease, has some CTD features, then we call it a CTD ILD. So irrespective of the type of ILD, it's a SARD ILD unless histopathologically proven otherwise. Now what is the role of CT scan in that case? So number one, to confirm that it's an ILD that we are talking about. Then to say whether it's a fibrosing ILD or not, then to prognosticate it. Then apart from that, HRCT also has a role as in predicting ILD as a precursor of CTD. So how do we do that? There are certain patterns on CT scan which strongly point to an underlying ILD. These patients may not have a manifest CTD clinically as yet. So these are a few patterns which we will be discussing as we go ahead. Amongst them, the most common is NSIP, or the non-specific interstitial pneumonia. This pattern is most commonly seen with connective tissue disease ILD, and at the same time, if you see this pattern, you should be going back and looking for CTD features as well. It's one of the most common pattern of lung involvement in scleroderma ILD, which we've heard some time back. And a very important point is idiopathic NSIP is very rare. So if you're seeing an NSIP pattern, the patient might not have an autoimmune disease as of now as a manifest, but will definitely go on to have something in the future. This is a typical NSIP picture. So what do I see here? I see predominant ground glass opacities. So these are all ground glass, and you go down and you realize the ground glass becomes much more evident. How do you say that this is ground glass? Because you look at the attenuation of the air in the trachea, and despite being a good inspiratory film, the entire lungs are looking more gray. So this is all ground glass, confirmed when you go down and you realize the increase in the density. then the disease has a basal predominance. It's a very homogeneous disease, and that's why this can be overlooked as a normal lung. So we need to understand that it is so homogeneous that often you can be taken away by that homogeneity. There is subpleural sparing. You see this very characteristic subpleural sparing where the fibrosis or these reticulations fall short of the pleural space. There is very minimal reticulation and usually very less honeycombing. So this is a very typical NSIP picture, and you see this dilated esophagus. This is a cellular or a predominantly non-fibrotic NSIP ILD. Then what is a fibrotic NSIP ILD? Where you see much more reticulations all over the lung, again with a subpleural sparing, and you see the disease has a lower zone predilection and very homogeneous appearing disease. So this is how a fibrotic NSIP looks like. So now let's talk about how to differentiate fibrosis from non-fibrosis. Honeycombing is one of the keystones in ILD. When you see honeycombing, you know it is ILD. When you see honeycombing, you know it is a fibrotic ILD. So what is honeycombing? Honeycombing is very typical cluster of cystic air spaces. So you see these cystic air spaces. They can be a single or multiple layers, subpleural in distribution. They share walls with each other, and there is associated architectural distortion. So when all these 5 criteria are met, it is honeycombing. If any of these is not met, please question yourself once again whether you are actually dealing with honeycombing, or is it bronchiectasis, or is it simple emphysema, or is it a cystic lung disease. So those questions need to be asked, and once you ask yourselves, you will definitely find your answer. Apart from honeycombing being a sign of fibrosis, the other signs are traction bronchiectasis. So you see bronchiectasis in an area of fibrosis and towards the periphery. Then it's a traction bronchiectasis related to the interstitial lung disease. Or you have these lines, irregular lines all over the lungs. So these are another feature of fibrosis. So if in an ILD you see any of these features, you know that the ILD has already progressed to a fibrosing interstitial lung disease. So this was the fibrosing ILD. When do we call it a cellular or a non-fibrosing ILD? When you have ground glass. So predominantly ground glass or maybe nodules, which you see in setting of HP and sarcoidosis. When you see a lot of ground glass, you know it's a non-fibrosing ILD. At this point, when we've been discussing the poor prognosis of scleroderma ILD, one of the big reasons is that in scleroderma ILD, the GGO also points to fibrosis. So it's very difficult to differentiate whether the GGO we are looking at is just an inflammatory disease versus a fibrotic disease, especially in context of scleroderma ILD. Then once we have the understanding of whether it's a fibrosing versus a non-fibrosing ILD, we need to see how is the pattern of distribution. So the disease, the ILD, on the axial scans distributes itself in 2 manners. Either it will be a peripheral disease. So when you draw a circle in the center, you see all the disease on the outer side of it. Then it becomes a peripheral disease. The peripheral disease, when it reaches up to the pleura, it becomes peripheral with subpleural involvement. The peripheral disease, so you draw a circle and you see the disease is still towards the periphery. The center is spared, the disease is peripheral, but it is falling short of the pleura. So it's a peripheral disease with subpleural sparing versus a disease which is diffuse central peribronchovascular. So these are the 3 important axial patterns. Apart from that, the zonal distribution for an ILD is important. So it's an upper zone disease versus a lower zone disease. Very beautifully and easily picked up with the MPRs wherein you do your sagittal recons, and these things become evident on a single image. When you're looking at the axial images, you need to put all of them together and you see very clearly that the disease has an upper zone predilection. Now the question is, what is the need of this exercise? The need is to be able to identify the pattern. So we've already discussed that if I'm able to identify a pattern, even if the patient is not a case of autoimmune disease, and I see a NSIP pattern, I will raise a strong suspicion of there being a SARD ILD. But what if I see a UIP pattern? Do I rule out SARD ILD? Then what is UIP pattern? And does UIP does not exist in the world of CTDs? So we will address these questions going ahead. First, we talk about what is a typical UIP pattern. This is a typical UIP pattern wherein you see a disease with subpleural or basal predominance. It's a very heterogeneous disease. It is reticular predominant disease. So lines are all that you see in the lungs. There is honeycombing and there is absence of anything else as a predominant pattern. So that's a very important thing. If there is anything, if there is ground glass, there are cysts, there are consolidations, there are nodules, then it does not fit into the typical UIP pattern. The other pattern is the probable UIP, wherein everything remains the same except the fact that there is no honeycombing, but there is traction bronchiectasis. So when you see not honeycombing, but traction bronchiectasis, and still everything else falls into place, then you call it a probable UIP pattern. Both of these patterns fit into the UIP pattern. The question is, does it not exist in the world of CTD? If we see a UIP pattern, do we completely rule out an underlying CTD? Obviously not. There are certain specific features in a patient with UIP pattern that should strongly raise a suspicion of CTD, similar to the index of suspicion we raise in case of NSIP. These are the three important signs. How do we see them? So the anterior upper lobe sign means that despite the disease having a very typical UIP pattern, lower zone predilection and all, this anterior portion of the upper lobe is significantly involved. So either your sagittal recons or scrolling from top to down and seeing this anterior upper lobe involvement should raise your antennas for there being some underlying CTD. Exuberant honeycombing. So such an exuberant honeycombing you never see in a UIP IPF. When you see such extensive honeycombing, please think of some underlying CTD ILD. The straight edge sign, you do your coronal reconstructions and you see that there's a sharp demarcation from normal to abnormal lung without a normal gradation that you see in patients with UIP IPF. Then again, keep your index of suspicion for an underlying CTD high. Apart from that, there are certain patterns which are again more commonly seen with CTD ILD. So this NSIP OP overlap, when you see an NSIP pattern but with patchy areas of consolidation as well, we start calling it an NSIP OP overlap, very commonly seen with inflammatory myopathies, and you also see an associated significant involvement of the muscles in this patient with overlap polymyositis, which you can pick up with the MRIs with myositis protocol. Another common ILD that you see in the context of autoimmune diseases, the lymphocytic interstitial pneumonia, wherein you see these cysts, these cystic spaces. These are not honeycomb because these are well-defined discrete cysts, not sharing walls, not subpleural. These are discrete cysts within areas of ground glass attenuation, a very typical pattern that we see with lymphocytic interstitial pneumonia, most commonly seen with Sjogren's disease or in some immunocompromised status. This patient had obvious salivary gland involvement also picked up on the MRI. So when we talk about these SARD ILDs, there are certain patterns which are commonly associated. So there is no rule, but these are commonly associated, wherein rheumatoid arthritis has a UIP pattern, systemic sclerosis has an NSIP pattern, myopathies have an NSIP OP overlap, and Sjogren's syndrome has an LIP pattern. So I think we'll, before winding up, let's just see if we've understood what we are looking at till now. So is this a fibrosing or a non-fibrosing ILD? Fibrosing ILD, very nice. Is it a typical UIP, probable UIP, NSIP with fibrosis, or lymphocytic interstitial pneumonia? It is NSIP. How many for NSIP? Okay. How many for anything else? Is it typical UIP? Typical UIP, all right. So it is a typical UIP pattern. Now, is it idiopathic pulmonary fibrosis? Is it chronic hypersensitivity pneumonitis? Is it end-stage sarcoidosis, or is it SARD ILD? So the work is done. I think I'm happy enough. We've talked about how to pick up that there's an ILD when it is a CTD ILD. So either it is NSIP or UIP with certain features, or you have an NSIP with OP overlap, or you have a lymphocytic interstitial pneumonia. In these four cases, we should think of a CTD ILD. How to differentiate fibrotic from non-fibrotic, and if we can differentiate the pattern. So thank you.
Any questions?
I have one question. Now there are a lot of AIs in radiology. So to know the progression and EL, like Dr. Sena showed, if you have a 10% reduction of FVC to tell that it is a progressive disease. Is there any AI that now with AI you determine the volumes in a progressive nature in a time-bound follow-up? Whether there is a volume loss, particular volume loss, then you tell it is a progressive disease.
Yes, so definitely a lot of AI tools are around which help us quantify the lung volume as well as quantify the extent of fibrosis as well as quantify the extent of ground glass attenuation. And over a temporal period also, we can actually quantify that there was say 5% fibrosis on a scan done in 2023, which changed to say 6 to 7% fibrosis on a scan done in 2024. So all those kinds of tools are available. The only caveat is that you need to get your scans right and with a proper protocol, because if there is slightest deviation from the protocol, then the AI tools read it all haphazardly. But if the scan has been done correctly, they are phenomenal in giving us those numbers for fibrosis or ground glass or the lung volumes as well.
Ma'am, any role of minimum intensity projection in diagnosing early ILD?
I will not say that there is a role of MIP in diagnosing early ILD, but there is a huge role of MIP in characterizing the ILD and in giving certain answers with respect to ILD. So that is the reason I insist that you should always ask for your images to be sent to you on DICOM mode, because once you do these min IP projections, you pick up things like differentiating honeycombing from traction bronchiectasis, then at the same time looking at certain other features which may be a diagnostic conundrum while you are looking at the routine HRCTs. So that is there.
Thank you.
Ma'am, does the untreated NSIP heal with honeycombing later on? And suppose you don't treat it for some time, then you see septal thickening and all, maybe over 2 to 3 years. Do you take it as damage or do you continue to treat it?
No, so one thing, NSIP will not heal with honeycombing, it will progress with honeycombing. Obviously, if NSIP is not treated at time, there are honeycombing changes that we see over time. So then we say that the NSIP pattern is progressing. So the disease is definitely progressing when it changes from a certain pattern towards honeycombing. Whether or not to be treating will depend on a lot of other factors that everyone else will decide basis if the patient is improving clinically and those things. But the disease in the lungs is definitely progressing if there is honeycombing.
But do we take it as damage or active disease?
Obviously damage. That is damage.
No, because our treatment might to some extent depend on that also.
So it definitely means damage, because if something is converting from even ground glass to honeycombing or reticulation to honeycombing or traction bronchiectasis to honeycombing, it means there is irreversible damage. By whenever fibrosis incites into the lung, that means the damage is irreversible.
Thank you.
Any more questions? We have some time. So I extend my heartfelt gratitude to Dr. Khushbu for sharing her expertise in imaging ILD. Her insightful presentation has greatly enhanced our understanding of ILD management. She has also emphasized on the quality of scan, which plays a crucial role in diagnosing ILD. I thank Dr. Pilenia for valuable contribution to our knowledge. Thank you.
Thank you, ma'am. Thank you, sir. Kindly please proceed towards our felicitation area. Now it's time for something that is actually very close to the heart of every OARFT member. It's a time for our OARFT tribute. Every year it's being presented, and it's being presented this year too. For this, may I request Dr. B.K. Mishra, Patron and past President IRA Odisha Chapter, Senior Consultant Physician Bhubaneswar, Dr. Shri Prasad Mohanty, HOD PG Department Medicine, MKCG Medical Hospital, and Professor Dr. Alakendu Ghosh, past President IRA, to kindly grace the dais. May I also request Professor Dr. Jyoti Ranjan Parida to please come and say something about the tribute.
So when we have decided about this meeting that we are going to do a interface meeting every year, and there are a lot of postgraduate and young doctors are coming, then we thought of this concept of ORFT tribute, because everybody in the society, they need a role model. So it's okay to gain knowledge, and it's always better to learn new things, but you should always have a role model to look forward, so that you want to be like him or her. I think everybody, all of us, during our student life and this thing, we have always inspired by some of our teachers who have actually, by their work and by their deed, gone to that level that we always look up to, that at least we should be like 10% of this teacher or this guru, so at least I can contribute to my field. So ORFT tribute is designed. Every year we give this tribute to one of the pioneer in rheumatology who have contributed their with their selfless dedication and mentorship. So this year, ORFT tribute, we are going to give to somebody. You will look at her, I think she will look like a very simple, she doesn't have any hair, but she has lots of flair. So if you'll interact for 10 minutes, you will be just, I think you will be just mellowed down by her, that infectious energy and this thing. So I think words are very short, because I am introducing Professor Dr. Amita Agarwal. Madam, please give a big hand of applause. I invite Madam to come here. I think in the total rheumatology fraternity, she is a mentor, she is a mother, she is a friend indeed, and anybody passed from SGPGI, I think everybody love Madam, because whatever slide and everything Abhinas has showed, I think if you will take a slide presentation to her for correction, she will first clear your slides, she will first cut down everything. So I think that is a reflection of Amita Madam in all students' slides, PPT presentation to all these basic science, whatever you have told. I was there, luckily, I have not understood. TGF beta and all this. She has worked for 2 diseases, I think, immunopathogenesis of juvenile arthritis and lupus throughout her, besides many things, because pediatric rheumatology is something very close to her heart. Ma'am, please come. So now I request our scientific chairperson, Ranjan, to read the citation.
So it's a proud moment for me too, because like so many other people, Dr. Amita has been my mentor, is my mentor. So Professor Amita Agrawal's contribution, distinguished career as a professor and head of the Department of Clinical Immunology at the Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow, epitomizes excellence in both clinical practice and groundbreaking research. Professor Agrawal's academic credentials are stellar, with a robust educational foundation from the All India Institute of Medical Sciences, New Delhi, and the Sanjay Gandhi Postgraduate Institute of Medical Sciences, Lucknow. Her profound expertise and innovative research have significantly advanced the understanding of juvenile idiopathic arthritis and systemic lupus erythematosus, among other rheumatic diseases. Her work has been instrumental in revealing the immunopathogenic mechanisms and developing effective clinical management strategies for these conditions. Her dedication to research excellence is evidenced by her numerous prestigious awards, including the Fellowship of the Indian National Science Academy and the National Academy of Medical Sciences. International recognitions such as Malviya Traveling Professorship in 2020 and the University of Birmingham's India Institute Award in 2019 further highlight her global impact in the field. As a teacher at SGPGI Lucknow for over 3 decades, Professor Agrawal has demonstrated exceptional leadership through her roles in various national and international committees, contributing to the formulation of guidelines and policies that have shaped the future of rheumatology. Known for being a student-friendly teacher, her commitment to education and mentorship has nurtured the next generation of clinicians and researchers, ensuring the continued advancement of the field. The OARFT honors Professor Amita Agrawal for her outstanding achievements, visionary research, and unwavering dedication to improving the lives of patients with rheumatic diseases. Her contributions have not only advanced scientific knowledge, but also significantly enhanced patient care, making her a true pioneer in the field of rheumatology.
Now I'll request Amrita, my wife, who has written a poetry about her achievements. So a few lines from Amrita.
Ma'am, forgive me if I'm wrong anywhere. I always get tongue-tied in your presence. Still, I'm trying. From Delhi's hallowed halls, your remarkable journey in healing began. At SGPGIMS, decoding rheumatology's intricacies became your plan. In the vast realms of rheumatology, as a professor and head, you held the beacon of wisdom and walked ahead. Fellow of National Science Academy, a title so apt and grand, your research and discoveries have echoed across the land. Kashanika Oration, Kamala Menon, your awards are a testament to a life of sincerity, hard work, and scientific investment. Traveling the globe, your knowledge and expertise shared, from Oklahoma to Birmingham, your professionalism fared. With each study and paper, your insights grew. From cytokines to biomarkers, your breakthroughs are true. You have led committees with wisdom, sincerity, and grace. From juvenile arthritis, immunodeficiencies to SLE, you did face. Your voice in science for so many has been a guiding light. You have treated and cured many ailing children's plight. With numerous publications, your knowledge is spread. An author of great repute, your papers widely read. A clinician and a scientist, your roles intertwined. In the role of rheumatology, your brilliance enshrined. Professor Dr. Amita Agarwal, we celebrate you today for your tireless work and dedication in every way. Your commitment and brilliance in every endeavor, in the hearts of your students, you shine forever. With gratitude and honor, we offer this tribute to the legend who herself is not less than an institute. For the patients whose lives you have touched with grace, we thank you, dear ma'am, in this hallowed space. Thank you so much, ma'am.
Now I think Professor Alakendu Ghosh sir, our past president IRA, may tell few words about ma'am, and after that we'll.
What more to tell about Professor Amita Agarwal? So everything is told, and she should not be restricted to the boundary of SGPGI Lucknow. And Jyoti was telling, because throughout the country and for each strand of students who are inside the SGPGI or beyond SGPGI, she is being loved by all. Because of giving motivation to the students, you are also an important person. Do this and you will achieve that one. So I think it's really great of Amita. Thank you so much, Amita. You can have that.
Should I start? Or? So good evening, good morning, friends. And it's nice to hear from students. When they are there, they don't like you, I can tell you. Hard discipline, every day, I'm telling them that you should be there on time at 8 o'clock. As somebody said in the morning, very difficult for students to wake up at 8 and reach the hall at 8 o'clock for the morning sessions. So I hope something has rubbed in, and that is why people feel that we try for everybody. A teacher is one who tries for everybody. It is for the student what they take in. Every student takes in something. And we also learn so much from students. I think it's a bi-directional thing. If a student is good, the teacher is on its toes. You have to read, you have to be up to the mark. So I think it's a very excellent relationship between student and a teacher, and each side is enriched if you have a fruitful association. And that is what I've tried in the last 40 years, to be a role model, to live by that principles, and hope that our students will live by that principles. And obviously, things are changing, and we have to also change with time. And what we used to remember, nowadays you don't need to remember. Everything is on your phone. So fine, don't remember the details, but at least remember the concepts. So that is what we have also changed, and the students are also changing. And I hope that all the students become excellent teachers. Teaching is the best way to learn. There's no better way to learn than by teaching. So this is what I would say as a teacher. So I have a disclosure in the beginning that this is not my area of interest at all. As was said earlier, that my area of interest are pediatric rheumatology and lupus. However, I've been asked to talk. I do definitely look at the lab a lot. So I think I would be able to do justice to this topic. So I'm supposed to speak on autoantibodies in interstitial lung disease, and since morning you have heard enough about interstitial lung disease, how it is diagnosed, what is the role of radiology, which we heard very nicely from Dr. Pilania, and similarly we'll see what we can learn from autoantibodies. And these are the objectives. So just to start with, for the undergraduates or postgraduates who are there here, that what are autoantibodies? Autoantibodies are nothing but antibodies directed against our own self-antigens. And as self-antigens are present all over the place. So they can be to the nuclear antigens, they can be to the cytoplasmic antigens, they could be even to the membrane antigens, as you see in acetylcholine receptor in myasthenia, or it could be to soluble proteins like what you see in antiphospholipid antibody syndrome. Why do we do autoantibodies? Basically, it can be used for confirmation of a diagnosis or of an exclusion of a diagnosis, or to assess disease activity, as you do in lupus when you measure anti-DS antibody, or for prediction of disease, as Dr. Shinoy showed us, that how can you predict who is going to develop interstitial lung disease? Because we need to act fast. And then, what is assigned to me? How do you assess prognosis of a disease, and can you modulate a treatment based on the autoantibodies? We have a plethora of autoantibodies, and that's what I see. Most clinicians order a large battery of tests. They are very happy to order lots of ticks. But really, do they help us? And this is another person, this is science, that was clinic. People have looked at 124 autoantibodies in patients with interstitial lung disease, and this was an abstract which was presented last year at the American College of Rheumatology. And if you see, the common ones are anti-Rho antibodies, U1 RNP, antibodies to DNA proteins, and what do these antibodies do? Do they help us in confirmation of a diagnosis? Because as a clinicians, we have first choices to get to a diagnosis. Where do they help us when a person has interstitial lung disease? We have this entity called interstitial pneumonia with autoimmune features, where patient does not actually have a well-defined connective tissue disease, but has some clinical features, has interstitial lung disease, which suggests, as was told just before, suggests a systemic autoimmune rheumatic disease, that either it is NSIP or organizing pneumonia, or a combination of these two, or LIP, where you think that there should be an autoimmune disease underlying. That is the time when we do autoantibodies, And if they are positive, you can make a diagnosis of IPAF. Are they useful in prediction of disease? I showed you that there are large number of autoantibodies, but it is still good that some of the antibodies go with certain diseases. So for rheumatoid arthritis, we have rheumatoid factor and antibodies to cytokinated proteins. For myositis, we have antibodies to antisynthetase as well as MDA5. In patients with lupus, we have multiple autoantibodies, but unfortunately we don't know which one goes with interstitial lung disease. And for systemic sclerosis, for Sjogren's syndrome, anti-Ro and anti-La are the two most important antibodies, and we'll see which one goes with the interstitial lung disease. And for systemic sclerosis, I think Shinoy has already given you enough food for thought. If you look at the myositis-specific antibodies, which are more commonly associated with interstitial lung disease, the two subsets, one is antibodies to MDA5, which actually portends a rapidly progressive interstitial lung disease, which has a very high mortality. And almost 90% of the patients who have MDA5 antibodies can have some form of lung involvement. Second is antisynthetase antibodies, where you see it in about 70 to 80% if HRCT is done in everybody, though in some it is absolutely subclinical and we don't treat it. If you come to rheumatoid arthritis, it's both high titers of rheumatoid factors as well as elevated levels of ACPA. If you look at systemic sclerosis, as Shinoy said, the two antibodies which really define which patient is going to have in long run interstitial lung disease is antibodies to topoisomerase, which is also called the anti-SCL70, and antifibrillin antibodies. Antifibrillin antibodies are not commonly available, but anti-SCL70 is routinely tested in all patients with interstitial lung disease. And anti-centromere antibody as well as antibodies to PMSCL actually have a lesser chance of having interstitial lung disease. The anti-Ro antibodies actually are the most fascinating. They are the antibodies which are most common in general population. That is why you see complete heart block, baby being born to a mother who's never aware she has a disease. So it's been shown in interstitial lung disease that anti-Ro antibody presence actually has a modifier effect. This is a meta-analysis which came last year, which shows you that in setting of myositis, if in addition you have anti-Ro antibodies, you have a much higher chance of having interstitial lung disease. And this is the data only on anti-Jo1 antibody positive patient. Again, the chance that you have lung involvement is much higher if you have anti-Ro antibodies. It's not only true for myositis, it's also true for all other diseases, be it systemic sclerosis, be it lupus, be it MCTD. In all of them, it has a modifier effect. How do autoantibodies help in assessment of prognosis of a disease? Let's start with ANCA, because I haven't spoken about that antibody, even though, again, it is so misused by everybody. ANCA is associated with interstitial lung disease in a small proportion of patients. Actually, it's antibodies to myeloperoxidase, which have a much better association with interstitial lung disease than antibodies to proteinase 3, which causes more severe granulomatous polyangiitis. So this is a study where they had taken nearly about 400 people with interstitial lung disease, and only 49 were ANCA positive. So you can see that it's a very small fraction of patients with ILD who have ANCA positivity. Of them, 33 had myeloperoxidase antibodies. And look at the survival. The patients who were myeloperoxidase positive had a very poor survival as compared to one. Even though you are ANCA positive, but you don't have antibodies to myeloperoxidase, you're likely to do good. In patients with rheumatoid arthritis associated interstitial lung disease, where we know that really nothing much happens in these patients, some of them are subclinical, and treatment really doesn't do real good benefit. Presence of ANCA actually is much more in patients who have rheumatoid arthritis associated interstitial lung disease, as well as the specificities are to a very heterogeneous group of antigens, which we may not have even heard of, like elastase, cathepsin G, and bacticide permeability inhibitory protein. So we never test for them, so that's why we don't know about it. And if you have rheumatoid arthritis associated ILD with ANCA, you are more likely to have inflammatory marker, you're likely to have more disease activity, and you're likely to have more severe impairment of lung function. So presence of ANCA in a patient with rheumatoid arthritis ILD makes it more severe. And systemic sclerosis, we have already heard from Shinoy, and this is the trial he discussed, focus trial. There, in tocilizumab group, people have shown that if you have anti-topoisomerase antibodies, you're more likely to have response to IL-6 inhibitor. So it gives you a good, better prognosis. But overall, if you see, presence of anti-topoisomerase antibodies actually portends a faster decline in your FVC. What about myositis-specific antibodies, which are the ones which are most often present in patients with interstitial lung disease without having any underlying connective tissue disease? So this is a very large study of about more than 1,500 subjects with interstitial lung disease. And if you see here, the myositis ILD actually has a very good prognosis. If you have IPAF, where you don't have classical myositis, without MSA, you have very poor prognosis. If you have presence of any myositis-specific or myositis-associated antibody, you have much higher chance of survival. And this benefit is more if you have a myositis-specific antibody than if you have a myositis-associated antibody. The anti-tRNA synthase. Again, look at it. This is the graph for IPF, idiopathic pulmonary fibrosis. So if you have any of the anti-synthase antibody, you're likely to do better. So you pray that you have some antibody if you have interstitial lung disease, because you're likely to do better. And in rapidly progressive interstitial lung disease, actually there are two antibodies, which one has positive predictive value, that is anti-MDA5, while anti-Jo1 or anti-synthase antibodies are negative predictive value. They are less associated with rapidly progressive interstitial lung disease. And anti-MDA5 antibody actually portends a very poor prognosis. You can see the survival is only about 60%. And along with MDA5, if you have anti-Rho, I told you that's a modifier. So if you have anti-Rho antibody which gets a score of 2, and if you are having a higher score, that is if you have a high risk, your probability of survival is much less. So anti-Rho antibody in addition to anti-MDA5 reduces your survival when you have rapidly progressive interstitial lung disease. And this is the data which I showed you where they've done some 120 antibodies, and they have shown that some of these antibodies increase the chance of your dying by about 2-fold. Do they affect our treatment decisions ever? So this is a story, as you heard, that I am interested in pediatric rheumatology. So this is a 12-year-old boy who had inflammatory symmetrical polyarthritis for about 1.5 years. So we diagnosed him as juvenile arthritis, treated him with low-dose prednisolone, methotrexate, and NSAIDs. And then he developed, after 6 months, proximal muscle weakness. He had bilateral ulcerative lesions over his knuckles. That is, he had a ulcerative Gottron's lesions. And 2 months, he had dyspnea on exertion. This happened during the COVID time, so he didn't come back to us. He came back when he had bilateral periorbital puffiness. And if you see here, he has this characteristic puffiness, which is on both sides. This is a rash which is very typical of MDA5. Even if the patient does not have weakness, always think that the patient may have antibodies to MDA5, and especially if you have ulcerative lesions. So this child had ulcerative Gottron's, and he had decubitus ulcer, he had alopecia, as you can see here, he had tender joints, he had marked muscle weakness, he also had crepitation in both lungs. And if you see here, he has all the 4 muscle enzymes elevated, but in addition, he has high ferritin, suggesting that he has a very high inflammatory marker. High ferritin in a setting of myositis or interstitial lung disease should make you think to do antibodies to MDA5. And so we thought he had dermatomyositis, and we did his HRCT. This is the other sections, and if you see here, he has got ground glass opacities both and he has a reverse halo sign also there. In addition, he had bilateral pleural effusion. So we ruled out infection as usual. We have to rule out all this, and he had come during the COVID times. So we looked at all those things. In addition, as you saw here, he had antibodies to MDA5, which was, looking at him, you could say that he has anti-MDA5. How did it affect our treatment? It affected our treatment because he was antibodies to MDA5 positive. He had rapidly progressive interstitial lung disease. So we gave him triple therapy with IV methylpred, tacrolimus, and IV cyclophosphamide. And he showed significant improvement. If we had not given him triple therapy, he would have had a poor prognosis. Nowadays, tofacitinib has also come into the picture, and this is a Japanese study which has shown that tofacitinib, if used in rapidly progressive interstitial lung disease, it gives you a much better benefit. So these are the recent recommendations, which are by the American College of Chest Physicians as well as Rheumatology in 2024, that if you have MDA5 positive, then you must give with corticosteroids at least 2 drugs. Don't give 1 drug, because this disease is very rapidly progressive and you need to treat very effectively. So thus, I think I am on time to summarize that if you have a patient with interstitial lung disease, and you must take a detailed history that the patient has any features of autoimmune diseases. If not, and your lung CT is suggesting it is NSIP, or it is LIP, or it is organizing pneumonia, test for first these antibodies, which are more common, like you must do ANA, look for SCL70, anti-Rho, RNP, Jo1, rheumatoid factor, anti-CCP, anti-dsDNA. If that is negative and you have a very high index of suspicion, or you have mildly elevated muscle enzymes, then do myositis-specific extended panel, because it costs about 8,000 rupees, so it should not be done in everybody. So thus, to summarize for you, that autoantibodies are needed for diagnosis of IPAF. They increase the chance of ILD in a connective tissue disease if you have antibodies, anti-synthetase antibodies, you have antibodies to MDA5, or you have SCL70 antibodies, or in a setting of arthritis, you have RF or ACPA, or you have ANCA antibodies. Anti-Rho is always a additive factor. And if you have 2 of those, you're likely to do worse. And the poor prognostic antibodies are antibodies to MDA5, anti-Rho antibodies, myeloperoxidase antibodies, and anti-SCL70 antibodies. And therapeutics, the only thing which makes a difference is antibodies to MDA5. Please use triple therapy. Thank you.
Thank you, madam. As usual, very masterly lecture on antibodies, and that this is useful to both the undergraduate, postgraduates, and practicing rheumatologists. So any question madam can answer?
Yeah, sure. Yes.
Ma'am, anti-MDA5 is mostly associated with clinically amyopathic myositis. In that scenario, how to suspect that it is a case of myositis? As because there might be only cutaneous symptoms manifestation, there would not be any myositis symptoms per se. Then in that case, how we should proceed for that?
That's why I told you that look at the rash. The rash is the giveaway. The rash is very different than the heliotrope rash. You will have swelling both in the lower part and the upper part. It's like a angioedema of the eyelids. It's very different. Once you see it, you will never forget. Second, if you have ulcerative gottrons, if you have an inverse gottrons on the flexural areas, or you have vasculitic ulcers in the other parts of the body, if you will do muscle enzymes, there may be mild elevation of muscle enzymes. If patient has interstitial lung disease and has high ferritin, think of antibodies to MDA5 and do it.
Thank you.
Pardon?
IgM and IgG antibody in prospect of disease progression.
So in general, IgG antibodies are most pathogenic. IgM antibodies can occur following any infections, especially the viral infections. So we pay very little attention to IgM antibodies unless they are persistent. Otherwise, IgG antibodies are what we test all the time. So whatever I have talked of is predominantly IgG antibodies, except the rheumatoid factor, which is an IgM antibodies. And generally, we use immunosuppressive agents, and biologics are used as second-line therapy, except in patients with systemic sclerosis, where rituximab can also be used as first-line therapy. And sometimes in rapidly progressive interstitial lung disease, also rituximab has been used as one of the agents when you use triple therapy.
If there are no questions, we can conclude the session.
Thank you. Thanks a lot.
Thank you, ma'am. Thank you, sir. May I request you to please proceed towards our felicitation arena? Sir, may I request you to please to move towards our felicitation arena? So you must have had an academically enriching session by all our speakers. It's time to give your brain a little bit rest for 5 minutes. I'm sorry for the short time interval, but the tea break is there, and you can please move out and have the tea and snacks. Since we are running short in time, I would request you to please return back in 5 minutes. May I please request everybody to please come back. Please get your teacups and please come back. We'll be starting with our session in 2 minutes. May I request everyone to please take their seats so that we can start with the session.
Timing of the forced exhalation should be recorded and interpreted. There are a lot of variability in devices and technicians. So you need to use actually the same device for one patient every time you follow them up and use the same reference equations. So this is a bigger problem in centers, like today a patient comes to me, I send to this center, next time I send to this center, and third I send to this center. Every center will have a different device, different calibration, and there will definitely be a difference in values. So you need to have the same machine, preferably every time you do a PFT for one patient. We have discussed about the breath hold, oxygen, and body box is difficult in patients who have muscle weakness because they may not be able to hold the breath like that. Okay, so this is very important that restricted effect, we understand that there is a FEV1 upon FVC ratio which is maintained, but the loop becomes smaller. So I'll tell you about one case. This is a lady who is 27 years old, diagnosed as systemic sclerosis for last 4 years. The last CT was done 3 years back, which was reported as early NSIP. FVC was 76% of predicted. She now comes with worsening dyspnea. So clinical impression is that patient has worsening ILD. He got a CT done, CT shows which was similar to 3 years back. The FVC has gone down. Okay, so what are the things which can happen? Maybe there is a worsening ILD, whether there is chest wall restriction, where there is development of PH. So what I want to tell you that any reduction in FVC does not mean progression of ILD. Any reduction in FVC does not translate as. So when we examine the patient, there was worsening of skin thickening. Okay, you look at their previous PFT and the current PFT, there is a reduction in FVC, there is a reduction in DLCO, but the KCO is maintained. So what is KCO? KCO is DLCO by alveolar volume. That means the lung volume which is there is actually functioning well. The problem is the entire lung volume has gone down, likely because of worsening chest wall restriction. So this is also important that every FVC reduction should not be interpreted without looking at other parameters and the older values. We have to treat the patient, not the reports. Okay. So when you have a patient with worsening PFT and CT-ILD, what I can think of that these are some of the causes which should be thought of rather than only and only ILDs. Now I'll go to a second patient, a 48 years old lady with rheumatoid arthritis, RF NTCCP positive. She has dyspnea and dry cough. FVC is 60% of predicted. DLCO is 42%, 6-minute walk distance 250. CT done, CT is reported as NSIP-OP overlap. With this, she was started on corticosteroids and rituximab therapy, which will take care of her both joint as well as the ILD. The cough improved, there was improvement in dyspnea, joint disease got controlled. FVC was stable, 62, DLCO 40, 6-minute walk distance had some improvement. Patient was thought that she is responding to the treatment. Corticosteroids 5 mg per day and rituximab was continued for her treatment. Now after 2 years, what has happened? Now she comes with worsening dyspnea and cough over 3 months. Room air saturation has gone down, FVC has gone down, DLCO has gone down, and 6-minute walk distance has gone down. The CT done shows this. So what has happened now? What has happened is that what was previously actually an organizing pneumonia NSIP has evolved into a honeycombing pattern over time. So what do we call it as a progressive pulmonary fibrosis? Okay, so this is a term which I want to introduce to you all very importantly, that this is a concept of PPF which is applying to CTD ILGs as well. When you have a patient who has a disease, you have diagnosed, labeled them, you have treated them, but still the end behavior is same. All CTD ILDs, they may end up in a fibrotic pattern. Some may not, some may not. So I'll show you what is the proportion of those patients. So this is the graph from the ATS guidelines. So this blue thing shows the proportion of patients who will actually end up having progressive pulmonary fibrosis. And how can we pick this up? By only and only by the lung function testing. So what is PPF? A patient who has progression either in the respiratory symptoms or physiology, that is lung function, or radiological over 1 year without any alternate explanation, they are treated as PPF. And why diagnosis of PPF is important in the context of CTD ILD? Because that's the point where antifibrotics may work for these patients. Although the data is very less, but this is the point where they need to be started on antifibrotic therapy. What are the criteria? So criteria, I think Dr. Shinoy discussed the relative decline in FVC. 10%, he said that if you have a 70%, 10% means 7%. For a diagnosis of PPF, it's an absolute decline. You had a 70%, if you have a 10% decline or a 5% decline, that means from 70 you go to 65. That is absolute decline. This is also important because relative would be different and absolute would be different. So for PPF diagnosis, you need an absolute decline in FVC of 5% in last year or DLCO of 10%. So why I brought this is that this is where actually PFT plays a major role in diagnosis this subgroup of patients who end up in PPF. Now I'll talk a little bit about this 6-minute walk test. So how many of you perform 6-minute walk test? Please raise your hands. So a large proportion. How many of you have done it yourself? How many of you seen that it is being done properly? Because 6-minute walk test, if not done properly, the values will vary on time, with time, and you'll have a problem. So you have to have a standard way of performing it. There are ATS guidelines available. Even if you can't follow all the guidelines, follow one procedure every time. At least for your patient, it will be useful that the values don't change over time because of the method is being done. What are the problems with the 6-minute walk test? The problem is the distance which patient can walk does not depend only and only on ILD or lung function. There are other ways like arthritis, heart disease, pulmonary hypertension. They all will impact the 6-minute walk distance, and you may think it as a progression of ILD. It may not reflect symptoms or the daily activity. So what is the correct use of 6-minute walk test in patients with CTD-ILD? So if patients who do not have significant confounding health factors and they can perform the test, it is useful for follow-up, specifically for patients with pre-lung transplant, pulmonary hypertension, and those who cannot perform PFT. 6-minute walk distance plays an important role. It is only in the context of CTD-ILD. Other ILDs, 6-minute walk test, extremely useful test. So what does ACR recommend? So I'll just come to the ACR recommendations. So they say patients who have increased risk of ILD, they should be screened with lung function. And lung function includes spirometry, lung volumes, and diffusion. So these three may not be possible for everybody. This is also a limitation. We have to understand that we can adopt the guidelines to local setting, that whatever is available with us, at least a spirometry is something which should be done. And what are these patients who are at increased risk? Are scleroderma, IIM, MCTD, patients of RA or Jogren who have high risk factors. What is against? They recommend against the use of 6-minute walk test for monitoring as well as for diagnosis for the reasons which I have already discussed. So what we do, or what the frequency of monitoring, clinical monitoring is extremely important. PFTs, initially we do it for 3 to 4 months initially, for 1 year, and then it can be done at 6 to 12 months depending upon the stability of disease. 6-minute walk test, echo, anti-proBNP, etc. may be performed for these patients as and when needed. So just to conclude my discussion on PFTs in CTD-ILD, the key point here is the quality assurance of PFT. If you do not have a good quality PFT, you should not interpret it. If you do not have a good machine, you should strive for a better equipment so that you can have better values. PFT is most useful follow-up. E-spirometry is easy to do and readily available. 6-minute walk test is to be performed in specific situations. And frequency of monitoring by using these tests, there are guidelines, but it needs to be individualized based upon the clinical data, whether there is a clinical progression or stability. That's all. Thank you.
So Dr. Mittal has nicely explained about the use of spirometry and 6-minute walk test. These two are definitely the one of the most simplest monitoring tools from the primary care. So any question about 6-minute walking distance or spirometry as well as other parts of the PFT like DLCO and lung volume?
Sir, in combined pulmonary fibrosis with emphysema, the fall in FVC cannot be extrapolated correctly. So in that case, how we will extrapolate if we are searching for if the patient is going for progressive pulmonary fibrosis or not? There, the fall in FVC might not be extrapolated correctly in case of CPFE.
So patients with CPFE actually do not fall into this definition. The CPFE patients have COPD with IPF. So this definition of PPS applies only to non-IPF group. Once you have IPF, you have to give them antifibrotics, irrespective of progression. So CPFE does not apply here.
Very nicely presented, Dr. Mittal.
Thank you, sir.
Actually, one thing I need to know, since it's a chronic disease, how frequently do you advise to do the HRCT and PFT? How frequently you should do? Can you give some highlight on that?
Okay. So for scleroderma, obviously at diagnosis a CT is to be done. For scleroderma, our frequency is obviously not standard. The correct way is that you do it at any progression or any change in lung function. That is one thing. But for scleroderma, we may have to do it for maybe at 2 years or something. But the key for HRCT screening is based upon or guided by your clinical worsening or by your PFT worsening. Okay. For PFT, the initial is 3 months for at least 1.5 years. And after, if we see that the disease is stable, then we make it 6 months, but not beyond that.
Sir, wanted to ask about ambulatory desaturation testing and why they have said that we shouldn't use that in screening but in monitoring in the new guidelines of ACR.
So, okay, so ambulatory desaturation testing can be done from 2 ways. One way is doing a 6-minute walk test. You'll know what is the desaturation happening. Another is not doing it as a standard 6-minute walk test. You just make the patient walk and whether they desaturate. The problem here in the screening is the same. That desaturation may not reflect ILD. Desaturation may happen in patients who have heart disease, patients who have pulmonary vascular disease as their primary problem rather than ILD. So it is not recommended for patients with, for screening for ILD. This is only applies to screening for ILD. For monitoring purposes also, it is not the standard. It is an optional test which can be used, but I would still feel that if you want to use an ambulatory test, always use a 6-minute walk test rather than a non-standard test.
Thank you, Dr. Mittal.
Thank you,
for
sir.
a wonderful talk.
Thank you.
Thank you, sir. Please proceed towards the felicitation arena. Next, we have a very exciting program by, actually very exciting debate by 2 very renowned speakers. And this will be chaired by very dynamic chairpersons as well. Dr. Bharat Panigrahi, patron of IRA Odisha State Branch, and Professor Dr. Chandan Das, Professor PG Department Medicine, IMSN Saum Hospital. So kindly grace the dais. One important announcement. For the quiz, we had a very huge response. So we have almost 25 teams. So during the lunch hour, for the initial 15 minutes, we request them to stay back because the prelim round will be conducted. So after those 15 minutes, you can go for your lunch.
Okay, friends, so good afternoon to you all. So for the last few hours, we have heard many things about CTD-ILD, and we have heard about the pathogenesis, we have heard about the treatment of SSC-ILD, and of course, so different antibodies, how they influence the treatment of ILD. So this is a session, this is something new, and we'll be dealing with this session regarding the another phenotype, a new phenotype, that is the PF-ILD. It's nothing that progressive fibrosing alveolar, that is ILD. So here we have got 2 speakers. So in this group of progressive fibrosing alveolar, ILD, so which is the right treatment? Whether we should go with immunomodulation or we should go with antifibrotic. So we have got two eminent speakers, and my co-chairperson Dr. Chandan Das will be introducing these speakers. And before we go, I'll just tell you, each speaker will tell 13 minutes, okay? Then again, after these, both the speakers, they finish, and again report will be 2 minutes. Then it will be, then the audience will be asking, they can ask many questions, comments after that. So now Dr. Chandan Das will introduce the speakers.
Yeah, good afternoon. I think the first speaker will be Professor Dr. Varun Dheer. He is a professor of Division of Rheumatology and Clinical Immunology, Department of Internal Medicine in PGI Chandigarh. His research interests are rheumatoid arthritis, spondyloarthritis, and use of methotrexates in rheumatoid arthritis and its pharmacokinetics, and T cells as rheumatoid arthritis. I think you will be speaking on
immunosuppressive.
Yeah,
for immunosuppressive. Yeah, I think it's the other presentation. Can you change it to mine presentation, Varun Dheer presentation? Or we can change. Yeah. Okay, good afternoon, ladies and gentlemen. It's a pleasure to be here, and I thank Dr. Jyoti Ranjan Parida and Ranjan, who is the scientific chairperson, for the kind invitation. So I'll be focusing on the fact that I'll be going towards immunosuppression, much more than antifibrotics. And the format of my presentation is going to be like this. The first I'm going to talk about that progressive CTD-ILD is a killer. And then I'll go on to the other things, and we'll talk about progressive fibrosis and the role of immunosuppression. So progressive CTD-ILD is a killer and needs treatment. We've heard from the morning, Shinoy's warning showing us the mortality figures. And obviously, I'll go to the same study. This is a natural history study by Virginia Steen from the United States, who studied around 900 patients. And what she did find is that on a cross-sectional basis, there'll be almost 10 to 20% patients who will have that severe ILD when you see them. And the overall mean survival she found in her cohort was around not that bad, as Shinoy showed. Over 18 years, there were only 34% who had died over 18 years. So it wasn't that bad as well. But if you look at the severe ILD patients, so the subgroup which was severe ILD, she had at that time took a cutoff of 50%. The mean survival at 5 years was just 5 years after the first pulmonary symptom. So what I want to emphasize, this is a graph showing you, I'm sorry, I don't think this is visible. Okay, so what you can see on the y-axis is the mean loss of vital capacity, and on the x-axis, what you find is the disease duration. And if you find in the first 2 years of disease, and these are only of the severe patients. So what this graph is trying to show you, that there is a subset of patients who lose lung volume rapidly, to the extent of what she found 30% of vital capacity per year. And this is the subgroup we need to target.
Two things. One is point.
Okay. Okay. Oh, yeah.
This one.
Okay. Thank you. Thank you so much. So there is a huge subgroup of patients, there is a small subset of patients who lose vital capacity very fast, and that is what we need to target. Now, ideally, how do you pick up these patients? The ideal way, obviously, is to pick up is to follow them up regularly, like we had in Dr. Saurabh telling us about 3 monthly PFTs. But obviously, the problem is that if you keep following up and your action time is delayed, you might lose lung volume. So what was the other way which came up? We came up with a way in cross-sectionally to detect this subset of CTD-ILD. And how do we detect this progressive CTD-ILD on a cross-sectional basis? We have this elegant study from a single center by Go et al. In 2008, which many of us follow. And what I want to show you is they had subset of around 200 patients with a 10-year survival of around 60%. And majority, there were a lot of progressors in this study, patients who progressively lost their lung volume. Remember, this debate is about progressive CTD ILD. Obviously, we'll add the term progressive fibrotic, but does it make much of a difference? So what they found is, look here, in the extent of the disease, was 13.5% median, but the fibrosis was almost half of this was fibrotic lung disease. And this is how they classified. They classified based on 5 cuts on the HRCT. I'm not going to go into detail, but what did they finally classify based on the HRCT extent and the forced vital capacity? And based on this, whether the HRCT extent is more than 20% or your FVC is less than 70%, they call them extensive disease, and showed that this is the subgroup that we need to target. The extensive subgroup cross-sectionally is the one which are progressors, which are going to have mortality, and this is the one we need to target. Now, how does this make a difference to this debate? What I'm going to prove to you is that immunosuppression does treat progressive fibrotic ILD. So, this is the scleroderma lung study, one of the first large randomized controlled trials in this field, which still remains the gold standard, which had head-on-head comparison of oral cyclophosphamide versus placebo in patients of scleroderma ILD. So this was the entry criterion. I'm not going to detail, but you had, as you can see, the forced vital capacity at baseline was around 67 to 70%. And we all know that what it showed was that oral cyclophosphamide can stabilize the lung disease. And vis-a-vis placebo, there was a difference around 2 or 2.5% of FVC over 1 to 2 years. And this is what they showed. But what is more important is is this graph, which is from the original publication as well. On the y-axis, what you see is the forced vital capacity at 12 months. And on the x-axis is the maximum fibrosis score at baseline. And just see here, the dark black line is the placebo. And if you can see the placebo going down in the most highest fibrosis and cyclophosphamide holding in these. So that what happens is that the patients with the highest fibrosis, that means who had a fibrosis score of, let's say, 3 or 4, that the benefit was the highest. You could prevent a 10% loss of FVC if you use oral cyclophosphamide. Ladies and gentlemen, this would be the subset which, if today's world, because this semantic has come today, we would call them progressive fibrotic ILD. You have fibrosis on the CT, FVC lost by 10%, you might call them progressive fibrotic ILD and think that you need to treat them with antifibrotics. But this is the subset which was the best effect of immunosuppression was found. This is the subset in which immunosuppression is going to work and going to lead to better survival. And this is another sub-study of the same SLS1 published in 2011 by Roth et al. And if you see on the y-axis here is the cyclophosphamide treatment effect, and on the x-axis, I'm sorry, it is slightly is the modified Rodnan skin score. And again, they found that not only with the fibrosis in the lung, with the fibrosis in the skin as well, the maximum treatment effect in the FVC is coming with maximal fibrosis. So ladies and gentlemen, the message I want to bring out from this elegant study was that we've been told that, okay, you can easily differentiate fibrosis, activity. What I believe is that if you see a patient with high fibrosis, it does not preclude. In fact, it is an indication for aggressive immunosuppression, because these are the patients who are going to progress. Now, this is another sub-study based on the same SLS1 by Roth, by Roth et al. And what they did show was, if you see all patients here, I'm sorry, this is the all patients. These graphs have, I don't know how they've got a little mixed up. I'll start with the first graph, which is all patients. On the x-axis, what you're showing is the follow-up time. On the y-axis is the percentage FVC. And you can see the open circles are the cyclophosphamide, the shaded circles are the placebo. And you can see that there was some difference, yes, over time. At 12 months, there was a difference of around 2%, as we are saying. At 24 months, again, 18 months, it was again around 2.5% between placebo and cyclophosphamide. But look at the responders. The responders, the predicted FVC and the, between the predicted FVC in the cyclophosphamide group and the placebo group was going up to 10%. And who were these responders? these responders they had classified only on the basis of two criteria, which is the fibrosis scores at baseline on the CT and the MRSS scores. So if you have high fibrotic scores, those patients are going to respond to immunosuppression, period. Whereas if you have low fibrosis, those patients are not going to respond. Sorry, this little bit got mixed up. And again, showing you in another way, where they looked at the HRCT images. Rather than looking at the pulmonary function test, they've looked at the HRCT images. And again, from the same sub-study, from the scleroderma lung study, what they've seen in the two treatment groups, this is the fibrosis, this is the cyclophosphamide arm and the placebo arm. And if you look after treatment, on a 12-month repeat HRCT scan, what they found is, in the cyclophosphamide arm, there were much less patients who had progressed, that had become worse on the HRCT, whereas in the placebo arm, almost 50% of the patients had progressed and developed more fibrosis on HRCT. So, ladies and gentlemen, we can prevent progressive fibrosis in a fibrotic disease with aggressive immunosuppression. And this is just the representative images. They had shown that in the placebo arm, patients progressing, whereas in the cyclophosphamide arm, not progressing. And then we have this scleroderma lung study too. Again, I'm not going to go into the detail, but this was a study head-on-head between oral cyclophosphamide and mycophenolate mofetil. The forced vital capacity was almost the same at baseline, 67%. And if you see here that on the y-axis is the forced vital capacity, on the x-axis is the time, and you can see it here, both the arms doing much better. In the scleroderma lung study 1, we found stabilization. But here, as Shinoy said, we find improvement in the forced vital capacity in both the groups. And you had almost 3% improvement in forced vital capacity in both the groups with just immunosuppression, either of the immunosuppression. And if you look at their, overall lung extent on HRCT again, and you look at the quantitative ILD scores, this on the y-axis is the quantitative ILD scores, this is the number of patients, and you have 4 quadrants which come up, and you can see majority of the patients are in the lower 2 quadrants, that the quantitative ILD score became negative on follow-up. That means that you could improve what you were seeing on the HRCT initially, right, with immunosuppression. So, it is very clear that progressive fibrosis is treated by immunosuppression. It not only stops it, but in many cases, it can improve it. Now, let's see this new kid on the block, which is antifibrotics, which we have for 5 years. How does it compare with our immunosuppression? Now, look at this. These are 2 studies which are important. One is the SLS2. This is the recital study. In the SLS2 and the recital, both of which you are finding gains by 3 to 5% in forced vital capacity. How does antifibrotics do? Antifibrotics, even if you're making them, it is negative. It is still you're able to little bit improve the fall you're having. You're getting if you compare it with placebo, in which the fall is 2.5%, you reduce the fall, you reduce the extent of the fall, but you can't make it positive. So there is no comparison between immunosuppressive. If you to choose between immunosuppressives and antifibrotics, it has to be immunosuppressive number 1, immunosuppressive number 2, immunosuppressive number 3, and then it is the antifibrotics which come up. What is the problem with antifibrotics? If we have a great antifibrotic tomorrow, I will be all for it. With the current antifibrotics, the problem which Shinoy alluded to, they have a very poor tolerability. You're trying to give it to a patient who is short of breath, who's having a problem, and what are you giving him? Diarrhea, right? You're giving him transaminitis. That is the major problem. In many patients, they lose weight on antifibrotics. So that is the problem with the current class of antifibrotics. To reiterate, well in time, that we were always treating progressive fibrotic ILD. This terminology doesn't change much for us, right? We were treating progressive ILDs, we were treating progressive fibrotic ILDs. This term of saying it is a new semantic which has come in, but I don't think for me it changes much. Immunosuppressives will not only stop, but improve fibrosis of CTD-ILD of this progressive fibrotic variant. Antifibrotics, as of now, are weak and poorly tolerated. So I don't think there's much of a debate between them. Thank you very much.
Thank you, Dr. Varun. I think Dr. Varun was very vocal about his advocacy of immunosuppressions in progressive fibrotic disease. And I think to contest his views, we have another stalwart, Dr. Rajadhar. Dr. Rajadhar is, I think he has such a huge, he is a director and head of Department of Pulmonology, CK Group of Health Hospitals in Kolkata. And he is director of HERMES exams, Asia European Diploma. I think it's a long queue, so I think everybody knows him and did not explain everything. And Dr. Dhar, you will be talking on antifibrotic therapy in progressive ILD.
Can I have my slides up, please? In the meantime, big thank you to Professor Jyoti Ranjan Parida, my friend Professor Manoranjan Dash, my senior Professor Jyoti Patnaik, and all the rest of the team to actually put up a wonderful conference. This is novel, this is different, and I love the way the interplay between the two specialties have been brought to fore during the course of this meeting. Can I have my slides up, please? So, as expected, Professor Varun Dheer has put up a very passionate disposition about the role of immunosuppressives, and I'll try and present to you the other part of the story as soon as the slides come up. Yeah. So when I was given this debate, I tried to find out about my opponent. And Professor Varun Dheer is about 10 years my junior, but cited widely an H index of about 22, which is sort of very close to where I have got, being 10 years senior to me, and I was skeptical. I also felt a little intimidated, so I rang up Professor Parida and said, can I have a talk, please? And he said, no, you have to debate. So here I am. I'm here, and it's the battle between Dheer versus Dhar. I think that's something to think about, and that's what we're going to discuss. So the reason we are doing this meeting today, the entire meeting today, is that major pulmonary complications are present in autoimmune rheumatic disease, and you would have heard Professor Dheer, I'll call him Varun for ease, so you would have heard Varun talk at length only about scleroderma. So it's not just about scleroderma. There's a wide array of diseases in which interstitial lung disease forms a prominent part, maybe not the most prominent part in some of them, but forms a prominent part across the board and across disease processes under the umbrella of connective tissue diseases. And when you look at lung patterns, the histology of the disease, you would see that there are two patterns, usual interstitial pneumonia and non-specific interstitial pneumonia, which form the vast majority of the changes in the lung under the umbrella of CTD-ILD. And when you think about the lung patterns, UIP pattern forms about 35% and about 45% constitutes of NSIP. That's the histological pattern that you have. And the remaining ones that you see, the tongue twisters that you have down that list, they constitute about 10% of total. So that's the sort of percentage that you're looking at. Now this is, I'm not trying to confuse you, but this is just to say pulmonary fibrosis is different in different areas, and not all fibrosis is created the same. So you can see on the top left there, that's a normal healthy lung, and you can see the thin alveolar septa, the pleura which is thin, the bronchovascular bundles in the middle. And then you see fibrotic non-specific interstitial pneumonia. You have more diffuse involvement. The center of the lobules are, there's distortion of architecture, and there's thickening of the interlobular septa. And then down here, you see more airway-centered pattern. That's the chronic HP. That's the sarcoid that you see. And the cartoon shows you that there's fibrosis and there's bridging between individual fibrosis. And then you have the fourth, which is usual interstitial pneumonia, which, as you all know, and you've seen since the morning, it's subpleural fibrosis. The fibrosis is irregular, it's peripheral, and this transition that you see. So this fibrosis, and then this transition to normal alveolar septa immediately after. So all fibrosis are not different. So I can see Varun gazing at the screen and saying, that's my dialogue. That's why you don't need to give antifibrotics to all of them. This guy is actually speaking in my favor. But before he jumps in joy, pathologically and prognostically, UIP, whether it's from rheumatoid arthritis or whether it's from IPF UIP, is actually very, very similar. Similar radiologically and similar histologically. The pink blobs don't mean a lot to me. However, you can see that there's fibrosis, honeycombing that is similar across the board in the two disease processes. So remember, carry home message, in patients with UIP, the ultimate pattern post-disease progression looks similar, is similar across the board, and hence you would hypothesize that the treatment for both would be very, very similar. So that's about UIP in different disease processes. What about the NSIP and the UIP? So the basic premise is when there is progressive fibrosis, you would get worsening traction bronchiectasis and you would get honeycombing. You heard in the morning that any progression of traction bronchiectasis, any progression of honeycombing or appearance of these features would qualify with the terminology that's been spoken about since the morning, which is progressive pulmonary fibrosis. And there's some commonality in disease behavior in IPF and PPF, especially when fibrotic NSIP progresses, and Varun has shown that very nicely. So let's get the basic premise right. What you see on the top, the red is all fibrosis, that's IPF. So all patients with idiopathic pulmonary fibrosis have a fibrotic disorder, and hence in IPF, you would treat them uniformly with an antifibrotic. Look at what happens in patients with non-IPF ILD, and you can see at the top there, the disease we are talking about today, which is CTD ILD. So there's inflammation, there's an overlap zone for transition, and then you have fibrosis, and you can see the two here overlap. They look very, very similar. It's only fibrosis. The inflammation is burnt out thereafter. And hence, depending on the stage of the disease, when it's blue, it's immunomodulatory therapy, which Varun spoke about so passionately. And then you have the overlap zone where you have a combination. And then progressing forward, you probably only need the antifibrotic. The combination therapy is no longer needed because it's fibrosis that you're treating at that point of time. So think back, and we'll do a little bit of extrapolation now for the next couple of slides. Think about the Panther trial, which is now about 12 years old. We found out in Panther that a combination of steroid, azathioprine, and NAC did harm. The study was stopped midway because immunosuppressives seemed to cause harm, steroids seemed to cause harm in this cohort of patients. I would argue that the fibrosis here, and then the latter part on here where there's burnt out inflammation and only fibrosis, probably steroids and immunosuppression would also do harm in this category of illness. So the debate, as Varun very aptly put it, is not about whether it's immunomodulation or it's antifibrotic. What we are debating about today is whether, how do we position the antifibrotic, and how important is an antifibrotic as first line when you have progressive disease, when there's appearance of fibrosis, not just progression of the disease, but about progression of fibrosis, and how does the data of immunosuppression and antifibrotic compare. So a couple of slides about IPF, and I'm going to extrapolate a little bit of data again. So antifibrotics we know improve survival in patients with IPF. The presence of honeycombing and traction bronchiectasis helps predict responders. And static antifibrotics early improves lung physiology better in patients with IPF. Couple of large disease trials. So this is the Australian registry. This is the European registry, and to cut a long story short, adding in the antifibrotics improves survival in both these large Australian and European registries. Can we identify antifibrotic responders? So on this forest plot, they compared various factors which you cannot see, you need not see, but the important part is here, presence of honeycombing or the confirmation of a UIP pattern by surgical lung biopsy predicts you would have a far better response with nintedanib, the antifibrotic, whereas compared to no honeycombing or no surgical lung biopsy. So that's the comparison. So is this, I'm just extrapolating, I can see Varun jotting down. So is this something which is unique just to IPF? So I found this paper, which my esteemed opponent has written, which is factors associated with interstitial lung disease and the PF-ILD pattern in patients with rheumatoid arthritis-related disease. And this is quoting directly from the paper. It says subjects which were older had a greater frequency of honeycombing, higher HRCT score for honeycombing, and aggregate fibrosis than those without the PF phenotype were the ones which progressed. So no similar, as Varun has very aptly pointed out in this paper, compared to what you see in the IPF category of patients. This is the lung function decline, the FVC decline over 52 weeks from the inbuilt study. And you can see there are three categories here. The overall population, and you can see in the overall population, patients who had nintedanib had a far greater relative reduction as compared to people who had no fibrosis, whereas patients who had fibrosis, as in honeycombing, had the greatest amount of relative reduction of fibrosis. And you can see the separation between the inbuilt category and the placebo category starts off early. So there's, at 12 weeks, you have improvement or reduction in decline of lung function at an early stage. Let's try and define this progressive phenotype better. This is a global expert group which I was fortunate to be a part of, but which our own Dr. Sujit Rajan from Mumbai started off. And this looks at the PPF category. So worsening respiratory symptoms, progressive lung function decline, reduced quality of life results in early mortality. Dr. Dheer pointed out that 18 to 32% of non-IPF ILD develops the progressive phenotype. This is Indian data. And again, the largest number of people said that about 16 to 30% of patients with the non-IPF ILDs would progress in real life. UIP is the most important risk factor for progression, as we pointed out in this paper. And we also said that various parameters, lung function, as Dr. Saurav Mittal pointed out, so reduction in FVC, DLCO, increasing symptoms, and HRCT scans are what should be done in defining progression in these patients. What about management? And I'll read this, I think it's important. The distinction between rapid progression and long-term indolent disease is important. The distinction between UIP pattern and other patterns of lung fibrosis is important. BAL is important. Age and comorbidity status is important. And of course, we need to take into account what the side effects of these medications are. And we talked about the side effects of systemic corticosteroids and also of the background immunosuppression in these individuals. So I showed you, Dr. Dheer showed you the SLS2 data. I show you the SLS3 data. So these are patients who are on a combination of mycophenolate and pirfenidone. And you can see early on, up to about a year, the patients who were on a combination of mycophenolate and pirfenidone did far better, but at 18 months, they evened out. If you look at the Senesis trial, which looked at, again, with patients with mycophenolate and nintedanib, so cohort of patients on nintedanib alone versus those on nintedanib and pirfenidone, there was only a small reduction of relative risk. So relative risk reduction of 40% versus a relative risk reduction of 46% is all we have. So how does this data compare? So what data do we have? This is immunomodulator data, and this is picked up from the European Respiratory Journal and includes all diseases other than scleroderma. And I won't take you through this table, there's no time, but look at the quality of data we have about immunosuppressives. They're all case series. All of these that we are talking about are case series that we have. I also found this paper from Varun, which talks about the effect of mycophenolate in interstitial lung disease with mildly impaired lung function. And he says that there is no improvement with mycophenolate in this category of patients. So this is early scleroderma, mild scleroderma, no difference. Varun was speaking about the side effects of that we have with nintedanib. Look at his paper, looking at methotrexate-related adverse effect. He says minor adverse effect, but he was very worried about 31% of patients on methotrexate having adverse events, and it's more than a nuisance, he says. What about the antifibrotic data in the last minute? So nintedanib, so you see reduction of decline of lung function, adjusted annual rate of lung function decline comes down in randomized control trials. So these are RCTs, not case series that we are talking about. And again, similarly about pirfenidone, you can see these are randomized placebo-controlled double-blind parallel group trials which show a benefit. What's on the anvil? Immunomodulator versus fibromodulatory. The red is the new drugs. And you can see the number of new drugs on the immunomodulatory arm compared to the fibromodulatory arm. You can decide for yourself where the research is aimed on. Hence, like Varun, I'm on the other side, but I'm not sure what we are debating. Of course, antifibrotics have an upper hand in CTD-ILD, and it reduces progression of fibrosis. Drugs definitely have less serious side effects compared to immunosuppression and infection, and you only have to look at Varun's data for that. But we are hospitable people from the eastern part of India. I'll give you this, Varun. In patients within the overlap zone of inflammation and fibrosis, using both judiciously is definitely an option. Thank you very much.
Thank you, Dr. Dev. Now, Dr. Varun, you can take 2 minutes to rebut.
Yeah, I think very nice presentation, but like all subspecialists do, we confuse by using semantics. The problem is that this overlap zone, which my friend Dr. Dhar has referred to, is present in 90% of the patients. And we don't see the classic UIP in CTD-ILD, except for RA-ILD, which is number 3. The most important we are dealing with is scleroderma-ILD, number 2 is myositis-ILD, and yes, some bit of RA-ILD. So actually speaking, this debate has to be about the 80 or 90% we talk about. Getting that classic exuberant honeycombing is not something which we see in our patients. So in a prototypical patient of CTD-ILD, I will reiterate that immunosuppression remains the best, right? The second issue, can I have my presentation, please? Last slide. I just make 2 other points. And the second is, this patterns is a trick by the pulmonologists to trick us, because they themselves have no, consensus. If you put pulmonologists together, it has been shown that 30% will differ. Radiologists will differ. Then you get a histopathologist in. And then you have a multidisciplinary to actually find out what pattern it is. Right? It is not that simple in CTD-ILD to say this is a classic UIP pattern and this is that. This is a very complex kind of a thing, and we are still far away from having a uniform definitions. In most of the patients, definitions change. What is known as fibrotic NSIP, lack of activity. As our friend Dr. Pilania said in the morning, what was supposed to be GGOs was supposed to be alveolitis at one time. Then we started saying, no, GGOs are fine fibrosis. So these things keep changing. This is just semantics to confuse us. What we can understand is, you have a patient of CTD-ILD who's progressing, you have fibrosis, no fibrosis, go for immunosuppression. Okay, sorry. So one other thing I want to say about what is the problem with antifibrotics. You'll use it either as a combination up front, or you'll use it sequentially when immunosuppression fails. There's a problem with both the strategies. If you have it a combination up front, which is a very, very attractive strategy, give everything to the patient, something is going to work. The problem is that, there is, you are gaining anyway FVC in most of the cases with immunosuppressive. So what are you going to get with an antifibrotic? An antifibrotic can only slow the decline. It cannot gain. So what are you gaining? The second is, if you use it sequentially, right, you failed on an immunosuppression. The problem with that strategy is these 2 cases. Like I had a case, I'll just go through them briefly because I'm out of time. So these are patients who didn't respond to cyclophosphamide, who didn't respond to mycophenolate, but they responded to rituximab. So there would be people who would give up after giving cyclophosphamide and say, nahi, ye to progressive fibrosis hai, it's not going to work. So immunosuppression is not about cyclophosphamide alone. You have multiple options which you have to go through before saying that this fibrosis is not going to respond. That's it. Thank you. Thank you very much.
So, Dr. Dhar, you have about 2 minutes.
So very quickly. So I think I saw Khushbu and Dr. Deepak Talwar frowning when Varun said that there are no good definitions for definite UIP and probable UIP. I think we have now got very good definitions. There are no confusions between, definitely between radiologists and not even between pulmonologists, and we can define these disease categories very nicely. The second, I think when you're comparing patients in SLS1 and SLS2 with patients in SLS3, you're comparing apples and oranges, Varun. The patients in SLS1, the scleroderma was much early onset. You had a lot of inflammation in those patients, whereas SLS3 are patients with progressive disease who've got a fibrotic component, and hence in SLS1 and 2, you saw an improvement in FVC, whereas in SLS3, because it's a sort of late-stage disease, progressive disease, you don't really talk about improvement of fibrosis, improvement of FVC. You're talking about sort of trying to stabilize the disease process. And again, you showed two cases. That's my point, Varun. Here we are talking about case series, we are talking about individual cases where you've made an exception rather than talking about randomized controlled trial, which is what everyone and yourself follow in day-to-day clinical practice. Thank you.
Okay, thank you. Please. Okay, Dr. Dheer and Dr. Dhar, both have got nice presentations. So, Dr. Dhir, this all of us know the CT-ILD, and in this PF-ILD phase, so this is a very aggressive phase, and fibrosis is very aggressive. So in this situation, definitely immunosuppressant doesn't work always in the same way as it was acting. So also antifibrotic that are also helpful in some way, not definitely as you have already pointed out. It doesn't stop the fibrosis, but it retards the fibrosis to some extent. So to come together in this stage, why not immunosuppressant plus antifibrotic? What is the problem if we start combinedly immunosuppressant and antifibrotic? What is the opinion of both?
You want an honest consensus statement from both.
So I think we were not giving dishonest consensus statements before also, but I'll tell you my consensus statement, and I hope Varun would agree. I think in most of the patients that we see, when there's onset of fibrosis, there's good data to show that adding in an antifibrotic, and the word adding I think is the crucial one here, adding in an antifibrotic early on actually stabilizes disease and reduces the decline of lung function. So I don't think it's either one or the other. As in any debate, I think there's a gray zone, and I completely agree, sort of outside the debate now, Varun, I completely agree that there can be no patient who doesn't go onto an immunosuppressive before going onto an antifibrotic in the CTD-ILD category at least. We actually see a lot of RA-ILD, unlike the patient cohort that you see, Varun, which is mainly scleroderma. We see a lot of patients who come to with honeycombing, with traction bronchiectasis, where the first drug that crops up in our mind is the antifibrotic. And they're normally on a steroid and an immunosuppressive anyway. So I think it's a continuum, like you have said. I don't think it's one or the other. It's more about a continuum. But I think the carry-home message from my side is start the antifibrotic early, not at the expense of the immunomodulator, but along with the immunomodulator if there's a response.
Yeah. I can't be dishonest because I don't follow this. And the problems I've told you is the same. The sequential and additive both have problems. And it's in the few rare patients that you've gone through the immunosuppression and you know that you're failing. But before that, it's difficult to add on to a patient who's already having a problem with the current set of drugs. I'm saying that if we have better antifibrotics, the current set of drugs are weak, antifibrotics are weak, and they have side effects. That is the major problem. So the tolerability is really bad in my experience, actually, but I don't use it that much. So, but yes, obviously there will be a subset. But in the vast majority, I'm saying if you have to choose whether fibrosis, whether the pulmonologist and the radiologist is saying UIP like pattern fibrotic and SIP like pattern alveolitis present, not present, close your eyes. If it is CT-ILD, patient is short of breath, having an FVC which is lower side, HRCT showing fibrosis also, immunosuppression will be the way to go. But obviously, as I totally agree, going on in a patient, that everything, you throw in everything once the patient is not improving.
Yeah. So, audience comments.
Thank you, Dr. Dhar and Dr. Varun, for your wonderful talk. Sir, you people created a big confusion among the pulmonologists, rheumatologists in this forum. Actually, the problem is now you just, both of you tell what should be the strategy for a fibrotic NIC patient in a CTD-ILD. One. Second thing, what happens, sir, when I am a pulmonologist, sir, whenever a patient is stable, till that the patient consult to the rheumatologist and they are giving the immunosuppressive drugs. But when he is little bit tachypneic, or when he is in distress, they are referring the patient to the pulmonologist. We don't have any options. If you are seeing traction bronchiectasis or honeycombing, we add antifibrotic to your armamentarium. So this is the practical issues. So to me, I think most of us practice the same standard immunosuppression along with antifibrotic in our fibrotic NIC patient in CTD-ILD. This is my estimation.
Any other comment?
Okay, I'm stuck between the two sides actually, and I will only say one thing actually.
everybody is sitting here, everybody is a teacher or perhaps a professor and head of the departments. Tell me in life, as a medicine students, have you seen ever in your life where a treatment of a condition is done before and the name of the condition is done afterwards? A disease is diagnosed and labeled after its treatment has already been proved in a trial. That's what happened. PPF was defined much later after the inbuilt trial, which showed that what should PPF be defined as. So somebody from the industry told us that how to define this disease and how to treat this disease. And look, we have already a trial data, which is, sorry, Raja. We have a trial data showing phase 3 trial inbuilt that it decreases the decline by 50% in FVC as it is done in IPF. So what is it? Is this disease driven by the pharma? Is it that what is happening? And pirfenidone is slowly in the race, but much lower, much lower. I very strongly feel PPF is totally going to go away, because what we are talking about IPF is actually not IPF. We are idiots and our patients are pathetic and we are calling them IPF because there is a cause and we are not able to find the cause. The number of IPF patients from 50% has come down to 20. In next 10 years, it will remain 2. And then we will know actually it is nothing idiopathic, only we didn't know that. So I think the scenario will change. But yes, upfront immunosuppression, more aggressive immunosuppression is the very important thing, because most of the time we miss on one thing. That is this MMF good enough, what the patient is taking? Why will I not give rituximab? Why will I not use other things to see whether they change and they can produce improvement? Actually, antifibrotics don't improve. That's the major thing. But honeycombing is something which is the most important thing which Raja brought in. That if it is there, it is a precursor. It's a precursor of something which is very bad going to happen to the patient. So be very wary of that, but rest is okay. I understand. Tolerability and everything is an issue always.
So let us have a voting. So people in favor of Dr. Dheer, please raise your hands. That is immunosuppressants. And if it is a more, okay, if both immunosuppressant plus antifibrotic, oh. So I think Dr. Dheer and Dr. Dhar both own the debate. So thank you, both of you.
Wow, this was stimulating, much more than the dose of caffeine we had earlier. Yeah, definitely. May I request our esteemed chairpersons and speakers to kindly proceed towards the felicitation area. This was definitely a strong dose of caffeine. For the next session, may I call upon Professor Dr. Jyoti Patnaik, Professor, Department of Respiratory Medicine, SCB Medical College, Professor Dr. Shrikant Kumar Dhar, Consultant Physician, SAM Ultimate, and Professor Dr. Sudarshan Puthal, HOD, Jagannath Medical College, Puri. Kindly grace the dais, sir.
Hello. So the next topic for discussion is sarcoidosis, which is a disease that was identified almost 150 years before, and to speak on this topic that is such a heterogeneous disease and is usually referred to as a chameleon because of its presentations that mimic so many other diseases. And to speak on this is Dr. Deepak Talwar, who can speak on any topic for more than 3 hours if he is given the chance. So, Dr. Talwar for...
Thank you, ma'am, and thank you, organizers, Dr. Jyoti and everybody around here. I know it's a lunch time, and I won't keep you for long, and I will definitely try to justify whatever you have come to learn here about sarcoidosis today, whatever I can, or whatever our World Sarcoid Clinic, which is VSOC Clinic on sarcoidosis in India, has to offer to clarify the doubts about diagnosis and management of lung involvement in sarcoidosis. So let's clear our mind at the moment on 3 things. When lung gets affected in sarcoidosis, it can be good, it can be bad, and it can be ugly. And she has already, Dr. Jyoti has pointed out, it's a multi-system disease. But what is this that we are talking about sarcoidosis in a way that it can be even good also? So the important things to remember is that about 10% of sarcoidosis is now recorded as hereditary. But the bad is that the pulmonary involvement occurs in more than 90% cases of sarcoidosis. We know it's a multi-system disease, but 90% the lung are going to be affected. But what the good part is that most of them will resolve in 2 to 3 years on its own or on your treatment. Only 20% will develop pulmonary fibrosis, and still worse than that is that 10% of this 20% will progress and become again that progressive pulmonary fibrosis. Okay, that I have already clarified a lot. And then only 6% of the patients will die. But the important thing is that those patients of sarcoidosis who die, 70% of them will die because of the pulmonary cause, the lung being affected. And rest of them, anybody? Rest of the sarcoid patients die of what? Cardiac sarcoidosis. There are 2 things which kill sarcoid patients, lung and cardiac, okay? And we are talking about a disease which is highly variable. So every patient who gets affected with sarcoidosis is not going to follow the same course as well as the same prognosis. So moving on, it's frequent miss or missed diagnosis. That's equally important. Not only misdiagnosis, missed diagnosis is equally important in India. Because classically acute presentations by which, rheumatologists or dermatologists will look at it and say, this is sarcoid, nothing else, is fortunately or unfortunately very rare. 30% of sarcoidosis is misdiagnosed as tuberculosis in India, and 15% of sarcoidosis is misdiagnosed as something else. And of course, very important data shows that what you diagnose as sarcoid today, on follow-up, 5% of the patients will develop tuberculosis later on. Where do we stand? Where do we stand with this kind of a data in India? We try to put clinical data, we try to put radiological data, we try to get our non-caseating or non-necrotizing granuloma into it, and then we look at it how far we can be correct in the diagnosis of sarcoidosis. It is only 3/4. So you do everything and still you reach 3/4 of the times that you are correct, and then 1/4 time, that means nearly about 20% of the times you are still wrong. What is going on? And then what do you need? And I think Dhir very rightly brought it out, when everybody is confused, call for the MDT and call everybody to put their brains into it, and let's have some consensus. And it's very good to have a consensus statement to tell us that, okay, 90%. Now people are saying it is sarcoidosis, so you reach the level of confidence in 90%. And the study from AIMS showed that this classical asymptomatic, lymphadenopathy, mediastinal lymphadenopathy occurs only in 4%. But then obviously there will be a referral bias, but by and large 10% of patients are accidentally picked up as a finding on the chest X-ray or CT scans. Sarcoidosis in the thoracic cavity can affect lung parenchyma, it can affect lymph nodes or both, or pleura or pulmonary vasculature. It can affect anything. Of course, in pleura it is supposed to be rare, but no longer that it is not reported, and there are enough number of cases. But I think the unfortunate part is that the classical presentation of what we call about lupus pernio, Hereford syndrome, Lofgren syndrome, where even the ATS recommends that no need to do a biopsy, just treat them, they are sarcoid. Very, very rare in our Indian scenarios. What do we get commonly in India? So many types of clinical presentations. Of course, one can be just accidental, finding on a chest X-ray or a CT scan. There could be just mediastinal lymphadenopathy or some nodules in the lung parenchyma even. There may be constitutional symptoms like fever, night sweats, weight loss, and fatigue. Fatigue is a very important, very difficult to treat, and very troublesome for patients when they complain of fatigue. It's very, very resistant to treatment. Respiratory symptoms are associated with parenchymal involvement like cough and sputum and dyspneas, but even chest pain can be there. And there can be extrathoracic symptoms also. Arthralgia, skin, eye, kidney, generally involved in about 8% of cases. Most of the time, chest examination does not tell us much. So we are confused with this so many things which are happening in patients with sarcoidosis, and some of them come with hypoxia. So when you see hypoxia in a sarcoid patient with pulmonary involvement, it's either pulmonary fibrosis or a sarcoid-associated pulmonary hypertension. And of course, this is a disease which is characterized by recurrences and relapses, so-called, we call them sarcoid flares. So how do we diagnose the sarcoidosis? And I think this is my conventional teaching which is going on from the PGI, and I'm going to carry on that forward forever. The diagnosis of sarcoidosis is never 100% sure. You cannot be, because you need to rule out so many diseases, and it's a retrospective diagnosis. Most of the times on day one, the level of confidence cannot be 100% to reach there. Because we have three set of inputs to make the diagnosis of sarcoidosis: biomarkers, imaging, as well as pathology. We know all pathology is that non-caseating, non-necrotizing granuloma. We have biomarkers in which we have serum ACE level, MON2 test, IGRA test, vitamin D, and calcium metabolism blood markers, or we can have even lung functions. Even on lung functions, you can get clear-cut asthmatic pattern in 20% of patients of sarcoidosis. Airway hyperresponsiveness is there. In the imaging, 20% will have normal chest X-rays. And in non-caseating granuloma, 20 causes of non-caseating granuloma needs to be excluded. And in 10% of sarcoidosis patients, you can have necrotizing granuloma. Where do you stand here? You can imagine what I'm trying to say, that the diagnosis is really very difficult upfront on day one to make it. So all the tests which are available are neither highly sensitive nor highly specific. This is the serum angiotensin converting enzyme story, which I think everybody gets it done the moment they think about sarcoidosis. But how do you utilize in your clinical practice? Have you ever made a diagnosis of sarcoidosis on the basis of serum ACE level and treated any patient? I don't think so. Anybody would have done it. We do it because it is in the protocol, but we do not look at the value. And the value is not going to be good for us because it is elevated in 30 to 80%. And look at the specificity and sensitivity varies from 20 to 50 to 90%. Like, where does it stand? Nothing. It depends upon the studies to studies. Mildly elevated up to 2 times upper limit of normal, like 100 or 120, it makes no difference. If the patient is on ACE inhibitors, no difference. It may be in some studies has been shown to correlate with PFT after treatment, but I do not know about it. Is it worth looking at it even? If it's less than 100, I think it's not even worth looking at it. Just drop it. And of course, it may be at the most a prognostic marker, and still we do not know it. And we continue to see that there is a polymorphism in the genes, that is the insertion and the deletion genes, which causes about 10% interference, and that's why it's not a good biomarker at all. Vitamin D metabolism and sarcoidosis, yes, we try to look into these parameters, but they are not specific. You can have hypercalciuria in nearly 40% of patients, but hypercalcemia in 5 to 10%. And we know it is because of the granuloma activity. And they just indicate activity of sarcoid granulomas. And of course, 125D metabolism is something which needs to be looked into because that's the precursor which comes from the cells. So it may be an initiative to biomarker to initiate the treatment or to see how far the treatment should go to stabilize it, because we all have seen patients with hypercalcemic acute kidney injury coming up because the patient of sarcoid was given calcium and vitamin D because vitamin D was low, but vitamin D 125 was never done. So that kind of mistakes are done. Anyways, imaging is equally challenging. Diagnosis on sarcoidosis on chest X-ray versus HRCT picks up much more. There's nothing, no brainer in it. So HRCT is definitely a tool to pick up for the diagnosis and monitoring. But there is so many manifestations on the radiology also. You can get these kind of various signs, you know, they have been very beautiful names to remember and very beautiful to ask the student to just corner him. But doesn't mean anything. All it means is either there are ground glass opacities, ground glass nodules, or there are multiple tree in bud appearances or beading of the nodules along the fissures, mediastinal lymph nodes and everything. But all these are actually non-fibrotic and they are reversible. The most important thing is this bronchocentric distribution of masses, destruction, bullae formation, which is permanent and it can progress. So now we have moved actually from these stages of sarcoidosis to something like, the severity of sarcoidosis, which is on fibrotic versus non-fibrotic. Because even a stage 4 sarcoidosis may be expected to live much longer than you can anticipate by looking at those CT scans. So it is fibrotic versus non-fibrotic, and that's called CT phenotype. So this is a Delphi consensus which we also worked into it and worked with Brompton. And these are the ones which clearly tells us that if you have that extreme right, then obviously it is the one which may be the one who is not going to do well, but rest all of them are going to be reversible. And then in 2012 we got EBUS, and we thought now we can actually diagnose sarcoidosis like anything. I think we were the first center in India to get EBUS in 2012. And then we were like, you can diagnose sarcoidosis. And then the data came in that still 70%, nothing great even after the EBUS. And then my friend Dheeraj published this article in 2014 in Chest, which was an eye-opener. You don't have to do EBUS alone. You do an endobronchial mucosal biopsy and combine it with a transbronchial lung biopsy to get the diagnosis of sarcoidosis with a good diagnostic level of confidence to the tune of 90%. You need to do all the things together, not just simple EBUS. And that is why it is basically the TBLB and EBB which increases the yield. Our paper also showed a cryo-EBB, if is done, it is also increasing the yield and almost reaching the level of TBLB if you want to avoid TBLB, which obviously has a risk of doing pneumothorax. So we are moving in the biopsy, lung biopsy, from a transbronchial lung biopsy to transbronchial cryo lung biopsy, so that we stop there and don't need to go for a surgical lung biopsy. In my entire career of running this sarcoid clinic, we have only 2 patients where the surgical lung biopsy was required because of the manifestations not matching as sarcoidosis. When we get a granuloma like this, you look at the causes. So many of them have to be ruled out. Tuberculosis, berylliosis, telecosis, drug-induced CVID, vasculitis, lymphoma, malignancies, so much. Some of them may not be manifest and may be occult right now and may manifest over a year or 2 years' time. And we have seen lymphomas coming up, very slowly growing lymphomas later on turning out to be the cause of this non-caseating granuloma rather than sarcoidosis. Biomarkers like lymphocytosis and CD4 and CD8 ratios, they really do not help. They cost a lot to the patient, but they do not help. There are certain others like CXCL 9, 10, 11, as well as TH17.1 cells which are under process. But again, they are more towards making the idea about the prognosis in sarcoidosis. So we have not got any which is like a biomarker which can give us a diagnosis of sarcoidosis. So we worked together with the other continents to find out that can there be a sarcoid diagnostic scoring system made. So they made it in the US and then they tried all over the other countries, and China and India also participated in it. And SDS score of 4 was having almost like 90% chances of getting fit into the diagnosis of sarcoidosis. But again, you know, in sarcoid in India becomes very, very difficult, and I don't think so it works. Then it comes to finally the PET scans. So obviously, this is where I differ from my PGI, that they don't want to yet talk about the PET scans, but actually if the PET scan costs the same as the CT scan, then why not? The question is, where it costs 5 times, there it makes a sense, but here it does not, because it does a lot of things. The 2 classical signs on PET scans which we have described is a burning lung fire or lung fire sign or a burning mediastinum sign, are the signs which tells us how much is the activity going on there. And finally, I am happy to show that this is the BTS guidelines, which is showing you where is the role of PET scan. And I think that is directly what Dheer has just spoken about, that if you have a patient of stage 4 sarcoidosis, it looks all fibrotic. So I think if Raja is there or was there, he would have said, give antifibrotics to that. Now the BTS says go for a PET scan, and if shows any activity, upscale your immunosuppression, go to 3rd line and 4th line therapies, don't start antifibrotics even at that point of time. So this is same for, I think, all other ILDs also. Before you say it is PPF, you have to be sure that there is no activity in the lung. And at the moment, we don't have any other tool but PET scan to tell us the FDG avidity there. So when it comes to management, then this is a simple thing that we treat the sarcoid for 2 things, to decrease the mortality and improve the quality of life. Because as I told you, even stage 4 sarcoidosis has only about 5 to 7% excess mortality over the baseline. So what do we need to do basically? We need to try to bring the balance where we don't overtreat and produce toxicity, and also we don't undertreat and put the patient into the danger for early mortality. That's, I think, a biggest question and difficult to answer. So this is called Wells' law. I do not know how many in rheumatology know about Wells. It is called Wells, and it is his law that you need to treat sarcoidosis if there is a threat to life or quality of life of the patient is impaired. So what is threat to life in pulmonary sarcoidosis? That's the question. And he has produced this data of clear danger signs. If your diffusion capacity is less than 40%, KCO is less than 60%, or FVC is less than 60%, then you have a clear danger that this patient is going to do bad and may die of sarcoidosis. You need to treat that patient. Also, he found out on the CT scans, and if the diameter of the pulmonary artery is more than aorta, HRCT extent is more than 20%, or if it's a stage 4 disease, they are also an indicator that this patient might need treatment more aggressively. So balancing it out, we know that we need to look at it. So any patient who has FVC of more than 70% or DLC of more than 60%, you really need to treat it only for the quality of life. Otherwise, it is the threat of life which is required. So these are the guidelines, ERS guidelines, Bogman. You can see that you have to define your patient, whether he is at low risk or at high risk for complications and early mortality. Low risk, do nothing. Actually observe. 70% of the patients only need that. In fact, the largest number of our patients of sarcoid in our sarcoid clinic are just simple observations, doing nothing, come every 6 months to 1 year, get their follow-up done and go back home. In those who have intermediate risk, recommended is glucocorticoids at the lowest possible dose. That is called the dose which is acceptable to the patient as well as the physician. And it is normally around 10 milligrams and not more than 10 milligrams. You are trying to adjust the side effects vis-a-vis good effects of steroids. But if, of course, the patients are at high risk, you need to use the corticosteroids for that. And this high risk is the group which I have already discussed to you very clearly. FVC less than 70, DLCO less than 60, HRCT showing more than 20% fibrosis, and ECO showing pulmonary arterial hypertension. So how much to steroids to give? I think after the Delphi consensus study, last year Sejal from PGI again put up his study, which showed you don't have to give 40 milligrams. 20 milligram is enough, and it is good enough to use in patients with pulmonary sarcoidosis. And of course, you reduce it to 10 milligram over 6 months' time, maintain it for 1 to 2 years, and then see if the patient is stable, you can withdraw it. When do you use alternative immunosuppressives and what are they available? Methotrexate is the first one of choice. Yes, you can use azathioprine, leflunomide as well as MMF. MMF data is little weaker because of the one study which didn't show it equally effective. But yes, we use these. When do we use? When we cannot, think of taking the steroids completely off. So that is one thing that we know that this patient has ongoing disease activity, poor quality of life. Taking out steroids is not possible. Now you want to use immunosuppressives so that you can use it as a steroid sparing agent. You want to get the patient off the steroids. Second will be when even at the low dose, there are unacceptable side effects which are just not possible. Some patients develop eye problems, osteoporosis, so many things, they cannot take steroids. You have to stop the steroids and put them onto immunosuppressives, and we generally use methotrexate. For pulmonary sarcoidosis, to the august gathering of rheumatologists, I can't say anything because they use 25, 30 milligram methotrexate, while in pulmonary sarcoidosis, even with the 10 milligrams, we are more than happy to maintain these patients on that. What if it fails? So steroids and immunosuppressives. So we have third-line drugs, infliximab and adalimumab, which are both approved for it. And for most of the reasons, for the reasons basically to cover it for the cost, we use infliximab. And adalimumab can be taken by the patient even on a OPD basis. There's no problem. But these two are there. And if even these two fail, you still have down the line what is rituximab, then JAK inhibitors, and both of them are still available in India. I do not know how many of your patients of sarcoidosis are on infliximab or adalimumab. I do not know how many you have tried rituximab or JAK inhibitors. But these are the third and the fourth line agents, and they are now approved for sarcoidosis. And this is the actually difficult problem for us, because when sarcoid patients are like suddenly, they are not doing well on line 1 and line 2, rather than putting on to antifibrotic, actually you need to go to the third line therapy. You have to give them infliximab. And they really do so well on infliximab, although the trials show use it for 1 year, but after 1 year we make it like once in 2 months rather than once in a month or once in a 1.5 month, something like that. And going on for last 5 years on infliximab and still not getting nintedanib. So I think the amount of immunosuppression which can be used is only on the basis of clinical decision making, may not be accurate even in sarcoidosis, and much more in sarcoidosis because it is much more amenable to treatment. And if you miss that boat, then obviously there will be a frankly fibrotic terminal respiratory failure. But even at that point, anti-immunosuppressives of this third line will work in those patients, because all the sarcoid flares which come, you actually just double up their steroids on what they are, they improve like anything, and then you just need to maintain it. So don't take sarcoid like other diseases. It's a disease which has got a best survival in interstitial lung diseases. So if you look at the data, ILD secondary to sarcoidosis has the best survival, longest survival in comparison to all other ILDs. And even when they look bad, they still can actually do much better with more aggressive therapies. So with that, I will thank you all, and all those of you who are interested in knowing more about sarcoidosis and granulomatous diseases. We have VASOG 2024 coming to India this year, and I'm sure many of you are coming there, and others also would be welcome to have interaction in VASOG 2024. Thank you, everyone.
As usual, sir, I know everybody that Deepak Talwar is talking means everybody will listen. You are excellent talk, sir. One thing, sir, a little bit kindly throw some light regarding monitoring tools. How to monitor the treatment response or like that, other than clinical.
Okay. So how to monitor pulmonary sarcoid patient who's been started treatment or not started treatment?
With treatment.
Sorry?
With treatment.
With treatment. Okay. So with treatment, we follow these patients not with the CT scans. We follow them with the lung functions. As I told you, the clear data is the danger signs are the lung functions here. So we monitor them with the FVC and DLCO, which we generally do at 6 months to 1 year. But sometimes if we are in a hurry to reduce the dose of steroids, then we just try to be a little more comfortable by looking at that we are not losing these lung functions for which we need to increase the dose later on. So sometimes at 3 months, but 6 months, and then annually every year we are doing for these patients. But most of the patients, once they are becoming comfortable at 10 milligrams per day, then monitoring is more for the side effects of the steroids rather than of the disease. And at that point of time, we start looking for complications of oral corticosteroid therapy to look for alternatives like immunosuppressives so that they can be steroid-sparing agents. But lung function is the most important.
Any questions from the audience?
No. Thank you.
If there are no questions, we'll wind up.
Thank you, everyone.
Thank you so much, sir. I request our esteemed chairpersons and speaker to kindly proceed towards the felicitation arena. Before proceeding, we have an announcement to make. We had a huge turnout for the quiz competition, around 25 teams. So we had to organize a preliminary quiz round, for which it will be held during the lunch break. First 15 minutes, we request the quiz participants to kindly be seated. And after the 15 minutes, after the quiz, preliminary quiz round, you can proceed for lunch. Proceeding further, for the next session, so it's not lunch. So we have 2 more. So I was just giving the announcement to prepare for the preliminary round, in case the students move ahead. So moving ahead, may I request Professor Brigadier Ambika Prasad Mahanti, Dean and Principal, KIMS Hospital, Dr. Niranjan Padhi, Senior Rheumatologist, BMC Hospital, Bhubaneswar, Dr. Damodar Bindhani, Senior Pulmonologist, Care Hospital. Sir, kindly grace the dais. So this is the last session before the lunch.
Thank you. So the next session is diffuse alveolar hemorrhage in lupus and vasculitis, optimizing the treatment for better outcome. And to speak on, we have got Professor Dr. Vinita Shobha from St. John's Medical College, Bangalore. Madam, please. She has been the former professor and HOD of the Department of Rheumatology in St. John's. She will be speaking on this is an emergency. I think people should be quite attentive to this.
Thank you very much, chairpersons. It's an honor to be here. Good afternoon, everyone. I know I'm standing between the lunch and so I will try to be as brief as possible. So I'm going to talk on only 2 aspects of diffuse alveolar hemorrhage in context of lupus and ANCA vasculitis. One is about the burden and another one is about the therapy. So I'll just start first of all with a case, a relatively simple case of 42-year-old lady without any comorbidities who presented with oral ulcers, inflammatory polyarthritis, cough, hemoptysis and dyspnea. And hemoptysis and dyspnea was only for a week. The other symptoms are much longer lasting. And she had no specific features of lupus per se. And examination was perfectly normal. Investigations revealed only mild anemia and nothing much on the other biochemical examination and on the urine analysis, but her inflammatory parameters were significantly elevated, and her chest X-ray showed bilateral patchy consolidation, which was interpreted as bilateral bronchopneumonia. Her echo, however, showed that she had a dilated LA and RA, and she also had mild to moderate MRTR, borderline elevated pulmonary hypertension, and a mild pericarditis. So now in the hospital when she was admitted, her saturation started dropping. Her room air saturation dropped to 89%, and she also started developing progressive anemia. And this is at this point we did an HRCT chest which showed ground glass opacities with interlobular septal thickening in the bilateral lung parenchyma suggestive of diffuse alveolar hemorrhage. And BAL was done which showed plenty of RBCs, hemosiderin-laden macrophages, and the culture came sterile. So at this point in time, we went ahead and did all the autoantibody workup, and ANA blot both were positive with low complements. And so we made a diagnosis of lupus with diffuse alveolar hemorrhage, myocarditis, and inflammatory polyarthritis, and she had had some urticaria. Her SLEDAI was 10. Unfortunately, diffuse alveolar hemorrhage, despite being a severe life-threatening disease, doesn't get captured in the SLE disease activity indexes. She was treated with steroids, cyclophosphamide, and hydroxychloroquine. Unfortunately, she did well. So coming to the diffuse alveolar hemorrhage in SLE, it is a rare, serious, and potentially life-threatening complication of SLE. Its prevalence is very low, 0.5 to 5.7%. It occurs early in disease course. Sometimes it can even be the first manifestation of SLE. In a systematic review, the cases which were reported in 1980 to 89, the survival rate was only 25%, which is now gradually improved to 64%, and in the last decade and a half, it is about 70%. So what it tells us is that this disease, this manifestation has a high mortality rate, emphasizing the need for timely diagnosis and appropriate initiation of therapy. Now, these initial symptoms of DH can be fairly non-specific, and sometimes they can be really abrupt as well. The manifestations are the usual cough, hemoptysis, fever, and dyspnea. But hemoptysis may be absent in about 1/3 of the patients, and it might be a drop in hemoglobin, which might point towards DH. However, even that drop in hemoglobin may not 100% reflect the severity of the condition, and it is not always matched. Some of the patients will present directly in respiratory failure requiring a ventilatory support, and pulmonary examination typically is again non-specific with just tachypnea, drop in saturation, and few occasional scattered creps. So the diagnosis of diffuse alveolar hemorrhage in the context of an immune-related disease or even in non-immune DH it has three major components. One is symptoms and signs, which I've already mentioned about. In the signs, the bronchoscopy with a bloody return, that is very important to take care of, and drop in hemoglobin, and chest imaging, which shows new diffuse infiltrates. So that is very important. Now in this busy slide, I just want to draw your attention to the relative rarity of this condition in the context of SLE. As you can see that the number of patients of diffuse alveolar hemorrhage in the majority of series are varying from 7 to 57. The largest series being recent publication from China of 94 patients by Sun et al. And the mortality is very high, which I've already mentioned. It can be as high as 62% in some series. And one of the series in USA, they showed a mortality of 86% as well. That was in children with childhood onset lupus with DH. Now, what are the risk factors for DH? Again, it is quite variable. It is thrombocytopenia, low complements, presence of lupus nephritis. In a recent series from China of 94 patients with diffuse alveolar hemorrhage, the risk factors identified were lupus nephritis, anti-SSA positivity, thrombocytopenia, and an elevated CRP. Now coming briefly, very briefly to the histopathology, there are three patterns: pulmonary capillaritis, bland pulmonary hemorrhage, and diffuse alveolar damage. And for us, clinical immunologists and rheumatologists, it is the pulmonary capillaritis which we are interested in. And this is what we find if we do a pathology of these patients or do a lung biopsy. There is neutrophilic capillaritis with destruction of the alveolar septae with a resultant disruption of alveolar capillary basement membrane. And this is mediated again by as lupus is characterized by the immune complex deposition, the same are deposited in the alveolar capillary wall, leading to pulmonary capillaritis and alveolar hemorrhage. Sometimes on histopathology, we can also see small vessel thrombosis. There can also be features of organizing pneumonia and type 2 alveolar epithelial cell hyperplasia. Now coming directly to the treatment of diffuse alveolar hemorrhage, the supportive treatment is of course extremely important. Correction of hemodynamic status, transfusion, ventilatory support, including high PEEP and ECMO. if required, and the immunosuppressive therapy consists of cyclophosphamide, glucocorticoids and cyclophosphamide in majority of the situations. Plasmapheresis is used to remove the autoantibodies, and very important to remember the infections which may coexist in these patients to treat them with antibiotics and antivirals. Now, what do we know about the corticosteroids and diffuse alveolar hemorrhage? We all use glucocorticoids high dose, and there is no evidence for the dose of the glucocorticoids, but we accept it as a mainstay of therapy. The dose varies from 500 to 2 grams per day in different series, and most of the times it's given for about 3 to 5 days. These studies which have tried to investigate the dose effect of glucocorticoids for DH have suggested overall mortality does not differ based on the dose of glucocorticoids. So it might be worthwhile using a lower dose rather than a higher dose, even in the context of diffuse alveolar hemorrhage. When we talk about cyclophosphamide, again, the data is quite sparse, and there are studies which have shown that cyclophosphamide has a tendency for better survival even after adjusting for the degree of severity of the lupus as measured by SLEDAI 2K or acute kidney injury. So in this study by Sun et al., they have shown that the survival was much better in patients who received cyclophosphamide versus the ones who did not receive cyclophosphamide. Now coming to the plasmapheresis, it is used as an adjunct therapy in taking the cue from the anti-GBM disease, both for ANCA vasculitis as well as for lupus-associated DH. And it is usually, the classical protocol is 7 cycles of Plex over 14 days. The retrospective studies have reported excellent patient outcome and safety. However, the long-term follow-up data has not really been supportive for treatment of DH in lupus. So in this systematic review of DH in patients with lupus, they were this was a publication about 10 years back when they looked at 174 DH episodes representing 140 patients, and almost everybody had received corticosteroids. 55% of the patients had received cyclophosphamide and plasmapheresis in about 1/3, but it did not appear to be associated with survival. And if we see the newer drugs like rituximab and mycophenolate have also been used for treatment of DH, but the reports are typically in terms of case reports or case series, and there are no large RCTs to guide us as to which is the best immunosuppressant. So for me, cyclophosphamide is our mainstay of therapy for DH in context of SLE. And one should not forget infections because they either cause or contribute to mortality in about a quarter of episodes. So what are the risk factors for mortality? Older age at diagnosis, longer lupus disease duration, concurrent infection. And plasmapheresis is shown to have a poorer survival, but probably it is because that severe disease patients would have anyway required plasmapheresis or mechanical ventilation, and they may not really be associated with poor outcome. This is the Indian study from NIMS, Hyderabad, wherein they looked at the patients of 1,828 SLE patients for 10 years between 2008 to 2017, and they found 24 cases of DH. All I want to say is that in our country, the last line here, that 50% of these patients died. Despite the optimized treatment, all patients had received methylpred. 20 out of 24 had received cyclophosphamide, IVIG in 4, but despite all of these efforts, the mortality rate was very high of 50%. Now moving on to the second case quickly, which is ANCA vasculitis. Again here patient presented with cough, hemoptysis, breathlessness, and a drop in saturation. And here we find that the patient had severe anemia, a high creat, and an active urinary sediment. And the CT chest showed features of diffuse alveolar hemorrhage, and the P-ANCA was positive even though PR3 and MPO both were negative. The BAL here again showed hemosiderin-laden macrophages. So with the diagnosis of ANCA vasculitis with DH and nephritis, the patient was ventilated, given antibiotics, methylpred, plasmapheresis, and followed by IV cyclophosphamide protocol. So we know that a DH can occur in GPA. It occurs in about 5 to 15% of patients. It might be an initial manifestation or an exacerbation of a previously existing case. In microscopic polyangiitis, it occurs in much higher number of patients, about 1/3. And immunosuppressive therapy for DH and ANCA vasculitis is also, there is not much evidence. We use glucocorticoids and we use steroid sparing with cyclophosphamide and rituximab. The rituximab is being increasingly used in this context, extrapolated from the trials of rituximab in ANCA vasculitis for both remission induction as well as for maintenance. The current guidelines for ANCA vasculitis actually do not speak much about specifically about DH and consider it as one of the categories in the severe disease. So we all know about the MEPEX trial, which had shown that there was a benefit of PLEX in patients with severe renal vasculitis, and taking a cue from that, in 20 DH patients, there was a report of PLEX being useful. However, the long-term data from MEPEX showed that there was no survival advantage of PLEX in terms of death and end-stage renal disease. However, the American Society for Apheresis recommends plasmapheresis in ANCA vasculitis patients with DH who present with hypoxemic respiratory failure requiring either high-flow supplemental oxygen or mechanical ventilation. So if you look at the PEXIVA study, which is one of the trials which has looked at PLEX in the context of ANCA vasculitis, in this we know that the patients were a subset of patients who had DH in this study, and they were categorized as no DH, non-severe DH, and severe DH. Out of 704 patients, there were 191 patients had DH, out of which 61 were severe. And when we look at the treatment results, let's focus on the last two lines here. That is the severe DH who underwent PLEX, that is the second lower one, and the lower one is a severe DH no PLEX. So as we can see the distance between these two lines, it tells us that severe DH PLEX might have a role, though it did not reach statistical significance. So this has been published recently. This is a sub-study from the PEXIVA's trial. So the EULAR, the 2021 guidelines, says that recommends against adding plasma exchange to remission induction therapies, largely because of this study. And plasma exchange is still considered an option only in patients who are not responding to recommended remission induction therapies. So lastly, coming to avacopan in ANCA vasculitis DH, we all know the ADVOCATE trial wherein C5a inhibitor has been shown to reduce the glucocorticoid exposure and improve the renal outcomes. In a retrospective analysis from the Mayo Clinic, wherein they looked at their data of ANCA vasculitis patients with DH over 2 years, and they found 10 patients who had received, who had DH and had received avacopan. And in this, they demonstrated at a median follow-up of 12 weeks that 90% of the patients achieved remission and 4 were having BWAS 0. So that tells us that this avacopan may have a role in treatment of DH in ANCA vasculitis, and importantly, all of these patients were also off prednisolone at a median follow-up of 12 weeks. In this study, they did not find any relapses or recurrences of DH, and they did not encounter any serious adverse events also, but this is a retrospective analysis, so it has to be taken with a pinch of salt. What is the Indian data of ANCA vasculitis from India? This is a ACR abstract which was published last year from Dr. Aman's group at PGI Chandigarh. And herein they have used remission induction agents, glucocorticoids in 100%, cyclophosphamide in about 62%, rituximab in about 1/3, and PLEX in 5 patients. And the outcome here is relatively better than what we saw in lupus DH. Here the outcome, the death was in about 11 patients, which is about 22%. So the other therapies play a very important role too in terms of maintaining a platelet count of at least above 50,000 and maintaining, treating coagulopathy if it is required. And antifibrinolytics, tranexamic acid and ECA have been used for treatment of as an add-on therapy in patients with diffuse alveolar hemorrhage, and so has been factor 7A with variable success rate. So to sum up here, what we can say is that DH occurs uncommonly in SLE, more commonly in ANCA vasculitis, but with much poorer outcomes. There are no RCTs to guide us regarding the treatment of DH, and we basically learn from the other components of the disease process to guide our treatment. And a case-to-case therapeutic decision is what can take us forwards. Thank you very much.
excellent presentations. So those who are intensivists, I think in ICU, this is the most challenging part, how to initiate the treatment, whether bronchoalveolar lavage along with plasmapheresis or both simultaneously. Because we know this is the patient very crucial state, you have to take initiative. So which should be aggressive?
So we have to first exclude because the diagnosis may not be evident in the first case. So we have first presentation. We have to rule out infections, support the patient in terms of blood transfusion, platelets, correction of coagulopathy. And if they require mechanical ventilation, go for that. And I usually prefer first to go for glucocorticoids, a methylpred pulse, which is helpful. And then subsequently, based on the response to therapy, the initial glucocorticoid therapy, we decide on the next step.
Now, lavage along with plasmapheresis, both can be better outcome.
So there is only one study from Singapore in which they looked at in lupus, and they gave glucocorticoids, rituximab, and cyclophosphamide triple therapy, and they showed 100% success rate in therapy. So plasmapheresis is of course useful, but it has its own problems in terms of causing hypotension and need for, and there is an increased risk of infection with plasmapheresis. So for me, plasmapheresis is not the first line treatment.
Any question from
Sir,
audience?
yes, sir. Thank you, madam, for your nice presentation. Madam, we learned a lot about this. Actually, since last 1 year, we have received 3 cases of SLE with diffuse alveolar hemorrhage, rightly pointed out by Bindani, sir. That is very difficult to manage. The 2-3 things, 3% what we saw, there is an infection, there is a AKI. So the problem is giving the high dose of steroid was challenging for us. And we have started dialysis and immunosuppression, we cannot start those group of patients. And so finally, they succumbed all of 3 because of these multiple issues. One thing. Second thing, madam, what should be the duration of the pulse steroid therapy, whether it's 3 days or 5 days, what protocol should we follow? And what we will do if there is an infection, and what modality of treatment should be given to this group of patients. Besides the ICU support, we have intubated, we have ventilated, we have given fluid therapy, antibiotics, everything. This is the real challenge for us.
Thank you very much for these questions, very interesting questions. So duration of glucocorticoids, the shorter the better is what we consider at the moment. So there was a time when we used to give 1 gram pulse of methylpred. Now we are coming down to 500. Some people are even coming down to 250. So maybe you can give glucocorticoids in a particular dose, 250 or 500 milligram methylpred pulse, and observe day to day the improvement, the condition of the patient, and then take a call whether to escalate it or whether to come down on the steroid therapy. If there is a coexisting infection, it is a very, very difficult situation. And I have personally used IVIG in this situation to combat, to cover up the time, to support the patient so that we can take care of, we can give time for the antibiotics or antivirals to act while we are controlling the inflammation.
So IVIG is the...
Is something which I have used, but the studies are not really pointing towards that.
Any other questions? Ma'am, I have got a question. Patient presenting primarily as a DH, not even any test has been done. Patient presented with DH. Can you give an opinion whether fall in hemoglobin is an indication for SLE or not?
What is the indication?
Fall in hemoglobin.
Fall in hemoglobin.
Is it an important factor that when you don't have any test, patient presented with DH, primarily presented with DH without any test?
So I think we need to consider here the drop in hemoglobin. There could be several causes, and instead of considering DH as a first cause, I think we have to consider other conditions like autoimmune hemolytic anemia, which is far more common in SLE than diffuse alveolar hemorrhage. So if a patient has respiratory symptoms and has a drop in hemoglobin and a suggestive CT finding, and you find on bronchoscopy that there is a bloody return, that is a situation when we have to consider DH.
Okay.
Thank you, madam. The last thing, can we predict that so and so patient is going to the diffuse? Once it happens, mortality is very high. Mechanical ventilation is just to buy time, maybe some drugs can act. Can it be predicted that in the study that this patient is having a predisposition for diffuse alveolar?
So there have been efforts to look at the predictor, sir, but because as you can see that the number of patients in each study is very small, so it has varied across different series. But thrombocytopenia has been one of the predictors. So has been low complements and presence of lupus nephritis. In one study, they even found that presence of neuropsychiatric lupus was a not a predictor. These are associations. They are not really predictors. So because the number of patients are so small, we don't have an accurate, algorithm or a prediction of diffuse alveolar hemorrhage.
Thank you, madam. I think we'll all agree this is an emergency. The cases I have seen, all of them have died. Some of the time we discuss only in the CP scene from PGI only, the patient dies of diffuse alveolar hemorrhage. Thank you so much, madam. Thank you.
Thank you very much.
Now I request all our chairperson and the speaker to move to the felicitation arena. So there are very important announcements actually. So the most awaited event, that is our international speaker, his session will start sharp at 3 o'clock. So we'll join here by 3 o'clock. Number 2 is because there is huge turnout for this quiz. So we are having a quiz prelims. So all those who are participating, 25 teams, they are supposed to be here for next 15 minutes. Number 3 is, so we will have a very quick short launch. Number 3 is those who have already appeared those who are appearing for poster presentation, please be with us. You will be given time for lunch, don't worry. And next, the faculties are requested to go upstairs and all other delegates to go downstairs so that we can have a quick lunch and we can come back and join in time. Thank you very much. So those who are participating in the quiz, please come forward.
Hi, good afternoon. This is a note. Come up please to the front. We're going to do this as quickly as possible. You're done. You can break for lunch and then come back for the post-lunch sessions. Please come forward. Forward, more. Come forward, guys. It's going to be faster. It's going to be easier to distribute the mark sheets. The way we'll do this is, I'm going to distribute the question papers. These are all MCQ for the prelims. So space out ideally. We're going to collect your papers at the end of 15 minutes. Yeah. Space out, guys, because if we see you guys sharing answers, I'm going to disqualify both the teams, which means you're not going to get the amazing Amazon gift vouchers planned for you today. Also, just a quick set of background rules for the prelims. Please write your teammate names and the name of your college, so that when we are calling out the 4 people who have been selected, the 4 teams, there's no mistake on our behalf, okay? So write down your college name, write down your team member names clearly on top when I'm distributing these. We are going to give you guys 15 minutes. If anyone is seen fiddling with their phone, they are going to be disqualified, no questions asked. There are prizes to be given out, so please ensure fairness for all. Come to the front quickly from behind. Guys who are sitting at the back, if you're quiz participants, come to the front. We're going to start distributing immediately.
There should be nobody else in the hall other than the ones who are participating in the quiz. So anybody who is not participating, please leave the hall right now. So you'll have 15 minutes. Please don't take out your phones. Keep them in your pockets. If we see any phone in anybody's hand, we'll disqualify the team. Very clear. just for the marking, there is a +4, -1 for every wrong answer, +4 for correct answer, -1 for wrong answer. And there are some star marked questions which are like tiebreakers in case we have a problem.
start coming to you guys to take the papers. Just make sure you have your team member names and the name of your college written on top of the answer sheet. We shall start collecting the answer sheets now, and the top 4 teams are going to go to the mains. That will be announced after the post-lunch session, all right?
All those who will participate in the poster presentation can stand with your poster. Our judges are already, they will come. Otherwise, you can have a quick lunch and come back. But those who are interested to appear in the exam first, then food, so they can stand actually. Good afternoon. So just as we have finished the lunch, I'll request only the poster participant with the judges. They can continue with their work in a very lower volume. Like the rest of the people can sit and we can start the next session. And to chair this session, I'll call upon Professor Dr. Manoranjan Das sir, who is the head of the Department of Respiratory Medicine from SC Medical College, Cuttack. And another Manoranjan sir, Professor Dr. Manoranjan Behra sir, from Medicine Department. Manoranjan sir is here. Sir. And Dr. Ranjan Gupta, our scientific chairman, he can join. So the next session is going to be a virtual session because Professor Rohit Agrawal had some emergencies for which he couldn't come. But so I think if anybody has any questions, they can write it in paper and give it to us so that at least we can get an answer from him and we'll mail you back. You can introduce.
Very good afternoon. Wonderful lunch by organizing team. Thank you, Dr. Jyoti, for the hosting this session. And for the next session, we are having Professor Dr. Rohit Agrawal, who is a professor, Department of Medicine, University of Pittsburgh, Medical Director, Arthritis and Autoimmune Center. He has lots of designation. He is the past chair of the Medical Advisory Board, Myositis Association, leaders in disease criteria and outcomes of myositis, established independent clinical investigation, significant funding from NIH, extremely high publication record, a great stalwart. So I request Professor Dr. Rohit Agrawal to carry forward his talk.
Hello everyone, my name is Rohit Agrawal. I'm a professor of medicine, a rheumatologist in University of Pittsburgh, USA. First of all, I would like to thank the organizers for inviting me to present this talk on dynamic landscape of ILD in myositis. We'll talk about emerging patterns and treatments in myositis ILD. I'm sorry I could not be with you today. I would have loved to be in person there or online and interact with you, but because of the vacation, I had to record the lecture and send. Would love to interact with my colleagues in India in future. So let's get started. First of all, I want to talk about overall risk of myositis associated ILD. If you look at all the CTDs and look at the frequency of ILD in all the CTDs, you see there are, it's given on the chart here, myositis, polymyositis and dermatomyositis, anywhere between 30 to 40% of all myositis have ILD. But if you look at a subset of anti-synthetase syndrome, it has the highest prevalence of ILD amongst all connective tissue disease. And anti-synthetase syndrome is considered part of myositis. We pay a lot of attention in systemic sclerosis and MCTD about ILD, but I think we need to pay a lot of emphasis on myositis ILD in near future. Because myositis ILD is the #1 cause of mortality and morbidity in myositis. My patients don't die of myositis or skin disease or muscle weakness, but they die of interstitial lung disease. And also, in terms of the prevalence, if you look at overall prevalence of myositis ILD, it really almost mirrors systemic sclerosis and perhaps mixed connective tissue disease. So I think in terms of the numbers, in terms of the prevalence, incidence, the percentage of patients with ILD, we need to start paying and identifying myositis associated ILD with a lot more rigor. And I hope this lecture will help stimulate the discussion on myositis ILD. Now, if you look at the survival curves of myositis ILD and compare that to IPAF or other CTD ILD, fortunately, you will see that myositis ILD does the best. So the top line, the best survival curve is of myositis ILD, closely followed by IPAF with myositis specific antibody. I would argue it should not be called IPAF, it should be called myositis ILD. Anybody with clinical myositis or a myositis specific antibody with ILD is myositis ILD for me. And it needs to be treated with the right immune suppressive drugs, and outcomes are going to be very rewarding if you aggressively treat these patients with immune suppressive drug. The problem happens is many times I feel like then myositis clinically is not there. The rheumatologist is not entertaining that patient, which is wrong. I think if the patient has ILD with myositis specific antibody, both rheumatologists and pulmonologists should work together to find the best solution or best treatment for the patients. Next, I'm showing you a Venn diagram of various myositis autoantibodies. Now, this Venn diagram is divided into 4 major clinical subtypes of myositis. One is dermatomyositis or DM, polymyositis or PM, necrotizing myopathy or NM, and CTD or overlap myositis. But within these 4 major clinical subsets, you have these autoantibody subsets or bubbles. Each one represent a unique clinical phenotype within myositis. Now, when we divide myositis into this type of autoantibody-driven subsets, what we identify is 3 major subsets in which ILD is the most common or most problematic. The most important subset perhaps will be antisynthetase syndrome, just because 85% of those patients will have ILD. The second most common, most important would be anti-MDF5 antibody subset, in which the ILD frequency may vary depending on the region of the world. In Western world, the frequencies are about 30 to 50%. In Eastern world, in Asia, China, Japan, the frequencies are as high as 70 to 80% of ILD. Nevertheless, it's still important because they have rapidly progressive ILD. And then the last but not the least is overlap antibodies like PMSCL, U1RNP, CHO. They all have, and Rho52, they all have higher frequency of ILD than other myositis. So if we pick these 3 antibodies as our main driving factor or identifying factor who could develop interstitial lung disease, it will be really helpful. Because when we look at the frequencies of ILD in JO1 and non-JO1 antisynthetase syndrome, we find 73% of JO1 has ILD and 81% of non-JO1 have clinical ILD. Now, some more patients have subclinical ILD. In Western world, anti-MDF5, at least 50% of have ILD, and overlap antibodies, anywhere between 40 to 70% of these have ILD. If you just look at these 3 autoantibodies, they will represent about 80 to 90% of all myositis associated ILD. So this is the power of autoantibody. Just by autoantibody testing, you can actually predict, almost prognosticate a patient that who is high likelihood or high risk to develop ILD, and perhaps that patient needs to be aggressively monitored. In other way, if a pulmonologist is seeing a patient and they have ILD and they may have no clinical finding of myositis at that point, but perhaps they should order these antibodies at the minimum to identify high-risk patients who could have underlying myositis ILD. The reason is if they have MSA, the treatment algorithms are going to be very different than if they don't have myositis-specific antibody or MSAs. Now, what are the types of ILD? What are the pathogenic types of ILD in myositis? I would argue that myositis have the most diverse type or subsets of ILD. It has very commonly a UIP, most commonly a NSIP, but problematic subsets like diffuse alveolar damage or AIP, as well as cryptogenic organizing pneumonia or just organizing pneumonia are the 4 patterns of ILD seen in myositis. This is more diverse than any other CTD ILDs that we see.
Hello, Professor Rohit, it's not audible. Not visible also, sir.
Now, if you look at the overall clinical patterns of myositis ILD, you see 2 different worlds. You see regular chronic ILD, which could be stable, but in 30 to 40% of patients, it's generally slowly progressive, and that's a pattern we see in anti-synthetase syndrome and overlap antibodies. Whereas on the other side, the more severe pattern of rapidly progressive ILD is seen in patients with anti-MDA5 antibodies or even without anti-MDA5 antibody with clinically myopathic dermatomyositis. You can see that pattern. What's the difference in the pattern? What is rapidly progressive ILD? We define rapidly progressive ILD as someone who has a symptom onset of cough or dyspnea, from symptom onset to either requiring oxygenation, hospitalization, intubation, or death within 3 months. That's how rapidly progressive. It's like having COVID. Very lot of similarities have been drawn between anti-MDA5 antibody disease and COVID ILD. Or COVID lung disease. Now, on the progressive side is a traditional, slowly progressive disease that we see, similar to what you will see in, let's say, scleroderma or other CTD ILDs. But I would argue that myositis ILD has a little faster pattern progression and also have a better response to treatment or immune suppression than other CTD ILDs. Another very important aspect to understand is that anti-synthetase ILD or typically myositis ILD improves. Their CT scan improves, the so-called fibrosis that should not improve improves. The patient's FVC improves, patients who come on oxygen can go off oxygen. That's something we don't typically see in scleroderma and other CTD ILDs like RA-ILDs. But in myositis ILD, if a patient is recognized early and appropriately treated, you can see very good outcomes. However, on the flip side, if the early diagnosis and management is missed and you see the patient in ICU or in hospital admission where the patient is presenting with acute respiratory failure, even this good subset of anti-synthetase syndrome has a mortality of about 30%. And anti-MDA5 probably at that point has a mortality of about 80 to 90%. So it's really important in myositis ILD for pulmonologists and rheumatologists, when do you diagnose ILD? Do you diagnose it early when the patient comes and sees you for the first or the second time in the clinic, or you diagnose when the patient is admitted to the hospital with acute respiratory failure? And that's a huge difference in mortality and morbidity, because if you see the patient in clinic and you start immune suppression, many of these patients will respond. Another important lesson for a pulmonologist here is that many patients who come in with acute respiratory failure in ICU or hospital, you will not be able to recognize any clinical feature of CTD or myositis. As you can see, about 30 to 40% patients would have muscular joint or skin involvement, and most would have no extramuscular feature at all. Many would not have any extramuscular feature at all. So you really need to rely on autoantibody testing to properly diagnose these patients in a timely fashion. So the next part of my talk, I'm going to talk about the upcoming treatments. So there recently, 2003, we published the ACR guidelines on treatment of ILD in patients with SARS or systemic autoimmune rheumatic disease. And if you pay attention to the myositis cohort, which is the second in number or column, you see the initial treatments are mycophenolate, rituximab, or calcineurin inhibitor, which are tacrolimus and cyclosporin. Now, in very mild cases, perhaps you could use azathioprine, but we generally go for mycophenolate, rituximab, or tacrolimus. Now, in additional treatment option would include JAK inhibitor like tofacitinib as well as cyclophosphamide, and short-term glucocorticoids are very helpful initially. So that's the treatment guidelines that have been put together by ACR, and I was fortunate enough to be part of that guideline. Now, when you look at that's initial treatment, but what happens when patients are progressive despite initial ILD treatment? In that case, you can either add or switch therapy. And in myositis, you can add or switch mycophenolate, rituximab, tacrolimus, nintedanib, cyclophosphamide, IVIG, and JAK inhibitors. And there's also a recommendation against using high dose of long-term glucocorticoid, because high dose of long-term glucocorticoid do more harm than good to our patients. And also consider patient for early referral for lung transplant, because many of these progressive disease patients are younger patients who could benefit from lung transplant. At least in Western world, if somebody is progressing after first or second line treatment, they get referred to lung transplant very early in their disease course, even if they not yet be ready for lung transplant, because lung transplant evaluation takes quite a lot of time. Now, recently, there was a systematic literature review and meta-analysis published on myositis ILD. It is important to highlight that there are no randomized controlled trial on myositis ILD yet. But they still reviewed about 225 patients of rapidly progressive ILD of 16 studies and 300 patients on chronic progressive ILD in 15 studies. Only 2 of them were prospective. So really, we need to do a better job in studying myositis ILD in a prospective study as well as in randomized controlled trials. Now, when we look at those outcomes, we look at the corticosteroid as the treatment, and it is clear that corticosteroid is still the mainstay of treatment in myositis ILD with positive outcomes. However, the challenge with corticosteroid remains the disease flares up when we taper the steroid. Patient may worsen even on continuation of steroid, and also steroid toxicity, cumulative steroid toxicity is a huge problem. So we typically start at a high dose, but nowadays we rapidly taper to about 10 milligrams or so, and then slowly taper to 5, and then slowly take them off. It takes us about a year, but from 60 to 10 we get in within few months. Now, what about mycophenolate as a first-line treatment? There's emerging evidence that mycophenolate perhaps should also be first-line treatment for myositis ILD, similar to scleroderma ILD. When we start mycophenolate, there are clear shifts in FVCs in our patients, and there's clear decline in steroid use after starting mycophenolate. What about tacrolimus? Tacrolimus has been used, at least in our centers, for more than 20 years now, 30 years, where we published long time ago, Dr. Otis published this 13 refractory patient of antisynthetase syndrome who improved on adding tacrolimus. And a lot of Japanese and Chinese literature suggests that tacrolimus, early addition of tacrolimus is superior than a stepwise approach where you do first steroid, then next treatment, then next treatment. What about rituximab? Again, a lot of evidence. I'm sure you have a lot of clinical evidence to suggest that rituximab works in myositis ILD. I'm just showing you one of the retrospective study where FVC improved significantly, DLCO improved significantly, overall outcomes improved significantly after adding rituximab on patients with myositis ILD who were previously refractory to other treatment. But there's one catch on rituximab is when we look at the RIM trial, rituximab in myositis trial, it is clear to us that rituximab is a far more responsive or far more efficacious when the patient has an antibody, specifically if they have antisynthetase antibody, but also if they have other myositis specific antibody. But if they don't have any myositis specific antibody, rituximab tends to work less. So I favor rituximab more in patients with autoantibody positive disease. Cyclophosphamide, we've been using cyclophosphamide for a long time. Many of you probably have a lot of experience with cyclophosphamide, and it works, clearly works. This is a prospective study, open label though, in which 82% patient improved in their CT scores as well as in their vital capacity. So again, a lot of evidence that cyclophosphamide work. Why do we shy away from cyclophosphamide? Mostly because of the toxicity issues. I don't need to teach you what are the toxicity of cyclophosphamide, but continuous long-term cyclophosphamide has significant cumulative toxicity. But short-term, monthly cyclophosphamide for 6 months or every 2-week regimen perhaps is better tolerated and should be considered when patients are not responding to rituximab. Now, what about rituximab versus cyclophosphamide? Which one is better? Which one would you use first? This is answered by a recital trial where they compared rituximab with cyclophosphamide in patients with CTD-ILD, where they added systemic sclerosis, mixed connective tissue disease, myositis, and myositis patients, 45% patients were myositis. So it's quite a generalizable result. And cyclophosphamide and rituximab were quite similar, with slightly more side effects with cyclophosphamide. So my take-home message from here is that perhaps use rituximab first, and then if that's not working, add cyclophosphamide or replace by cyclophosphamide. In some more severe cases, we tend to add cyclophosphamide. Now, shifting gears from chronic progressive ILD, what about rapidly progressive ILD? What do you do when the patient has rapidly progressive ILD? First of all the evidence we have on rapidly progressive ILD is on your slide until 2019. Now, if you look at 10-15 studies done, the outcome of response was considered as survival in 3 months. So you see the bar is very low. If you survive at 3 months, that's a positive outcome in rapidly progressive ILD. And this was addressed by ACR guidelines on ILD with SARTs, in which the main question here is there a suspicion of anti-NDF5 antibody disease, or is there a suspicion of rapidly progressive severe disease? If the answer is yes, then pulmonologists, rheumatologists should consider to admit the patient, give high dose of IV glucocorticoid followed by 1 milligram per kilogram steroids with slow taper up till 10 milligram, then further slow till 5 milligram, and then trying to take them off. But in addition, add 2 of the following treatment: rituximab, cyclophosphamide, IVIG, calcineurin inhibitor, and JAK inhibitor. Now, many combinations have come up. First, we read about cyclophosphamide and calcineurin inhibitors. So, IV steroid, cyclophosphamide plus tacrolimus. Then, we have personally used rituximab plus cyclophosphamide. Then, there are regimens of IVIG plus JAK inhibitors. There are also regimens of combining rituximab with JAK inhibitors or combining cyclophosphamide with JAK inhibitors. So there are various different permutations and combinations that we can use, but the bottom line is to be aggressive, diagnose early, treat early, be aggressive early in these severe patients. The evidence for triple therapy, which is IV steroid, tacrolimus, and IV cyclophosphamide, is clear. Combined immune suppression in this survival curve was far superior than historical step-up immune suppressive therapy, where you first start steroid, then it's not working, add tacrolimus, then it's not working, add cyclophosphamide. Far superior to that is we starting upfront aggressive treatment, specifically in patients with rapidly progressive ILD on anti-MDF5 antibody positive disease. Now, what about rituximab in rapidly progressive ILD? Again, there is very small evidence, and these are retrospective comparative study with all the caveats of a retrospective comparison. But anyway, rituximab group was better than non-rituximab groups with either cyclophosphamide alone or cyclophosphamide with other treatment. What about IVIG in rapidly progressive? Again, retrospective comparative study has its own problems, but whatever it's worth, IVIG group was better than non-IVIG group. Plasmapheresis. We use IVIG and plasmapheresis early as a salvage therapy. We use it early because they can, when patient is rapidly worsening, they can really help us to buy the time for a week or 2 weeks or a month, and that may stabilize the patient. So plasmapheresis is used for that reason as well in rapidly progressive ILD. Again, very small comparative retrospective studies suggest that clearly it helps. At least there is evidence that it helps. Now, tofacitinib came on the scene several years ago with this NEJM article in which the doctors used tofacitinib upfront. As soon as the patient is diagnosed with ILD, they started tofacitinib. It's an open label study of 18 patients. And if you compare that to historical controls, tofacitinib was far superior because it has 100% survival. Now, it's only 6 months, but remember, this is anti-MDF5 disease. So even 6 month count in anti-MDF5 disease. All of these patients were also on steroid, but still remarkable to have tofacitinib plus steroid have no mortality in 6 months as compared to historical control where there was about 20 to 30% mortality. Now, what about ECMO? Well, we recommend to use ECMO if you have a lung transplant in sight. So, in other words, if you know that the patient may get a lung transplant, there's value in ECMO. But if you're using ECMO just to bypass the time and there's no hope of lung transplant or transferring a patient to a bigger center or different center, then 8 out of 9 of those patients would die because of not offering lung transplant. So ECMO is great, but as a bridge to lung transplant. And as a reminder to our pulmonologists, sometimes patients will have rapidly progressive ILD without any clinical manifestation of CTD. This is an example of rapidly progressive ILD with anti-MDF5 antibody, but no rash was detected in this patient. Now, nintedanib, all of you know, has been used in inbuilt trial, which has been it's been FDA approved for progressive ILD, including scleroderma ILD, and also perhaps should be used in myositis ILD. But what we find is it's not commonly used in myositis ILD. But I will have you pay attention to this study from China, where the patients were compared if they got a nintedanib in red line, in conventional therapy without nintedanib in red line, and those who got nintedanib therapy on the blue line. And they showed clear survival difference on adding nintedanib. And nintedanib, anti-MDF5, and overall disease activity were as associated with survival. So what they showed is perhaps we can change the survival as well if we add nintedanib early in our patients. So when to add antifibrotic on immune suppressive drug? And that's a very complicated question. A lot of people will use the evidence that I just showed and say we should add it early. A lot of people will be hesitant and say, look, many patients do get better with simple immune suppressive therapy, and perhaps we should add when you're not getting the response that you need. We put together a nice article that kind of has a nice flow chart to when to consider adding antifibrotic, and I would have you consider reading that article. Now, this is my summary. This may not be applicable to everybody, but this is my summary how I think about treating myositis ILD. If you have a mild to moderate disease, I could give oral steroid for a mild disease or admit them for 3 days and give them pulse and then followed by oral steroid. Or if you have a severe progressive ILD, then we can give IV steroid plus rituximab and or cyclophosphamide plus minus IVIG. This is what I do. Now, if the patient stabilizes, you convert them to a maintenance treatment of mycophenolate in moderate to more severe disease or tacrolimus. If you fail, then use more heavier gun of combination immune suppression like rituximab plus cyclophosphamide, mycophenolate plus tacrolimus, cyclophosphamide plus tacrolimus, and consider ECMO for transplant. Few drugs to consider here would be tofacitinib, abatacept, as well as nintedanib. So in conclusion, recognize myositis early and at-risk patient using myositis autoantibodies. These are anti-synthetase, anti-MDF5, and overlap antibodies. They have high frequency of ILD leading to poor outcomes. Consider, are you dealing with a rapidly progressive ILD or are you dealing with more chronic progressive ILD, and your treatment might differ in two. Many treatment options available and novel treatments are coming up, but there is no great data to suggest the treatment guidelines. Even the ACR guidelines were done almost without much clinical evidence. So we need randomized controlled trial, we need prospective study, and I think Indian rheumatologists and pulmonologists can be a great help in leading that. The role of antifibrotic again needs further clarification. With that, I want to thank you from Pittsburgh Myositis Center, and I will be happy to receive any emails or any feedback on the talk or in general how to promote studies in India and collaborate from US and India. Last but not the least, I'm going to have you pay attention and request if my esteemed rheumatologists and pulmonologists in this group who are interested in myositis perhaps should join this organization called Myositis India. It's doing a great work for patients in India. It's a free organization and it's working for patients, answering patients' questions, helping them, connecting them to the right doctors, even doing doctors webinar, patients webinar. So my humble request is we can only grow if you join the organization. We are doing every other month a webinar for doctors as well. So that's just my plug in the end to consider joining the organization. With that, I will end and I apologize that I will not be there live to answer any questions, but I will be happy to entertain any questions that may come up, and I've sent my email as well, and I'm happy if organizers want to share the slides or share my email. I'm happy to receive questions offline. Thank you very much.
Thank you. We'll have to conclude the session. There will be no questions here directly, but if you have any questions, as organizer, we would take them. Thank you.
Now I request the chairpersons to go to the felicitation arena to have their mementos. Please sit down. So today I was worried actually, why so many people are not leaving the hall. Then I realized today is Friendship Day. So most probably the friendship between pulmonology and rheumatology is growing stronger and stronger by the end of the day. So thank you very much for still being in the hall. Because now, actually, these were all talks, and talks. Now we are going to a very exciting session, what is called a panel discussion. So we have kept it very simple. We have very eminent speakers, panelists, who have framed very simple questions based on our day-to-day management of interstitial lung disease. I think that is going to be very, very helpful. And at the end, we can also take up some questions. So without delaying it further, I'll request our moderator for the session, Dr. Sajjan Senai, please. Dr. Sajjan Senai, our panelist, Professor Manoranjan Das, sir. Okay, you can finish. Professor Banani, madam. Professor Banani Jana, President of Odisha, madam. President of Odisha State, Odisha Chess Society. We have Dr. Manoj Paningrai, sir, from AIMS, Bhubaneswar. And from rheumatology side, we have Professor Dr. Pradipta Patra, who is a professor in Sham Hospital and head of the department. Dr. Avra Chaudhary, rheumatologist from Calcutta. And Dr. Amit Kansal from Ludhiana. Amit, please. Sajjan, yeah, it's all yours. Yeah. Chair.
So good afternoon, everyone. So with the permission of the organizers, I'll take over as the moderator for the session on panel discussion on how I manage ILD. So now, till now, all the speakers have spoken as to what is the current literature telling you, what are the current guidelines telling you. Now we are going to focus how the experts are actually managing ILD on the ground. Because on paper and on the ground are two different things, right? So we will speak to our expert panel who have eminent pulmonology colleagues as well as eminent rheumatologists. So I will speak my heart out of all the PG students and all the practitioners who are seeing these ILD patients in their clinics day in and day out. So I'd like to welcome all the panelists. The format of the panel discussion would be, I would put forward a question to one particular speaker, and then we can get some clarifications out of them as to how the ILD is being managed. So I'll start with Professor Banani. So with respect to the symptomatology of ILD, we would like to know what are the common presenting symptoms of ILD and how you can differentiate in a clinic from, let's say, bronchial asthma or COPD, which are far more common than ILD.
Okay, good afternoon, and thank you, Dr. Jyoti, for inviting me as a panelist. So first symptom which I will describe is progressive dyspnea, progressive shortness of breath, which is increasing on MMRC grading, or which is increasing dyspnea, and dry hacking cough, dry cough. It may be sometimes with scanty expectoration or expectoration when associated with other infective etiology like exacerbation or something like that. Then there may be sometimes they may, in case of sarcoidosis, they may present as fever. Sometimes hemoptysis is LAMH or DH, diffuse alveolar hemorrhage is there. So my first symptom is progressive dyspnea with dry hacking cough.
Okay. And is there anything which differentiates it from, let's say, asthma? Because asthma patients also have...
There will be no seasonal variation, no diurnal variation, and there will be absence of allergic history of allergy. And the disease may not be present since childhood. It may a late onset, maybe 4th or 5th decade of life.
Okay. So mainly it is got to do with progressive dyspnea with dry cough and a lack of previous history and then progression over the last few months. So that would be this thing. So I would like to go to Professor Manoranjan Das. So once we suspect ILD based on a clinical symptomatology, what diagnostic tests would you do to prove that this patient particularly has ILD?
That is the most important. The madam has clarified that. So clinical history and physical examination is the must. From clinical history and physical examination, we can suspect that the patient might have been interstitial lung disease. Then we should go straight forward to chest radiology. Chest radiology will tell something, but in order to confirm the diagnosis, the gold standard is HRCT thorax. So HRCT high resolution CT thorax, we can know what are the patterns of interstitial lung disease. What is the NSFA pattern, what is the IPA, VIP, everything we can know, whether it is cystic lung disease, like that. After that, we should do, to me, honestly speaking, the history, age, smoking status, and rule out CTD history in all group of patients. So CTD profile, if required, we should do. Then we should go for a spirometry, which is the restrictive pattern. But very often in spirometry, in ILD, it may be normal. So we may go for a diffusion capacity if the facility is available. But if you want to confirm, I will obviously go for a surgical lung biopsy. It's not at all possible. If possible, go for a transbronchial biopsy, or else the transbronchial long cryobiopsy may be a suitable alternate for the surgical lung biopsy. So these are the profile of tests we should approach while diagnosing interstitial lung disease.
Do you think we should do a chest X-ray always before we go for HRCT, or we can go to HRCT directly?
Sir, chest X-ray is a must, sir. To me, chest X-ray is a must. In Indian scenario, first we should go clinical history, physical examination, then chest X-ray. Then we should think of interstitial lung disease. Then we should go for HRCT.
HRCT. So, is it possible that we miss ILD on a chest X-ray and then pick it up on HRCT?
Definitely, sir. Because in 5 to 10% of the cases of interstitial lung disease, the chest X-ray may be normal. But those cases may be picked up early by doing a HRCT thorax.
Okay. So, at least the basic investigation should be a chest X-ray with followed by a HRCT and a PFT, because that will help us diagnose the ILD. So, I'll go to now Dr. Manoj Ranjan Panigrahi. So, which tests will you do to identify the severity and the extent of ILD?
Yeah, it is more or less the same thing what my previous panelist told. The way you are diagnosing, those are the tests basically also to assess the severity, particularly the spirometry and the forced vital capacity, and as well as the high resolution CT scan. And we can add to this, if facility available, the DLCO. And these are the three parameters which will give some idea about the severity. One is a functional severity or the physiological severity, which usually we will be measuring by the spirometric parameters. And the anatomic extent of the disease can be well assessed in the high resolution CT scan. As since morning we are hearing about the forced vital capacity, the DLCO, whether the extent is less than 20% or more than 20% in the CT scan, that we are hearing since morning. And the more the extent, the more worse the prognosis. We already heard a number of lectures on that. So, how to quantify in the CT scan? In a busy schedule, in a clinic, as a consultant, you are seeing a lot of patients. So, either you have a radiologist who has reported it, who is well versed in reporting the chest radiology, or you have your own visual assessment. So one could be a visual assessment of the extent of the disease in the CT scan. As far as the visual assessment is concerned, you may need to have a previous CT scan and you compare with that whether it has progressed, what was the extent of the involvement previously, whether it was only basal, the lower lobes, now it has gone to the upper lobes, or in a particular lobe the extent has now actually increased. Or in the current days, there could be many objective ways of assessing also, which may not be practical in a clinical practice. Like you incorporate your AI algorithms, the machine learnings, and objectively you quantify the amount of CT involvement, which has not come into the, I think, in the guidelines, but it may come in the future. So, but as a rough assessment, CT quantifications, as a clinicians, we can do it side by side. We can hold the previous and the new CT and see how far extent the disease has worsened. That is one way of measuring it. Then you can see the FVC parameters, how good or bad it is, whether it is 70%, whether it is less than 60%, whether it is less than 40%. Also, you see the DLCO parameters more or less the same, whether it is 70% or 50 to 70% or less than 30%. or more than 30%, like that. So that way you will have a rough idea about how much the impairment of the lung function has happened as far as the ILD is concerned. So these are the three most things. 6-minute walk test, we may not say for the severity point of view, maybe prognostication point of view may be more important rather than from the beginning saying that 6-minute walk distance, because that will be more or less related to the extent of the disease in the CT scan per se. So in this way we will assess initially.
So not only in establishing the diagnosis, PFT and HRCT are also important in knowing the extent of the disease and also the severity. 6-minute walk test will give you some extent which will try to prognosticate. Thank you, sir. So now, Professor Banani, I'll get back to you with another question on whether bronchoscopy or a bronchoscopic biopsy, let's say, a must in a diagnostic workup. Is it required? And if you want to do a biopsy, would you go for a transbronchial or an open surgical?
Actually, open lung biopsy is contraindicated as of now when HRCT has taken the front line management. But in a country like India, to exclude opportunistic infection like tuberculosis or any fungal disease or bacterial infection, you should have a bronchoscopy, not routinely, but if there is features of exacerbations or there is constitutional symptoms like low-grade fever or fever of acute onset high fever, in that case, you have to rule out the infective etiology for that only. And for DAH, we need a bronchoscopy. And TVLV cryobiopsy is indicated to establish the diagnosis.
Okay,
And,
so a bronch
is needed for sarcoidosis. We can have it. You have already heard for many times in today.
Yes. So a bronchoscopy is mainly required to rule out a competing diagnosis, especially an infection.
Yes.
Are there any contraindications to a bronchoscopy? Let's say some contraindication where we should not do a bronchoscopy and it's risky to do it.
If patient is in ICU and the condition, cardiac condition is worsens, then we can have a contraindications.
Okay.
Like severe pulmonary arterial hypertension or any other coronary artery disease, we can have contraindications.
Okay, thank you. So the role of bronchoscopy is mainly to rule out a competing diagnosis, and there are certain situations where we may not be able to do it also, depending upon the general medical situation of the patient. So we go back to Professor Manoranjan Das. So when you see a patient of ILD and you have done all this diagnostic workup, when do you consider that a rheumatologist has to see this patient? When do you refer to a rheumatologist?
So in order to refer a rheumatologist, actually it's to me it's a combined workup. So it is a pulmonologist and rheumatologist workup. From the history, if there are features of CTD, like joint pain, arthralgia or any rashes, we should think of a CTD. Then the blood profile also, what I told, that if you are from the history, if it is suggestive of a CTD-ILD, then we should go for a minimum screening for CTD-ILD. Then if HRCT thorax, certain features, suppose you are getting exuberant honeycombing or like anterior upper lobe involvement or a straight edge signs. So these are the signs that suggest to that this patient might have some CTD-ILD. Then in those category of patient, I suggest to prepare to have a discussion with my rheumatology colleague.
So you will mainly go by the clinical features
Yes.
of the patient and then consider a referral. Now we have since morning we have discussed about UIP, NSIP patterns on HRCT. Do you think a UIP patient who has got a typical UIP on HRCT should have a rheumatology referral at least once in his clinical course?
Sir, in our India, in our country, systemic sclerosis rheumatoid arthritis is the most common CTD-ILD. No doubt CTD-ILD may present a non-specific interstitial pneumonia, but very often we see UIP patterns also in systemic sclerosis or UIP. If my patient is not improving even after 1 hour of antifibrotic therapy in your patient, I should also take an opinion. It is a better idea to have a combined decision to rule out the CTD-ILD.
Okay. So if the patient has a clinical sign or a symptom suggestive of a underlying connective tissue disorder or an arthritic or an arthropathy, you would definitely require a rheumatological evaluation. And then if the patient has an NSIP or an OP, that is organizing pneumonia, on the imaging, we would consider a rheumatology referral. And of course then, as sir said, if we have a UIP pattern which is not responding to your routine clinical management, you would probably consider a referral once. So now we go to Dr. Amit Kansal. He's a rheumatologist. So what factors, so when a respiratory medicine consultant sends you a patient, what factors in the clinical history and examination would make you suspect that this ILD patient has an ILD of autoimmune origin, likely of autoimmune origin?
Yeah. So this is very common scenario in rheumatology practice when a patient of ILD is referred by a pulmonologist to rheumatology OPD. To see for the autoimmune features specifically, you first have to ask the patient about symptomatology of the common connective tissue diseases which are associated with ILD. The most common is systemic sclerosis. So you can see for Raynaud's or any digital infarcts, digital ulceration, and skin thickening and telangiectasias. Then most common second is myositis associated ILD. You can ask for muscle weakness, you can test for the muscle weakness, and you can look for any rashes for dermatomyositis. And third is rheumatoid associated ILD. So for rheumatoid you have to ask for arthralgias or arthritis, arthralgia with morning stiffness of more than 30 to 60 minutes and arthritis. Then Sika symptomatology to rule out Sjogren associated ILD, the dry mouth, dry eye, and then there are patients with SLE also which are associated with ILD. So lupus features like alopecia, oral ulcers, genital ulcers, photosensitivity. So you can ask particular disease associated symptoms. But many times there are around 25% patients of autoimmune etiology where they do not fit into a particular group of any connective tissue disease. So we used to say them as UCTD, unclassified connective tissue disease associated ILD, or lung dominated connective tissue disease, or autoimmune IPF. But now this group has been classified into IPAF, that is interstitial pneumonia with autoimmune features. And in this category, basically it is a research entity which is evolving now over time. And it has given 3 domains, the clinical domain and serological domain and the morphological domain, depending on the various patterns on radiology or histopathology. So the clinical domain, they have described 7 features, and all these 7s are actually limited to the involvement of hand. The first most common symptom is Raynaud's, which is most commonly associated with ILD. So you have to ask about Raynaud's phenomena. Second most common is mechanic hands. Again, you have to look at the hand, featuring on the radial aspect of the index finger and thumb. Then third is arthralgias or arthritis. Again, you have to examine the hand joints, small joints of the hand. And fourth is digital ulceration or digital tip ulceration. Fifth is unexplained edema over the digits, and lastly palmar telangiectasias. So all these features, they are limited to the hand, and they will give very good clue whether your ILD is associated with autoimmune features or not.
So to summarize, we mainly have to look at the skin and the joints to look for any clues of an underlying connective tissue disorder, a myositis spectrum of disease, or maybe an underlying arthritic disease. So thank you, Dr. Kansal. So I'll go to Professor Pradeep though. So with this, like if a patient with ILD has come, or you are seeing a lot of rheumatological patients in your clinic, which are the pre-existing rheumatological diagnoses which predispose the most to a patient to develop ILD? I'm talking about a patient who already has a connective tissue disease or an arthritic disease, who you will keep your eyes open for development of ILD.
Because as a rheumatologist, the most common condition arthritis you come across is rheumatoid arthritis. The incidence is though less in comparison to systemic sclerosis. Systemic sclerosis patients are more prone to develop this interstitial lung disease. Those systemic sclerosis patients have diffuse skin tightness, and the skin tightness proximal to the elbow or proximal to the knee joint, like we call it is a diffuse cutaneous systemic sclerosis. And with autoantibodies like anti-topoisomerase or anti-SCL70, or some antibodies like anti-THO and anti-RNA polymerase 3, those patients have more of risk factor for developing interstitial lung disease. Second is rheumatoid arthritis, as already mentioned, like apart from the other connective diseases, rheumatoid arthritis patients develop more of UIP pattern, Though UIP and NSIP they can occur, NSIP also can occur in RA. So RA patient most likely those are elderly populations, smokers, male age, high disease activity, and very high rheumatoid factor or anti-CCP. These are 5 risk factors of rheumatoid arthritis. Those can develop your interstitial lung disease. So we will follow up those patients. SLE patients, they're less likely they develop your interstitial lung disease. Fourth one is MCTD, mixed connective tissue disease. Apart from the systemic sclerosis, this MCTD patient can have developed this interstitial lung disease. Fourth one, Sjogren's syndrome. Sometimes they can have like elderly female, those who have dry eye, dry mouth. You should ask about the dry cough, dyspnea on exhaustion. You should look for the every time you should look for the any ILD features. And myositis. Myositis like autoantibodies when the patient is having your anti-synthetase antibodies. Those are more prone of developing your interstitial lung disease. Apart from the anti-synthetase antibodies, like the patient is having PMSCL antibodies or MDA5 antibodies. These MDA5 antibodies, if the patient have myositis, they get more chance of developing RP-ILD, like rapidly progressive ILD. Though MDA5 have 3 different spectrums, but in like depend upon the genetic association, those some MDA5 will have more of arthritis and some MDA5 will have RP-ILD patterns. And apart from these common scenarios, like already we discussed sarcoidosis, another group of patients, they can have ILD. So these are the common scenarios we should closely watch for the developing ILD in future when I will follow as a rheumatologist.
So to summarize, the top 3 diseases, if you want to put, top 3 pre-existing rheumatological diseases which predisposes patient to ILD, they are rheumatoid arthritis, systemic sclerosis and myositis group of disorders. So in these 3 group of patients, we will actively look for development of ILD in clinical follow-up. So Dr. Obrachandra, so once you have considered a patient to have interstitial pneumonitis with autoimmune features, which Dr. Kansal just alluded to, what diagnostic tests will you do to prove or refute a diagnosis of IPAF?
So these patients already have ILD, so the diagnostic tests mainly are, one is serological test and another is the radiological pattern. So among the serological tests, we'll test for the serology of the routine, the most common diseases that Dr. Pradipta has already described. So we'll go for the ANA profile. So ANA profile would mostly include anti-dsDNA, then RNP for MCDD, then anti-SSA, SSB for Sjogren's, and then some of the ANA profiles also includes anti-Jo1. Secondly, we'll test for the RF anti-CP for rheumatoid arthritis associated ILD. Thirdly is the anti-MDA5, then anti-PMSCL. Now, regarding the rheumatoid factor, very often we find very low titer rheumatoid factor positivity in some of the case of ILD. Some of the patients of ILD are elderly above 50 and we find very borderline rheumatoid factor positivity. So we should not consider that as rheumatoid factor positivity. The titer should be more than 2 times upper limit of normal, only then it should be considered as rheumatoid factor positivity. So very often we also order for ANA or patient comes with a ANA report. So if the pattern or the titer determines whether we should take this as positive or not, because even up to IPF, 30% cases of IPF can have ANA positivity. So regarding the patterns, if we get a centromere pattern or a nucleosome pattern, any titer is significant. But if we get other patterns like diffuse speckled homogeneous pattern, the titer should be high, like more than 1:320. So this is the titer that we should look into. Now regarding the radiologic investigations, patient already has a HRCT, so the pattern of the HRCT determines whether the patient is more likely to have a CTD associated ILD. So NSIP pattern, then organizing pneumonia or NSIP with organizing pneumonia, and LIP pattern. So UIP, the presence of UIP is not included, but the presence of UIP does not rule out IPAF. So, but if a patient has UIP, then patient needs to fulfill some of the other features like arthritis or rheumatoid factor anti-CCP positivity in order to be classified into IPAF. And in the HRCT, we also look at some of the other features apart from the pulmonary parenchymal involvement, whether there is pleural involvement, whether there is pericardial involvement, whether there is a presence of pulmonary hypertension and airway involvement. So apart from ILD, additional involvement of the lungs in these forms gives us a clue that this patient belongs to IPAF.
Would you consider doing a myositis profile for all of these patients?
If a patient does not have any clinical features, yes, I would do considering a myositis profile.
So, summarizing, we have to consider rheumatoid factor, anti-CCP, a high titer ANA positivity on immunofluorescence, ANA profile and myositis profile as the basic investigations to make or refute a diagnosis of IPAF. So, I think we are right on that. So now one controversial area which I would like Dr. Kansal to address us is, do you think that ANCA testing, by ANCA I mean ELISA or very specific ELISAs for anti-myeloperoxidase and anti-proteinase 3, do you think that we should consider this in all IPAF patients?
So this is a very interesting and controversial area actually. So I will touch the two aspects of this area. One is ILD in ANCA and second is ANCA in ILD. So if we see the series, first I will tell about the ILD in ANCA. So those who are proven cases of ANCA associated vasculitis, the series have reported that up to around 45% patients of microscopic polyangiitis, MPA, has a prevalence of ILD. Whereas in GPA, up to 23-24% patients can have ILD. So this is a significant figure where vasculitis patients, they have been reported to have ILD. The second is ANCA in ILD. So if we test every patient of ILD for ANCA, the positivity for anti-PR3 is around 2 to 4%. Whereas the positivity for anti-MPO, the myeloperoxidase, is around 5 to 35%. So specifically, particularly anti-MPO is much more associated with the prevalence of ILD rather than PR3. And even if a patient is having only respiratory symptoms, even if they test positive for anti-MPO or anti-PR3, the series has reported that up to 1/3 to 1/4, means around 25 to 35% patients, they over a follow-up of around 18 to 24 months, they turn into full-fledged ANCA-associated vasculitis. Means they develop gradually the symptoms of ANCA vasculitis like hemoptysis, weight loss, diffuse alveolar hemorrhage or renal involvement over the time. So looking at the high rate of prevalence of ILD in ANCA-associated vasculitis and the conversion rate of asymptomatic ANCA positivity into full-fledged ANCA-associated vasculitis, I will definitely go for testing for ANCA-associated vasculitis in every patient of ILD, specifically when your other workup or your serologies for other diseases like your myositis panel, your ANA, RF anti-CCP, if everything is negative, definitely you should check for at least anti-MPO and particularly in younger patients actually.
So doing an anti-MPO may be worthwhile, right? So in such patients, doing an anti-MPO may be a worthwhile exercise. So going back to Dr. Pradipto, are there any established prognostic markers or features which will help you in routine patient care for an IPAF patient?
Regarding IPAF?
Regarding IPAF. Or let's say connective tissue disease ILD patient, any prognostic markers which will help you?
Regarding the prognostic marker, no. Till now there is no prognostic marker is available so that it can tell you whether any progression is there apart from the radiological part. There is no blood investigation is available, like only some data like trial research purpose like KL6, surfactant protein D, those are, and some cytokines levels. There is no such hardcore biomarker is available to tell you whether this ILD is progressed or not progressed. It is the HRCT, it is the patient symptom which can tell you the patient symptom progression or not progression. So, summarizing that only HRCT and symptom is the only biomarker.
So there are no specific prognostic markers that we can use here. So go, Dr. Obro, so once we decide that a patient has IPAF or let's say connective tissue disease related ILD, what factor will dictate your choice of immunomodulatory therapy? What do you see before you decide which drug to give?
Basically, it depends on the disease which we are treating. Like a rheumatoid ILD, usually progresses slowly, whereas a scleroderma ILD progresses quite rapidly, or a myositis associated ILD progresses quite rapidly. So usually mostly the choice of immunosuppression would be mycophenolate in most of the cases, but like a rheumatoid arthritis associated ILD, very often they have joint involvement in addition to lung involvement. So I would also keep tacrolimus as an option, which would take care of both the joints as well as the ILD. Again, rituximab is a good option which can take care of the joints as well as the ILD. But regarding scleroderma ILD, where joint involvement is not that significant, mycophenolate or cyclophosphamide may be an initial choice. Again, for myositis associated ILD, mycophenolate may be a good choice, mycophenolate or rituximab. And then regarding the other, if these are resistant, then we'll move on to the second line therapy. Like for myositis, we can add on tacrolimus or JAK inhibitors, or add rituximab, and even for scleroderma or rheumatoid, we can add on rituximab. So it's basically the disease which we are dealing with, or the autoantibody profile, say ILD with rheumatoid factor or anti-CP positivity. So the autoantibody profile or the disease determines what choice of immunosuppression we will take.
So the underlying disease will dictate your choice of immunomodulatory therapy. So if I can ask Dr. Pradipto, is the treatment of IPAF, because in IPAF we do not have an underlying defined CTD, is the treatment of IPAF different than a defined CTD ILD?
Like we have that guideline, whatever we are having guideline ACR 2 2023, that guideline for all these established CTDs. There is no established guideline for the IPAF as of now. Only we are correlating data from the CTD ILD, because we are thinking like that patient might have progressed to develop CTD in futures. Those IPAF patients do not have classic CTD features and does not fulfill the criteria of CTD. That is why we are fulfilling into the IPAF. So depending upon the pattern, depending upon the progression and fibrosis, that we are giving the immunomodulator plus or minus antifibrotic therapy. Most of the guidelines what we follow for IPAF is according to the CTD ILD only, like Dr. Abra already described.
So we will use the autoantibody profile as well as the imaging parameters to decide which immunomodulatory therapy we are going to plan. So now, Professor Banani, do you prescribe antifibrotic agents like, let's say, nintedanib or piriferidone for all ILD patients? Or if you are not prescribing to all, what factors will indicate the need for such a therapy?
Actually, two antifibrotics are available in India. One is nintedanib, one is porphyrin. Both the mechanism action and the action is equal. Nintedanib has got a more nintedanib is better tolerated. Porphyrin has a pill burden, more pill burden, and lesser tolerated. And I will not be using antifibrotic in all cases, but in idiopathic pulmonary fibrosis and other CTD like scleroderma, I will use antifibrotics to prevent the decline of ABC. So better to treat to decline of ABC, which I can monitor at least twice a year. Nintedanib is a better choice as an antifibrotic.
So you would use nintedanib in most ILD patients.
Yes.
That would be the message for the audience. So for Dr. Obro, what test would you do to monitor the progression of a patient, and when?
So usually, as was discussed previously, mainly the pulmonary function test, which would include the FVC as well as the DLCO, and 6-minute walk test also we include, and as well as HRCT and the patient symptoms. So we follow up the patient usually at 3 months or 6 months interval. Initial period 3 months, and then if the patient is doing well, we shift to 6 months. So more than 10% decline in FVC between any 2 visits is considered significant, or between 5 to 10% decline in FVC and more than 15% decline in the DLCO is considered as significant, or 5 to 10% decline in FVC along with worsening of patient symptoms or worsening of the HRCT features. The problem with FVC, the PFT in our patients is like for scleroderma, many of the patients cannot open their mouth fully. So in those cases, PFT is not fully reliable. Also, the problem regarding the standardization of PFT and the technical aspects of the PFT are also problematic. So many a times we do PFT, but in addition we also do HRCT and take into consideration the deterioration of the patient's symptoms.
Oh.
And sometimes even there is mismatch between the PFT and the patient symptoms. In that cases, we choose to repeat the HRCT. And 6-minute walk test, again, there is a fallacy because many of our patients are arthritic. So a rheumatoid arthritis patient may not be able to, with active arthritis, may not be able to do a 6-minute walk test properly. So those are the fallacies keeping in mind. So we'll take into everything into consideration, FVC, decline in FVC, DLCO, which is not available everywhere, patient symptoms and HRCT. Depending on these, we'll take a further call on whether to modify the immunosuppression.
So putting together, we would do a PFT once in 3 to 4 months till the disease is stable, and then repeat an HRCT if there is a deterioration in between, if you want to quantify that.
Just
Okay.
to add there, besides these technical difficulties in performing a good, FVC maneuver, many patients are unable to do that maneuver basically. Now, when you are following up them and they are progressing, let's say, initially they might have done good, but later on they are unable to do it well. So that becomes really a challenge that how you are going to monitor the physiological progressions. When they do not do an acceptable maneuver, that becomes a problem for spirometry.
Yes, Dr. Panigrahi, the next question is for you. Are there any reliable methods where we can distinguish a lower respiratory infection versus flares of ILD or IPF?
Okay. This will be no single test, I think, will decide, but it will be a combination of the things. Whether basically the question is like that: a patient comes with a worsening of the ILD, and how to decide whether it is an infective worsening versus a progression of the ILD in an acute manner. So it is just like any other cases where we are thinking about infections. Maybe if you talk about the biomarker, then you do the CRP or the ProCal and see whether they are elevated. Also, you look for the leukocytes count as a laboratory parameter, and if high leukocytosis, but none of these things are foolproof that if ProCal is elevated, mean it is only infective exacerbations. So everything has to be taken into concern. Like let's say it's a febrile. If it is a pure ILD exacerbations, it will be mostly afebrile episodes, whereas there is a fever. So patient has come with fever, there is a leukocytosis, there is a purulency in the sputum, and there is a elevated biomarker like ProCal or CRP, then possibly you are dealing with an infective exacerbations. Whereas there is no fever, ProCal is not highly elevated. There is no we cannot say any single cutoff, but most people will accept for a ProCal cutoff, let's say 0.1 nanogram or something like that. So whatever way you decide, so you just compare, because ProCal can be elevated in a simple non-infective exacerbations as well. If it is more elevated, then it may favors towards an infective exacerbations sort of thing. And then if it is a true ILD exacerbations or the IPAF exacerbations, then you need to repeat the imaging. You need to repeat the imaging and you see whether there is a increase in the GGO or not. If there is an increase in the GGO, then it may favors to you towards a pure exacerbations of the ILD or the IPAF. Or if there are certain radiological patterns which may favor towards an infections, let's say there has been a cavity, a cavitary disease has developed, or there are discrete nodules has developed. So then, or there are discrete infiltrates other than the area where the ILD was there before. Then maybe you have a clue that it seems to be a localized problem in the lungs other than the pre-existing ILD, and this may reflect a new infection. So this is the way we can think of, that is one part. But in the practical ground reality, how many of us will dare not to give antibiotics when a patient comes with ILD exacerbations? Possibly the answer is 0. Everybody will start antibiotics and vis-a-vis he may work up. So what will be the conclusive evidence? If we can document some infections in the respiratory sampling. So is my patient fit enough to undergo a respiratory sampling? And the best way of respiratory sampling will be a bronchoalveolar lavage. Are we able to do? Is the patient fit enough for that? Otherwise, you send the sputum. In the sputum, you try to identify any organisms, whether non-tubercular or tubercular, whatever way. Or if you are able to do a ball, in the ball you identify any organisms, then definitely you are dealing with some infective exacerbation. Sometimes this organism may be a commensal as well. But you have to take everything into account. Patient has come with fever, there is an acute worsening of the symptoms over the pre-existing baseline, and he has grown an organism in your bowel or sputum, then probably it is a true pathogen. You may not think this is a commensal. So in everything you have to take into account, but the definitive evidence will be identifying an organism, whether a virus or a fungus, sometimes because these patients will be already on some immunosuppression therapy. So it's not uncommon to get some uncommon bugs like you may get a pneumocystis. Sometimes you may get a strongyloids if the patient is on steroids. So possible. So if we identify some organisms, definitely there is infections. In absence of identifying any organisms, possibly none of the clinicians will stop giving antibiotics. Everybody probably will give antibiotics, along with that whatever other steps you may do to optimize the patients in terms of respiratory support, in terms of immunosuppressions, in terms of pulse steroid, whatever you think at that moment. But I think with antibiotic always, whether you prove or you do not prove antibiotic, that's how we practice. And that's how in the literature also, in most of the exacerbations, you will see everybody has given antibiotics.
So an infection is presumed until you prove it otherwise.
Yeah.
So Professor Banani, what criteria?
Do you send biofire in these cases in all patients? Because presence of some bacteria does not rule out a viral infection. So biofire is a costly test. And presence of anything on the biofire, so do you routinely give antivirals also?
No. First of all, to be honest, we do not routinely send biofire in our setup. We are in a government setup. Patient has to afford for it, and most of those patients will not afford the biofire test. Mostly it will be respiratory sampling and in-house culture based. So I routinely do not send biofire. And simply identifying biofire also, and biofire will not also have all the organisms or the viruses that you may consider in a patient like this. I think, let's say CMV, I think CMV doesn't come in the respiratory biofire. But the only thing that you can treat is a CMV, something like that. So that's the limitations of that.
Professor Banani, we all know about domiciliary oxygen therapy and it's very useful. So what criteria do you use to decide whether a patient with ILD requires domiciliary oxygen therapy? And what is the flow rate or the saturation that you would target in such a patient?
So domiciliary oxygen, usually after exacerbation or progression of the disease, we need a domiciliary. The target saturation should be more than 88 and it should be maintained between 88 to 92. It is well and known. So if the patient may require domiciliary oxygen whenever he uses a washroom or day activities, usually via nasal cannula, will likely to up to 3 liters we can give, and we told their relatives to maintain that oxygen should be maintained at 88 to such SpO2 88 to 92, and we see that if there is worsening of dyspnea, they should be hospitalized.
Okay, so we target a saturation at rest of at least around 90% when we give domiciliary oxygen therapy. Yeah, thank you. And finally, Dr. Kansal, last 2 questions. Do you vaccinate your ILD patients? And if yes, what vaccines do you routinely prescribe?
Yeah, because the compromised lungs always are source of infection. I routinely, because before starting immunosuppression, I routinely counsel the patient for vaccination. And over the years, especially after COVID-19, patients' acceptability for vaccination has also increased. So routinely I vaccinate for pneumococcal vaccine, and second is influenza vaccine. Pneumococcal Prevnar 13, that is PCV 13, is the first shot which I give, and then after 2 months, the Pneumovax 23, that is PPSV, the polysaccharide vaccine after 2 months. Influenza vaccine usually given annually before the onset of winter. So usually September is the right month in North India to give influenza vaccine. Recently, Shingrix has been launched in India, and people, those who are more than 50 years, are counseled about Shingrix, but because of the high cost, very less acceptability for Shingrix is there.
Okay, so we would vaccinate every patient with the pneumococcal and influenza vaccination, and we can give a option of taking herpes zoster vaccination. So finally, we will close with the last question, Dr. Manoranjan Das, for you. What about lung transplant? Is it a practical option for our patients with ILD or IPF? Do you actively counsel them, and if yes, at what stage?
Sir, 10 years before when I was in a conference exact like that, someone has asked what the treatment in critical care, what is the treatment just for liver cirrhosis? One panelist told it should be the liver transplantation. Everyone loved. So, but now we are seeing like liver cirrhosis, liver transplant, this is lung cirrhosis, lung transplant is a must. So the criteria should be selected, guidelines is something different. But as for the heart lung transplantation, you should see whether our patient the chances of mortality. If I don't do a transplant, if the 50% mortality is within 2 years, yes, he or she is an ideal candidate for lung transplantation. Then see the survival. If you do a transplant, if my patient will not survive for more than 3 months, then it should not be used. And you see again for the 5 years survival rate. If it is around more than 50 to 80%, I think we should go for transplant. Then the criteria is fixed, led by the guidelines. When there is a progressive fibrosing ILD, it should be indicated mostly in CTD-ILD, Langerhans cell histiocytosis, or chronic HP, fibrotic HP, we can think. And one poster is there is a rare case of Hermasi-Pudlak syndrome. There is a Hermasi-Pudlak syndrome society in Mumbai, I think. They are giving a elective lung transplantation if they are detected in the 4th decade of the life. So I think these are category of the patients where there is a progressive fibrosing ILD with the FBC of less than 80%, DLC of less than 40%, it is not responding to treatment. Upfront we should give him an option of lung transplantation. Now in India, few centers has come. Perhaps in near future, many more centers may come with a lung transplantation.
Thank you, sir. So lung transplant, even though it's not widely available now, it will probably be one of the very important therapeutic options and a long-term solution to patients who have progressive fibrosing ILDs as well as end-stage lung disease. So with that, we have seen that our experts have given answers to all the common questions that many practicing physicians would ask, and we see that their practice and their thought process is actually in line with most of the guidelines and most of the literature that we have in these particular subjects. Of course, there are gray areas, there are controversial areas which probably will become clearer with time, but then this is currently probably the state-of-the-art management of CTD-ILDs. I would like to thank all the panelists for their expert input, and
Thank you.
I hope that the audience actually enjoyed this session and takes away a lot of technical points and the take-home messages from this. Thank you.
So I now request all the chairpersons to go to the felicitation area. So today is Friendship Day, and just because Sajjan was here, I have just reminded that we have completed 10 years of DM rheumatology. Sajjan, me and Ranjan, all of us are here. So this is a real moment of proud. We are really proud that we three of us are here. And we are going to the next and the most exciting session actually, for which so much of crowd are there actually. All are very excited to see the quiz, and we have a very dynamic quiz master, 2 quiz masters. One is Dr. Shaunak Ghosh from Calcutta, who is a national quiz master for Deodhar quiz, and Dr. Saurabh Mittal from AIMS. Already he has given a talk today. So I welcome you both to start your program.
Thank you, Professor Parida, for that warm welcome to both of us. So, without wasting much time, as we are lagging behind a bit, exciting day for all of us and a long day, and thank you for staying till the second half of today. I'm going to announce quickly the top 4 teams which have been selected, followed by an interesting announcement by Dr. Mittal regarding one more 5th team, which was very interesting. So, the team with the highest score of 61 is from SCB Medical College, Cuttack, Dr. Debashish Shahu, Dr. Kanhu Charan Nayak. Please make your way to the stage. Debashish and Kanhu Charan Nayak. Is the team here? Are there? Come on, please come to the stage. Whenever you call out your names, guys, please. A very close second from the top, another team from SCB Medical College, Cuttack, Dr. Roshan Patia and Dr. Gyanendra Kumar Nanda. So well done, SCB Cuttack. 2 teams qualifying for the mains. 3rd team with a score of 57 today, very closely fought, Dr. Rakesh Kumar Behra and Dr. Santi Swarup Sahu from MKCG Behrampur Medical College. Rakesh and Santi Swarup. And finally, the 4th postgraduate team qualifying for today's quiz with a score of 56. So 61, 60, 57, 56. Well fought. The team is Dr. Chandan Kumar Sahu and Siddhanta Sahu, again from SCB Medical College, Cuttack. So these are the top 4 teams, and now Dr. Saurav Mittal, please announce about the 5th team.
So we had conducted this quiz predominantly for the postgraduate students, but some of the DM candidates also joined in. So actually the maximum marks were for the DM pulmonology team from AIIMS Bhubaneswar, Dr. Subarna Acharya and Dr. Shashank Kumar. So they got 70 marks, but we did not take them for the final rounds because the quiz was meant only for the MD students. So, but they'll get a special prize for the same.
I don't need in case you. So I'll start the quiz now, but before that, just one short announcement. All the residents who have submitted their oral presentation or are taking part in oral presentation, please make sure that you have submitted your presentation to the console on the right side of the stage. So please submit your orals if you have not yet. And now, without further ado and wasting time, oh, you have, so sorry, well done. So please go and give your oral and come back. While that's going on, I'll ask the teams to introduce themselves, but before they do that, so as to not waste any time, let me just explain the basic rule of the first 2 rounds. There's going to be 3 very exciting and interesting rounds for the quiz. Pounce rules will apply to the first 2 rounds, followed by a rapid fire in the 3rd round. So I don't think I need to explain the rapid fire round, it's self-explanatory. After first, all teams are going into the finals. Initially, we were thinking of whether we want to eliminate some teams for extra dramatic effect, but we are not going to do that. What are the pounce rules? I'll explain, but please remember the second point. The quiz masters are going to be always right, so can't help it. Breathe, walk for 6 minutes, move on. What are pounce rules? In order to ensure fairness, making sure that everyone gets a chance to answer each direct and indirect question, whenever a team gets a direct question, suppose team A gets a direct question, before they answer, I'm going to give a 5-second countdown for the other teams to pounce. You all have been given chits of paper. If you think you know the answer before the direct candidate answers, do not shout, write down the answer on that chit. I will have Dr. Avarna from KIMS and Dr. Istarul from IPGMR. They have very graciously been helping me out with this. They're going to collect the chits. We're going to announce the right and wrong answers at the end of the round, after which the direct team will get a chance to answer. For round 1, you have a +10 and -5 for a direct team, but if you pounce, you get double that. +20 correct, -10 for incorrect. After this, if it passes, only +5 for correct and nothing for negative. And round 1, round 2 have the same pounce rules, but round 1 has 2-part answers. Is everyone clear on this? If there's any confusion, I'll explain this again. Yes. All got this? So what I mean by pounce is, if it's a question to team A, before they answer, team B, C and D can pounce. I will do a countdown. If you have pounce, please do not shout out the answer, just write it down on the chits. Avarna and Israrul will take the chits from you and announce whether it's right or wrong. Dr. Saurabh Mittal will be marking the scores, after which the direct team will answer. After that, it will go to passing of the teams to the teams who have not taken pounce. Got it? So pounce gets you double the right or double the negative marks. Direct gets you 10 and -5. A normal pass gets you +5 and 0 for each part answered. Shall we begin? Ready? Perfect. So I think it'll be clear by the end of the 2 rounds. So this is a double whammy. Each question has 2 parts. Both parts will be up on the screen. No hints, nothing. And could you just introduce yourselves, team A, B, C, D. Team A, please, names and college ones. Sit.
Dr. Kanucharan Naik from SV Medical College Hospital.
Dr. Devashish Sahu, second year PG resident of respiratory medicine, SV Medical College.
Team B.
Dr. Gyanendra Kumar Nanda, postgraduate resident from SV Medical College, Cuttack.
Dr. Roshan Kumar Polya, SV Medical College, Cuttack, respiratory medicine, MD.
Thank you. And team C.
Dr. Rakesh Kumar Behra, MKCG Medical College, Department of Medicine.
Santi Swarup Sahu, MKCG Medical College, Department of Medicine.
And team D.
Chandan Kumar Sahu, Medicine, SCV.
Dr. Siddhant Sahu, Medicine, SCV.
All right, so welcome to the quiz. Well done, guys. And this is question 1. There are going to be 8 questions, clockwise 4, anti-clockwise 4. Ample amount of fairness, okay? Question 1, for team A, direct question. You can pounce. I will start the countdown for pounce. So this is your question. This is Dr. Gordon Sharp. He and his colleagues described a series of 25 cases way back in 1972. This is an excerpt from the abstract that was published. All of these patients had a heme-agglutinating antibody to an extractable nuclear antigen without any detectable anti-Smith antibody. And the clinical characteristics of these patients were a combination similar to those of SLE, scleroderma, and polymyositis. Most of these abnormalities also responded to corticosteroids. So the 2 parts are what specific antibody is being referred to in this description and name the disease being described, and pounce closes in 5, 4, 3, 2, and 1. Team C and D have pounce. No answers, please. It's direct to question A. Wait, let them just write down. I hope the audience has caught on to the rules of pounce. Just let me know if I'm going too fast, okay? Done. That's Team D with their answer. Team C, please. Don't read out the answers. Done. Now direct for Team A. Please, your answer. A and B.
Autoantibody is anti-nuclear antibody.
Okay, and?
And the disease is systemic lupus, mixed connective tissue disease.
So part B is correct. So they will get marks for part B. The disease being described is MCTD. Part A is still open. So it passes to Team B. Only A. Quickly, guys, because C and D have answered, so there's no more passes left.
The antibody is your RNP, and the
so Team B gets it right for part A of the answer. Team A has gotten it right on direct for part B. And about Team C and D, Dr. Mittal, please. So Team C got both the parts wrong, and that's the twist. Now they get -20 to start off the day. And Team D? Excellent. Team D has gotten +40 because they got both parts, U1 RNP and MCTD, correct. Well done. We have started off with our first question. Now question 2, direct for Team B. The Iphigenia study, we have discussed this, I guess, demonstrated that triple therapy with N-acetylcysteine, azathioprine and steroids was better than the combination of azathioprine prednisolone in preserving lung function in patients with a disease I have named as X. As a follow-up to this, the Y study was designed to test the efficacy of NSE, azathioprine and prednisolone combination in this disease. But that had to be terminated early as this combination had significantly higher mortality outcomes. And this is our basis now in practice to avoid immunomodulators in the disease X. So identify the disease X and name the study Y. This is direct for B, so pounds closes in 5, 4, 3, 2, and 1.
No one has pounced clearly because of the marks in first question. So direct for team B. Tell me your answers. Disease and the study named. If there's no answer, I'm going to pass this question to team C. So moving on, team C. No answers as well. There's no negative on passing. You can take a try. Team D, would you like to answer?
Idiopathic pulmonary fibrosis.
IPF and?
Why I don't.
So they have answered one part correct. Y is still in place. So for team A, they have answered idiopathic pulmonary fibrosis correctly as the condition that is being described. What was the study? The hint is in the diagram, but it's an obscure hint because otherwise it would be too easy, as Dr. Mittal has pointed out. Any guesses for B? Please.
Panther tray.
Sorry?
Panther tray.
Be loud again.
Panther tray.
Any idea what the diagram is? Very good. So the study is the Panther IPF study. Excellent. Team A gets the second part right. And that is the necklace from the Marvel movie Black Panther instead of using a direct Panther's image. So now we have one part pass team A, one part answered by team D on pass. No one had gotten it direct and no pounces. Question 3, moving on, direct for C. A very famous image out there in every social media page, Facebook, newspapers. Imagine this shooter from Turkey, this 51-year-old coolest athlete ever, has come to you, admitted to the ICU with hemoptysis for the last 2 days. A skin condition or mucosal ulcer has been shown, and based on the CT findings, you're suspecting a particular diagnosis. I want part A, the gene, team C, this is your direct question with this condition, and the pulmonary manifestation I have highlighted in the image. Pounds closing in 5, 4, 3, 2, and 1. No takers for pounds, so direct. Team C, please.
Bechet's.
Look at the question, the gene associated with the condition and the pulmonary manifestation.
HLP5.
Your answer is HLA-B5.
HLP51.
I'll take that 5-1, okay, and B, the manifestation. So they have answered A correctly.
Pulmonary thromboembolism.
So their answer is thromboembolism. Moving on to team D, that is incorrect. Any guesses for the second part? What imaging I have highlighted in this image? Pass from team D, going to team A for part B.
Bilateral hilar adenopathy. Bilateral hilar adenopathy.
They said bilateral hilar adenopathy, which is wrong. Moving on to team B for the second part. Can you identify the pulmonary manifestation?
Yes. Thromboembolism.
They have already said that, so it's still open for the audience if anyone, any of the residents wants to take this. Yes, please, ma'am, please. Very good, that's a pulmonary artery aneurysm and not thromboembolism. Well done. So I don't know if there are chocolates, I haven't announced that beforehand. So team C got one part right, HLA-B5-1. So this is Bechet's Turkish descent person coming with this finding, and that is a pulmonary aneurysm and not thromboembolism. So well done, ma'am, and the team. Coming to question 4 of the first round. This is for team D, direct question. 36-year-old laborer from Dhanbad presenting with cough, shortness of breath. He has been told to have some lung disease as his occupation is that of a mine worker, and the chest X-ray is shown here. Now, can you identify any one major radiologic finding that is present in the chest X-ray and name an autoimmune disease that can present with these findings? So, question for team D, and pounce is closing in 5, 4, 3. Have you pounced, team B? In case you're pouncing, please raise your hand. 2 and 1. No takers for pounce. Team D, direct. D, direct question for you guys.
A, multiple rheumatoid nodules.
And B?
Rheumatoid arthritis.
So both parts are wrong. I'm sorry to say that. Now that moves pass to team A. Any one radiologic finding and one autoimmune disease that can present with these findings. Close mimic.
Reverse halo sign. Reverse halo sign.
And disease? Moving on to... That's the wrong answer, I'm sorry. Moving on to team B for the finding as well as the disease.
Disease is Erasmus syndrome.
And the finding?
Of autoimmune and disease is systemic sclerosis. And finding is middle lobe fibrosing. Middle lobe fibrosis.
You came very close, but no cookie. Team C, any answers? No. So the radiologic findings have not yet been answered. You did get one of the syndromes right. I'm not going to discuss that in detail until you will find out later. No, so the disease is not systemic sclerosis, which we are talking about. Any takers for the disease and the pulmonary finding? Anyone from the audience? Yes, please, please, go ahead. Yes, PMF is the finding we are looking for. Well done. So progressive massive fibrosis of the lungs and the disease which can have... No, that has been autoimmune disease. Which one? What you're talking about is already silicosis. What autoimmune disease can also come up with this? No, but... No, but... Not really. So I'll just give the answer in the interest of time. Sarcoidosis can often present with this sort of eggshell calcification and progressive massive fibrosis. Of course, ILD can be present in systemic sclerosis. Nothing wrong in that. Sorry? No, yeah, you can keep that. Yeah, but then you haven't pounced. You haven't pounced. You have to pounce. You cannot write the answer later. You have to pounce when I count down. Now coming back to Team D again, we are going to go anti-clockwise for the next 4 of this round. This is question 5 for Team D, direct. 32-year-old male presenting with dyspnea, dry cough, 6-month history, acute onset chest pain for 1 day before his emergency room presentation. This is the CT scan, and this is a photo of his right hand on examination. Anti-topoisomerase antibody is positive. So I want the finding I have highlighted with the red arrow on the CT scan, number A, and what autoimmune disease is described. Pounce closes in 5, 4, 3, 2, and 1. Pounce. Team B has pounced. I'll take that. Just write down, don't answer. Don't answer, write it down. Avarna will collect it from you. Team D, direct answer, please. Go ahead. Disease and the finding.
Option B is systemic sclerosis.
Excellent. So B is correct. And what is A? Say it. Any guesses? No guesses for A. Then I'm going to move on. Passes to Team C. B has been answered correctly. The answer is, of course, systemic sclerosis as the disease. I'm just looking for A. Identify the finding marked with the arrow on the CT chest. No answer. Then I'm moving to Team A as B have already pounced. Team A, answer for part A. Excellent. So I have 2 correct answers from 2 teams. That is pneumomediastinum. Team A has answered the finding correctly, and I think on Team D directly answered part B, that is, this is a case of systemic sclerosis, given the clinical and autoimmune features. And Dr. Mittal, did Team B get the pounce right? Perfect. They didn't write the wrong answer for the other one, so they're going to get plus 20 for one of the parts, that is systemic sclerosis. Well done, Team B. Question 6, anti-clockwise to Team C. Udia Connect. I don't know if this will be too tough or too easy for you guys. 2022 movie, Udia language movie called Daman. Adventure drama based on a doctor's struggles to raise awareness among rural Odisha locals about an infectious disease, X, very common disease. And the table Y denotes the definitions for 2 conditions of pulmonary severity in this infection. So what disease is X have I described, and what is the Y? Any one of the findings of Y will do. The 2 things, the parameters that are described. Pounce closes in 5, 4, 3, 2, and 1. No one has pounced, so Team C, direct question. X, the movie, and Y, what has been described in the table? If there are no answers, I'm going to move. So moving on to Team, are you answering, Team C? Moving on to Team B, any answers for A or B? A is malaria, and what are the complications?
Complications are hemorrhagic.
No, described here. No guesswork. What is the table showing? What is the definition I have put up? Excellent, so both parts are right. On pass to Team B. They get 5 marks each. Yes, please no prompting for the audience. So yes, the infectious disease is malaria, and the second part, of course, those are the definitions for ALI and ARDS. So they have gotten both parts right. So 5 and 5 marks to Team B. Wonderful effort. Coming to question number 7, the 2-parter. very, very famous doctor, a lady, Dr. Anandibhai Joshi, one of the first two Indian women to be conferred a degree in Western medicine. The other happens to be a Bengali woman. She graduated with an MD from Women's Medical College of Pennsylvania in 1886. But sadly, during her stay in the US, she contracted disease X. That is the first part. She returned to India thereafter, but unfortunately passed away the next year in 1887. X is known to cause a type of reactive arthritis called Y, usually seen when X is also present in the patient. So what disease is X? What is Y? This is a direct for team B, so I'm closing pounds in 5, 4, 3, 2, and 1. No pouncers. Team B, your direct question, answer the disease. And what condition is the reactive arthritis? Yes, team B. You have said Ritter's to part B, and what is the disease X?
Disease is Ritter syndrome, and condition gram negative.
So I'm sorry, team B gets both parts wrong. Moving on, passing to team A. What disease did she contract, which is X? And once again, I'll reiterate the question. What condition is Y? Which is a type of reactive arthritis seen in patients with X? X is one disease, Y is the reactive arthritis. Could you answer this, X and Y?
Whipple's disease.
You're saying Whipple's.
Whipple's disease.
And? No answers for B. Moving on. Wrong answer for pass. No negative for team A. Moving to team D. No answers. Team C. Final. Any takers for this? Because the moment I say the answers, all of you guys are going to do a lot of ooh and ah. So I'm closing the question. Anyone from the audience? A very, very simple question. Other than Sumant, other than Dr. Sumant. I know you'll know the answer. Yes, please. Very good. So the answer is tuberculosis is the infection X and Poncet's disease is Y. So well done. Very easy answers. Contracted TB, came back to India, also had reactive also Poncet's is the condition referred to as Y. And finally, the last question of round 1 for team A. 40-year-old lady, dry eyes, dry mouth, presented with 1-year history of gradually progressive shortness of breath and arthritis. Respiratory exam showed bibasal Velcro crackles, and this is the CT. For team A direct, what pattern of ILD is shown number 1, and name an antibody. So I see a lot of pouncers. Pounce closes in 5. All 3 have pounds. So closing pounds. Please take the answers before I take the direct answer. Wait, team A. Let them just finish writing and I'll go to the pounds. Are all the chits taken? Perfect. So now team A, your direct answer. What pattern of ILD? First one.
Lymphocytic interstitial pneumonia.
Excellent answered. LIP or lymphocytic interstitial pneumonia. And what is part B?
SSA and SSB.
Excellent. I'll take both of the correct answers. So SSA more than B. So they got the direct question, both parts right. Now, coming to Dr. Mittal, what about teams B, C, and D? Did they get any of them right? Excellent. Team C and D, 40 marks each, pouncing, getting both the answers correct. And team B? So they get plus 20, minus 10, so effectively plus 10 to team B. With that, I come to the end of the first round. Before going to round 2, Dr. Mittal, please do the honors and announce the scores of the 4 teams. I will explain the rules of round 2 until the time he does his collation of scores. So again, pounce rules apply. I hope all of you are familiar and now with the concept. No more problems with that. But there's a problem here. So these questions have a hint, which will not be on the screen initially. So I'll go again A, B, C, D, and then D, C, B, A. If you feel that you can answer without the hint, any of the other 3 teams can pounce. Very high scores for answering without the hint, plus 30, but negative 15. For the direct team, if you answer without the hint, you will get plus 20, minus 10. If you choose to go for the hint, the scores is halved. So plus 10 and minus 5. And just like the last round, once it passes naturally to the others, there's no negative marking. You'll get a plus 5 only for the answer. Clear? So pounds before hint, plus 30, minus 15. Direct question before hint, plus 10, minus 5. Plus 20, minus 10, sorry. After hint, plus 10, minus 5. Passes 5. Dr. Mittal, please announce the scores. Team A at 35. Team B at 35 as well. 25 for Team C. Team B has sped forward with 85 points. Well done, guys. So, without wasting time, quickly moving into round 2, with or without hints. Starting question for Team A. 28-year-old lady with lupus presented with acute onset shortness of breath. Just an imaging pathology has been shown. Before coming to the hint, I am going to ask to close pounce in anyone wants to pounce. So 5, 4, 3, 2, 1. No answers, please. Team A, wait. C and D both have bounced. Team A, just tell me, would you like to try without the hint first? No hints? Just wait. I'll just take the papers and then chance for you. Done. So, Team A, without the hint, you're going for plus 20 or minus 10. Answer, please.
Pulmonary thromboembolism.
Excellent. So, they have gotten it clear cut. That is pulmonary embolism and not the one I was showing for Bechet's earlier. So, you can see the hint was very easily. I would point out that she has had a history of multiple abortions, therefore going into a sort of antiphospholipid syndrome type presentation. And you're absolutely correct. So, Team A gets that direct without hint right. What about Team C and D who have bounced? So plus 30 each to Team C and D. Wonderful quizzing. Easy question across the board for everyone. Direct question now for Team B. Question 2. No hints. Identify the condition denoted by the images provided. Pounce closes without hint in 5, 4, 3, 2. Team A has pounced and 1. So Team A, please write the answer. Don't answer Team B yet. Are you going for without hint? Team B? So just wait, let them write the answer and I'll ask you. No answers yet, wait. Done? Give the paper. So, Team A has pounced, I'm going to come to the answer in a bit. Team B, direct answer, no hint for plus 20.
Polymyositis.
So their answer is polymyositis. I'm sorry, that is incorrect. Dr. Mittal, Team B gets a direct wrong. Pass to Team C. This pass will come with hint only because now there are no negative markings and the hint was a lateral connect. I was going to show you just this. The book When Breath Becomes Air, written by Dr. Kalanidhi, describes his battle with the disease that can be associated with the manifestation shown. After the hint for plus 5 and 0, Team C, would you like to try? Moving on to Team D, would you like to try? Pass.
Is this psoriatic arthritis?
No, it's not psoriatic arthritis. Coming to Team A who have pounced. Did they get it right? Don't say the answer. So you got it wrong. From the audience, now with the hint. Yes, please. Ma'am, please. Any one of you. No, no. Someone answered it correctly. Other than Dr. Avinash Jain, who will definitely know this answer. That's correct. This is HPOA. So I'm talking about metastatic lung carcinoma and this is hypertrophic pulmonary osteoarthropathy. Well tried, Team A, but they get it wrong. Coming to Team C, direct question without a hint. 40-year-old male with infertility history has come with recurrent sinusitis, chronic productive cough for 15 years. Just spotter images, identify without a hint. Pounce closes in 5, 4, 3, 2, and 1. So Team B and D, Pounce, please write down the answer. Team C, hold on to your horses. I'll come to you. Answers done. Now, you want to try without the hint, Team C? So they want to opt for the hint, so I'm moving on with the hint. No negative marks. So they're going to go for plus 10, minus 5 with the hint. This is the chest X-ray. Attempt for Team C after the hint for plus 10, minus 5. Answer, just answer. It's your direct question. Answer, please.
Carter-Jenner syndrome.
Excellent. So this is Carter-Jenner syndrome, situs inversus. So on the chest X-ray, it's quite obvious, but you can also notice that on the CT image provided with sinusitis. Dr. Mittal, did the pouncers, Team B and D, did they get this right? Perfect. Team D gets plus 30. Yes? I guess so. I agree. So both teams B and D will get this answer correct with plus 30 each. Wonderfully done, guys. Question 4. Without a hint, this is a direct for team D. No one else answer, please. Fibrosing mediastinitis reported on the CT chest of this patient, as you can see, with gradual onset shortness of breath for 1 year. And this is the histopathology slide with a particular finding. What is this condition? So without hint, Pounds closes. 5, 4, 3, 2, and 1. Team C has Pounds. Please collect their papers. And before you answer, do you want the hint or no hints? No hint. Great. Team D are going ahead with without the hint. Let me just take their paper and I'll come to you. Done. So team D, direct question, no hints. What am I looking for? What's the disease?
It's IgG4.
Could you explain the finding? What is on the biopsy?
Storiform fibrosis.
Excellently done. So team D is correct. Fibrosing mediastinitis. The disease condition is IgG4 related disease. A host of pathologies can cause this so-called condition. And what I have shown here, I would just say that this is storiform fibrosis as part of the hint. Team C had Pounds. Did they get that right? Excellent. So team C gets 30. Team D gets plus 20. Question 5, starting with team D now, anti-clockwise. I have shown a table with certain domains, clinical, serologic, and morphologic domains, and criteria are used, it's your direct question, it's okay, to define whatever clinico-pathologic entity I'm describing here. So before the hint, Pounds is closing. I want the name of what I'm describing. 5, 4, 3, 2, and 1. So A and B have Pounds, please collect the sheets. Team D, wait, before the hint, I'll come to you. Team B, please submit the sheets. So coming to you without the hint. No hints, right? Go ahead. If you name the criteria, I'm more than happy to give you all the marks you want. What? I'm just looking for the disease. What condition is being described by these criteria? So without the hint, what is your answer, Team D? On the mic, please. Absolutely correct. So they are IPAF or interstitial pneumonia or pneumonitis with autoimmune features. Excellently done. Team D gets it correct. And Team B had Pounced and A had Pounced. They both got it correct. So 30 marks each to teams A and B. And direct question correct for Team D. No passes for this. And I would just tell you that this would fall somewhere in the spectrum between IPF on one side and autoimmune ILD or CTD ILD as we have been discussing from the morning. So question 6, direct for Team C. The Pexivas trial has improved our understanding on the role of plasmapheresis in ANCA-associated vasculitis, and compared to the older MEPEX trial, this trial had the advantage of including a particular subset of ANCA vasculitis patients, unlike the MEPEX trial. What organ involvement was included as part of the Pexivas study? Without hint, Pounds closing in 5, 4, 3, 2, and 1. So no one has Pounds. Direct answer for Team 6 without the hint, right? Go ahead, please.
CNS vasculitis. CNS vasculitis.
They have answered incorrectly, saying it was CNS vasculitis. Well tried, but that's incorrect. Pass to Team B. No negative marking is there for passes. You can try. Kidney involvement was already part of the MEPEX trial. All they had taken was patients with renal involvement defined in ANCA vasculitis. So incorrect, but no negative marks. Team A.
Lungs.
What?
Diffuse alveolar hemorrhage.
Excellent. So Team A gets it right. They did define a subset of DAH patients, which was a strength of Pexivas. So the hint was going to be just a CT scan showing you a patient with DAH. Well done, Team A, getting it right on the pass. Question 7 for Team B, direct. What diagnostic test have I shown in this image? So without hint, Pounds is closing in 5, 4, 3, 2, and 1. No Pouncers. Direct for Team B. Do you want a hint without the hint? They have opted to go for the hint. So now the hint is, this may reveal abnormalities in patients with myositis or a specific nerve paresis or involvement. On the mic, please. So your answer is, do you think that this image is that of an EMG? So no, that you have answered already. So I understand that I confused you with saying myositis, but I'm looking for what this image is showing. Incorrect answer after the hint, however, for Team B. Pass to Team A with the hint, so plus 5 and 0. Do you want to try? Pass from Team A, moving on to Team D quickly. Pass from Team D and Team C. Audience, please. Yes, please. Anyone, just answer. Both of you are correct. So this is an image of fluoroscopy for diaphragmatic palsy, which I was trying to mark with the arrows of diaphragm movement. Therefore, particularly when the diaphragmatic muscle is involved due to phrenic nerve palsy or myositis, you may expect a sort of abnormality on this finding. Finally, Team A ending round 2 with question number 8. ASSIST and SCOT trials significantly improved mortality outcomes and event-free survival in scleroderma-associated ILD. What was the intervention? What therapeutic intervention was part of the SCOT trials? So without hint, Pounce is closing for you guys in 5, 4, 3, 2, and 1. Team D has pounced. Please collect the sheets. Don't answer anyone. And I'm coming to Team A. Do you need a hint or are you going to try without hint? You need a hint. So let them just finish their answers. I'll give the hint after that. So Team A opted for the hint. So this is your hint. This procedure is basically like an immune reset for the body. What therapeutic intervention am I talking about? Answer?
Plasmapheresis.
They have said plasmapheresis, which is incorrect. I am sorry. So moving to Team D. You have pounced. Coming to you later. Team C, any answers on pass? There's no negative. You might as well try. None. Moving on to Team B. Would you like to try? What intervention was done in these 3 studies? No, it's not immunomodulator. Did Team D get it right? So what was the answer, Team D? Might as well say it for the audience.
Hematopoietic stem cell transplantation.
Excellent. So autologous HSCT, hematopoietic stem cell transplant. Amazingly played, Team D. They are going to get the pounds plus 30 correct. And with that, I would just ask Dr. Mittal to tally the scores, after which he will be hosting the rapid fire last round of the day. Rules for rapid fire while he tells the scores. 6 questions. I'm sorry, for the interest of time, we have come down to a set of 6 questions for each team, starting with A, B, C, and D. Total time of 50 seconds since we have come down to 6 questions. There will be a timer bar. The moment the bar runs out, you are done. Plus 10 for each correct, minus 5 for each incorrect answer. If you pass, you can go back to that question once you are done with the remaining questions, as long as you have time left on the board. I'll be doing the marking and Dr. Mittal will be conducting this entire round. Just to give you an idea of what I mean by the timer bar. So once I start with the questions on screen, this blue bar is going to keep dwindling down, and it will disappear at the end of 50 seconds, by which time you are done. So before this round, please, Dr. Mittal.
So at the end of round 2, the scores are Team A is 65, Team B is 80, Team C is 80, and Team D is 215 marks.
Well done, Team D. Now we are fighting for very close second and third place prizes as well. So now, starting with Team A. If you answer incorrect, that question is closed. Could one of you please take a note of the right and wrong answers marked so that it's easy for sir to tally once? Okay. Just someone sit so that I don't have to keep coming back to whether it was incorrect or right. Team A, are you ready? So your questions start. I'll be reading out each question and then you can answer. If you pass anything, I'll come back to that later. Avarna, you can just sit with sir. So final round of the day, guys. Team A, starting with you. Question 1. Fast fibrosing alveolitis scleroderma trial was for which drug?
Pass.
Pass. Second, Erasmus syndrome is the development of an autoimmune disease due to exposure to which substance?
Pass.
Question 3, they have passed both. SLS2 study compared which drug against cyclophosphamide?
Mycophenolate mofetil.
Correct, mycophenolate mofetil. Question 4, antibodies to THTO is associated with which connective tissue disease?
MCTD.
They have said MCTD, which is incorrect. LIP, lymphocytic interstitial pneumonia, most commonly associated with which CTD?
Sjogren syndrome.
Correct. Which antibody is associated with autoimmune pulmonary alveolar proteinosis?
Pass.
You have still time left for question 1 or 2. Any answers? And you're out of time. So if I'm not mistaken, 2 correct and 1 wrong. Well done, Team A. Moving on to Team B, after which I'll announce all the scores. So, for the second team, Team B. Are you ready, Team B? And your questions start now. SLS3 study for scleroderma. Trial of MMF in combination with which drug?
Pass.
Detect algorithm device to screen for what kind of organ involvement in SSC, scleroderma?
Pass.
Progressive pulmonary fibrosis defined as a 2-year decline in FVC by what percentage?
10%.
Correct. What percentage of MCTD are ANA negative?
Pass.
Cancer-associated myositis is defined if the cancer occurs within how many years of onset of the myositis?
Pass.
Monoclonal antibody used to block the IL-4 and 13 pathways in atopic dermatitis or asthma? Do you want to try for any of the others? SLS3 or Detect? And I'm sorry, your time's up. So 1 correct answer for Team B. Moving on to the answers, questions for Team C. Your time, are you ready, Team C? Perfect. Time starts now. Name the randomized control trial for nintedanib in systemic sclerosis. Pass. Hippocratic fingers refer to which clinical finding? Passing. What maximum score is possible in the MRSS or modified Rodnan skin score? Answers or pass? Passing. What MSA or myositis specific antibody is commonly found in clinically amyopathic dermatomyositis patients? Passing. Imaging modality to differentiate primary versus secondary Raynaud's phenomenon. Correct answer, capillaroscopy, nail fold capillaroscopy, and name a PDE5 inhibitor used in the treatment of PH. Perfect. So I'll take that. Time has just been up. So answers 5 and 6 have been answered correctly. Only 2 correct answers. Finally, for Team D, at this point you're just playing for the sake of playing for this round. So are you ready? Starting with questions for Team D, rapid fire. Your time starts now. The Fascinate trial was for which drug in scleroderma? Passing. Hampton hump may be seen in which condition?
Pulmonary emboli.
Excellent. Correct. Scatting staging is used for which disease?
Sarcoidosis.
Correct. Commonest antibody found in antisynthetase syndrome?
Jo1.
Correct. FVC DLC ratio more than 1.6. This cutoff is for what condition?
Pass.
What type of hypersensitivity reaction is angioedema?
Type 1.
Do you want to try any of the passes? Fascinate trial or FVC DLC ratio? So now what we are going to do, we are just going to wait for the timer to run out, because clearly things have been placid for a while now. Dr. Mittal, please start tallying the marks, after which I'll close the sessions for quizzing for the day, and we are going to announce the winners. Ooh, suspense. Dr. Mittal, please just join me on stage. Before I close, before drum roll, I'd just like to thank the entire OARC team, and especially for helping me out with all these questions. Dr. Sakir Ahmed, who wasn't with us today, Dr. Ranjan Gupta, Dr. Jyoti Paridas sir, who has invited me, and Dr. Saurabh Mittal and myself, because it takes a village to pull off anything like this. Thank you so much. Dr. Mittal, over to you.
So I think these scores are almost like they were at the end of second round. So we have the last is Team A with 80 marks. Then we have Team B at third position with 90 marks. Team C at second position with 100 marks. And Team D has won the quiz with 255 marks. So I think that's the beauty of pouncing and having a lot of different rounds, that you get a lot of advantage of all the questions. So everybody plays fair. Nobody has a problem with that every question is not answered by them. So I think that's all. Now I'll hand over to the organizers.
So thank you, Dr. Shaunak and Dr. Saurabh Mittal. I think they have taken a big Hand of applause, please, for our quiz masters. They have done excellently good job, for which all are sitting here. And I think this is the best quiz we have ever had in Oarc Updates. So thank you, Sanak. In spite of his busy schedule, I think he is about to catch a flight. So thank you for being with us. And all the quiz masters, please come for the felicitation area. Sir. And today we are going to the last session, that is oral presentation. I think this is the most scientific program that we are going to have. We have very original case series. आपका हो गया ना अभी प्राइज मिलेगा इधर नहीं please I'll request all the quiz participants, please give a big round of applause for them. They have done all very nice. So now please clear it very fast. Just put 2 tables like our original this thing. It's kind of a so 2 tables, 4 chairs. So I request Professor Dr. Barundir sir. As the judge for our next session, and Dr. Abhinash, you are the judge for our oral presentation session. So, Medjay. Where is the list? Oral presentation. All the participants who will present their oral papers, please, you can come forward. Because we don't have sufficient time, we'll call you one by one. Okay. So the first is Dr. एका प्रमिला एस जोशी नहीं प्रकाश नहीं आया नहीं उसके बाद में करेंगे
The first is by Dr. Eka Parnika. Our topic is alprostadil in treatment of persistent Raynaud's phenomenon in systemic sclerosis. Dr. Eka Parnika. Dr. Ashrita from IMS Som Hospital. Dr. Ashrita from IMS Som Hospital. Dr. Shreya from AIMS Bhubaneswar. I repeat, Dr. Shreya from AIMS Bhubaneswar. Dr. Vinita, Kalinga Institute of Medical Sciences. Dr. Vinta, Kalinga Institute of Medical Sciences. It's not the right.
Anybody who have selected for oral? Are they please? No. Come. Yeah. Let me find the list. This is wrong. You introduce yourself, then yes, sir. Go, sir. You just introduce yourself.
Yeah, hello everyone. I am Dr. Vrushal from Hinduja Hospital, Mahim, Mumbai.
So how many minutes you have given?
6 minutes.
So 6 minutes for the presentation, 2 minutes for discussion. Name.
Vrushal Kale. Dr. Vrushal. Vrushal. Good evening everyone. I am Dr. Vrushal and I am going to present a study of myositis associated ILD, clinical and serological characteristics and treatment outcomes. Myositis ILD poses a significant clinical challenge due to complex interactions between autoimmune myositis and lung involvement, with ILD being the primary cause of death and hospitalization in patients with inflammatory myositis. The prevalence of idiopathic inflammatory myopathies ranges widely, and ILD is the most common extramuscular manifestation of IM with global prevalence of 41%. The gold standard for diagnosis of ILD is HRCT, and NSIP is the most common radiological pattern seen in these patients. Presently, the treatment for chronic myositis ILD is challenging as there are limited number of clinical trials and lack of strong evidence-based treatment guidelines. This image illustrates the various clinical presentation and serological profiles in patients with myositis ILD. On the top, there is antisynthetase syndrome associated with antibodies such as Jo1, PL12, PL7, EJ, OJ. On the right, there is dermatomyositis-linked antibodies such as MDFI, NXP2, TIF1 gamma. On the bottom, there is overlap myositis, KU, PMSCL, RNP antibodies. And on the left, there is immune-mediated necrotizing myopathy with SRP and HMGCR antibodies. The aim of our study was to investigate the clinical and serological characteristics of patients with myositis ILD, focusing on demographics, symptoms, serology, ILD subtypes, and treatment outcomes. This retrospective study included electronic medical records diagnosed with myositis ILD according to the ACR-ULAR 2017 criteria conducted at a single center, single physician tertiary healthcare facility over a 10-year period of 2013 to 2022. The parameters measured were demographics and serology, complete PFT and HRCT, and the outcome was interval change in the lung functions, transplant, and death. Coming to results, we studied 17 patients with a near equal gender distribution of 8 females and 9 males. The mean age was 46 years and the median age of ILD onset was 42 years. In our cohort, 75% patients had concomitant ILD with myositis. The median interval between myositis and ILD diagnosis was 9 months. Coming to clinical profile, all patients experienced constitutional symptoms of fever, weight loss, and proximal muscle weakness at the onset. ILD-related symptoms were present in all patients. Other symptoms in decreasing order were pharyngeal muscle weakness, cutaneous involvement, joint complaints, respiratory muscle weakness, and cardiomyopathy. Coming to serology, regarding antibody profiles, 35% of patients had myositis-specific antibodies such as Jo1, PL7, NXP2, MI2, and 53% had myositis-associated antibodies such as SMRMP, PMSCL70. Coming to types of ILD, the majority of our patients, 11 out of 17, had NSIP radiological pattern. 2 patients had UIP, 1 had organizing pneumonia, and 3 had undifferentiated types of ILD. This distribution highlights the variability in ILD presentation among the patients with myositis. Treatment profile, all patients received an oral prednisolone 0.5 to 1 milligram per kg taper at the onset, while 7 additionally received pulse MPS. The most common immunosuppressive agent for myositis was MMF, which was used in 9 patients, followed by rituximab in 4. Other immunosuppressants included cyclophosphamide, azathioprine, cyclosporin, and tacrolimus. Coming to treatment outcomes, at 6 months, we saw a mix of improvement, stability, and deterioration. By 5 years, most patients remained stable or showed improvement, with 3 deaths recorded during this period. Discussion. Rituximab played a crucial role in the management of patients who were treatment refractory and had a severe disease. 3 patients showed significant improvement after receiving rituximab. These patients had previously not responded to the standard treatments and exhibited severe manifestations of the disease. 9 patients were treated with MMF, and among them, 3 who switched from methotrexate or azathioprine to MMF demonstrated marked improvement or stability. This highlights MMF potential for long-term disease control. Of the 7 patients presenting predominantly with moderate to severe ILD, 4 achieved disease stability during the treatment period. However, 3 patients unfortunately passed away. 1 patient succumbed to severe ILD while awaiting a lung transplant. Another patient died due to severe pulmonary hypertension, and 3rd passed away as a result of severe lung infection. So to conclude, our study demonstrates the myositis-specific and associated antibodies are valuable in early diagnosis, prognostication, and subphenotyping of myositis-associated ILD. The initial choice of therapy should be tailored to the patient's specific antibody profile and the severity of our ILD. Our findings emphasize the importance of individual care plans and close monitoring to ensure timely intervention. Early and aggressive treatment strategies such as the use of rituximab and MMF can lead to significant improvement in patient outcomes. Thank you for your attention. Yes. No, sir. Loss to follow-up no loss to follow-up actually, besides the 3 deaths, but we had patchy follow-ups. Like 5-year follow-ups we had for all the 17 patients, but few of the patients were not following up at 12 months or 18 months exactly, but then they are coming after a year or so, and then we have done the LFTs.
That you have a good record where you are keeping all the PFTs and measuring lung functions.
Yes, sir.
When you did the retrospective analysis.
Yes, yes, sir. Not all the data was available, but whatever could be made. That's why I have not given any statistically significant data of any PFTs or the serology, because the number of patients are less and some of the data was missing. So whatever I could extrapolate based on just the number of patients that I have presented.
And what was the pattern of ILD in those who died? 3 patients?
They were NSIP pattern. Most of them were NSIP pattern.
Most of them?
Okay. Yes, sir. No, NSIP pattern it was. NSIP. All 3, yeah. Thank you.
Dr. Subarna Acharya.
Good afternoon, everyone. I am presenting on the topic clinical and therapeutic insight in ANCA-associated vasculitis. It is a small comprehensive case series done in 15-month period. Moving to the introduction, ANCA-associated vasculitis comprise rare autoimmune diseases followed by inflammation of small and medium vessels associated with necrotizing granuloma, and that is often associated with ANCA positivity. And mainly there are 3 types of disease included in this, that is the granulomatosis with polyangiitis, eosinophilic granulomatosis with polyangiitis, that is EGPA, and microscopic polyangiitis, that is MPA. And other ANCA-associated vasculitis are drug-induced vasculitis and renal-limited vasculitis that should be ruled out. And the GPA is the most common of 3 types, and incidence is 5 to 10 cases per million, and peak incidence is the middle age, and the MPA is the less common than GPA with a ratio of 2:1 female to male ratio, and EGPA is the rest of the all. Here we report our experience with the 5 cases of ANCA-associated vasculitis during the 15-month period. 4 are GPA diagnosed and 1 is EGPA diagnosed, and we highlight the clinical manifestation, radiological findings, and the response to the rituximab therapy. And this case series mainly describes the clinical and the radiological presentation of the ANCA-associated vasculitis diagnosed cases and response to the rituximab therapy and other modality of treatment like cyclophosphamide in this patient, and highlights the importance of multidisciplinary approach in the management of ANCA-associated vasculitis. So these are all the variables included in these cases, and mostly the age group is ranging from the 30 years to the 47 years, and mainly the symptoms present are dry cough, shortness of breath, hemoptysis, migratory polyarthalgia, and in case 5, it was presented with history of bronchial asthma with abdominal pain and polyneuropathy, which was a slight difference in the clinical feature, and duration of symptoms was ranging from 1 month to the 1 year. So HRCT finding, most common findings were patchy consolidation or cavitating nodules and bilateral GGOs. And some, in one cases there was no any finding, HRCT finding. And biopsy sites were 3 from the lung and 1 from the kidney and 1 from the left sural nerve biopsy was taken for the EGPA diagnosis. Immunological, 4 cases has been positive with the CNCA positivity, highest in the case 1, and ANCA was negative on the 5th cases, where eosinophil was high, 8,500, and renal involvement was in the 3 cases, that is case 1, which present with proliferative glomerulonephritis, case 2 present with the chronic sclerosing glomerulonephritis, and case 3 present with the RPGN presentation, and case 4 and 5 do not present with any renal involvement. DS was present in the 3 cases, and eye involvement was present in the case 1 with EP scleritis and case 4 with bilateral conjunctivitis. ENT involvement was nostril crusting in the case 1, and GI involvement was present in the eosinophilic gastritis that is diagnosed by the upper GI endoscopy. And the neurological involvement was there in the case 5, that is EGPA case, and where we found symmetrical sensory motor axonal neuropathy, polyneuropathy involving the upper and the lower limbs during the NCS. The ACR score in all the cases ranges from 5 to 10, and the treatment was done with the remission of induction was done with the rituximab 1 gram followed and the repeat on the 2 weeks and followed by the maintenance of rituximab. In all cases it responded with the rituximab except in the case 3 where it presented with second time it presented with the DH and the RPGN features. So the pulse cyclophosphamide is given 3 weekly and patient is being on follow up, and 5th dose of cyclophosphamide has been given, and follow up taken from 3 months to the 12 month. And BIVAS score at the initial time of diagnosis ranging from the 6 to 12, and BIVAS on the follow-up was 0 in all the cases except in the case 3, which was follow-up on 5th month was 1 BIVAS score, that is persistent disease. And the adverse effect in the case 1, after using cyclophosphamide, we have seen hyperkalemia and the hyponatremia, so the induction dose of cyclophosphamide was changed to the rituximab. In case 3, after giving Septran DS, there was a hemolytic picture of hemolytic anemia where G6PD was negative, and so we stopped giving Septran DS as a prophylaxis. So outcome in all the cases, there was remission was maintained except in the case 3, which present with the persistent disease with response. And these are the pictures mainly presented with the GGOs, nodule cavitating nodules, and the dense consolidation from where the biopsy has been taken, and the blood bronchoscopy shows the bloody return that is suggestive of the DH. And these are the histological pattern which shows excessive necrosis, asymmetrical neutrophilic infiltration in the multinucleated giant cells in the various cases, and histocytic cells with vessels with neutrophilic infiltration that are suggestive of encapsulated vasculitis, GPA, and fibrinoid necrosis that is typical of encapsulated vasculitis. So moving to the result, in our study 3 were male and average age was 35. Predominant symptoms were dry cough, hemoptysis, polyarthritis, and shortness of breath, and renal involvement was in 60% and DS was in 60% with ANCA positivity in the 80% cases, with BIVAS score of average of 9.5 during the diagnosis, and mean follow-up was around 8.6 months, and 80% respond with the rituximab therapy that was supported as by the REV and the rituximab trial. And in one case GPA with RPGN that failed with the rituximab induction and started on the cyclophosphamide that shows more better response with the induction of remission. So despite the therapeutic advance, mortality was high in the encapsulated vasculitis patient as compared to the general population, that is 2 to 3 times, and definitive diagnosis should be done by the organ involvement, but treatment should not be delayed for the diagnosis, and it is presented by the granulomatous inflammation mononucleated giant cell that are the key pathological findings. And induction and maintenance can be done by the rituximab followed by the low dose steroid according to the Pexivas trial. Evacopan can be used as a steroid sparing agent, and minimum 24 months of maintenance therapy should be given for the remission, and remission occur in the 85 to 90% of the cases, and relapse rate can occur in the 50% of cases within the 5 years. And for EGPA induction and the maintenance, high dose steroid is only required in the non-organ threatening, but if it is organ threatening can be given rituximab followed by azathioprine, methotrexate, or the mepolizumab, and mepolizumab can be used in the relapse cases. So to conclude my talk, early diagnosis and treatment should be given for the prevent and relapse, and rituximab are more preferred in the most of the cases with less side effect profile and required further study to conclude our results, and cyclophosphamide are more potent immunosuppression if used in severe renal involvement, and multidisciplinary approach is required for the management of this encapsulated vasculitis. Thank you.
So well done. Few points. One is your discussion and conclusion should be around what you have presented. You're not presenting ANCA vasculitis in general, where you start talking about mepolizumab is better, cyclophosphamide is should be used in severe cases, etc., etc. And what was the regimen that you had used in your case 3, where you said you gave Ritux followed by cyclophosphamide every 3 weeks?
Yes.
So, did you continue cyclophosphamide for what? How many doses did you give?
Fifth dose given, sir.
Sorry?
Fifth dose it was given. 5 dose.
5 dose?
5 dose. First we started with rituximab 1 gram, repeated on 2 weeks, and it was not responded. And patient has symptoms of polyarthralgia and patient presented with DH, and creatinine was rising, and we did biopsy, and which shows RPGN features. So after that, we induction was done with the cyclophosphamide.
Okay, and all your patients are being, so you have median duration of follow-up is around?
Around 9 months.
So you have given maintenance, what drug have you used? Did you
I have used rituximab.
Okay. And how was eosinophilic gastritis diagnosed in your case 5?
Okay, it was diagnosed by upper GI endoscopy. And from that case, I was diagnosed with encapsulated vasculitis from the sural nerve biopsy, sir. Sural nerve biopsy has evidence of vasculitis. Okay, thanks.
Thank you. Dr. Swati Patnaik. Pointer.
A very good afternoon, honorable judges and my learned audience. I, Dr. Swati Patnaik, PG resident from Respiratory Medicine, SCB Medical College and Hospital, is going to present an interesting case series, Pulmonary Manifestations in Systemic Lupus Erythematosus. SLE is a complex autoimmune disorder in which we find autoantibodies against nucleic antigens, and injury or malfunctions can be seen in multiple organ systems. Pleuropulmonary involvement is to the tune of 20 to 90%. Pleural disease, being most common, can manifest in the form of pleuritis and pleural effusions. Moving to our case series, my case series consists of 6 cases taken from our chest female ward over the last 6 months, and all the females were aged between 20 to 40 years. Case number 1, a 34-year-old female, a known case of SLE with ILD of NSIP pattern, came to us with complaints of fever, cough with expectoration, and loss of appetite for 1 month. On examining her, we found that she was tachypnic and clubbing was present, and on chest examination, she had inspiratory crepitations. We immediately sent for HR-series thorax and sputum examination also. Her HR-series thorax showed ILD of NSIP pattern, but the game changer was the sputum. Sputum Sibinat showed positive results and MTB was detected, which was rifampicin sensitive. Hence, our final diagnosis was microbiological confirmed pulmonary TB with ILD with SLE. For treatment, we gave her ATD and previous treatments were continued. Similarly, case number 2, a very young female, a 25-year-old, known case of SLE, came to us with complaints of swelling of both the legs, abdomen, shortness of breath, and generalized weakness for 15 days. On examining her, we found non-scarring alopecia, tachypnea, and palatal ulcers. Her breath sounds were decreased, heart sounds were muffled, and ascites was also present. SLE with a polycerositis. We sent HR-series thorax. We found bilateral pleural effusion with pericardial effusion. Again, in this case, when we sent sputum Sibinat was positive, MTB was detected, which was rifampicin sensitive. We aspirated the pleural fluid, which was transudative in nature. Hence, our final diagnosis was microbiological confirmed pulmonary TB with serositis with SLE. As for treatment, we gave her ATD and the previous treatments were continued. What we learned from these cases were when a SLE patient comes to us with complaints, constitutional symptoms, we should never forget to send sputum. A 23-year-old female, a known case of SLE, came to us with complaints of fever, cough, swelling of both feet, and also a history of reduced urine output. On examining her, we found that she was hypotensive, tachypnic, febrile, and also pallor was there. We sent for HR-series thorax, which showed ground glassing, and the radiologists opined that the features were suggestive of DAH. In CBC, the total leukocyte counts were 23,000, and there was an acute drop in hemoglobin to the tune of 5 gram %. Her previous hemoglobins were quite normal. The sputum culture sensitivity showed the growth of E. coli bacteria on the 5th day, and hence our final diagnosis was SLE with RAH with severe anemia and sepsis. As for treatment, we gave her antibiotics according to sputum, and previous treatments were continued. She was also put on invasive mechanical ventilation. Case number 4, a 24-year-old female, a known case of SLE, came to us with complaints of left-sided chest pain, cough, shortness of breath for 15 days, and fever for last 3 days. Examining her, she was febrile and tachypneic. When we auscultated her, we found that breath sounds were decreased on the left, and we immediately sent for X-ray, which showed us that there was a left-sided consolidation with moderate pleural effusion. We aspirated the fluid and sent for analysis, which showed us that the cytology was a suppurative one with neutrophils to the tune of 70%, and on biochemical analysis, it was an exudative effusion with very low sugars. Hence, our diagnosis was SLE with left-sided empyema of pyogenic nature. For treatment, we gave her ICTD and antibiotics. Case number 5, a 40-year-old female, a known case of SLE, came to us with a quite long duration of cough and shortness of breath. So, we sent her HRCT thorax, and we found interstitial lung disease of UIP pattern. After that, we also did a spirometry, which revealed a restrictive physiology. Hence, our final diagnosis was SLE with interstitial lung disease of UIP pattern. And for treatment, we gave her inhalers, antifibrotics, mycophenolate, hydroxychloroquine, prednisolone, and diuretics. And my final case, a 24-year-old female who had a bad history of persistent nephritis flare, came to us with complaints of cough, shortness of breath, and anasarca for 15 days. On examination, she was tachypneic and had anasarca. We did a chest X-ray where we found that there was cardiomegaly and bilateral perihilar opacity suggestive of pulmonary edema. Her urine culture sensitivity also showed the growth of Klebsiella species. Hence, our final diagnosis was SLE with refractory nephritis flare with pulmonary edema. As for treatment, she was shifted to the ICU, she was given non-invasive mechanical ventilation, and all the previous treatments were continued. To summarize my case series shows 6 females with a background of SLE of 20 to 40 years of age who came to us with various respiratory complaints like fever, cough, shortness of breath, and also swelling of limbs. We did a detailed chest examination with sputum examination, X-ray, HRCT, and spirometry, which revealed to us important pleuropulmonary manifestations. We diagnosed and treated TB, empyema, ILD, and pulmonary edema with SLE in these patients, and we saw gross symptomatic improvement. What we need to remember is, as these patients are on immunosuppression, they may not manifest classic symptoms of infection, and hence high index of suspicion is required. I thank all the faculties of my department to help me collect this case series, and the team of OARC to give us such a beautiful platform to present this case series. Thank you, everyone.
What was the title of your presentation?
Pulmonary manifestations in SLE.
Correct. And the last case where the patient had pulmonary edema.
Yes, sir.
Why are you calling it a pulmonary manifestation? Was it non-cardiogenic? Like,
Sir, because she had a history of persistent nephritis flare, she was transferred to us from the rheumatology department because she was having cough and shortness of breath, sir. So when we admitted her, we are keeping her in the line, and we are sending the chest X-ray, we are finding infiltrations. So as we have not done echo, so we cannot say it is cardiogenic in nature, although we found a cardiomegaly. So we are keeping it in that line, and also the urine culture sensitivity report showed growth of Klebsiella, more than 10 to the power 4 CFU. So we are keeping it in the line of nephritis. For that, fluid overload and the pulmonary edema.
okay. And I think in your second or third case where the patient had a UIP pattern.
Yes, sir.
You had done a sputum AFP.
Sputum CBNet
was done.
Yes, sir.
Any reason why? Like, or it was just protocol for every
Sir, whenever a patient is admitted to us, like any CTD or rheumatology patients, they are always on immunosuppressants, like steroids and all. So we have a protocol that we will definitely send a sputum for everybody as a routine. And their symptoms are also like that, sir. She was having generalized weakness for 15 days. So we'll send it and we also found it to be positive.
One more last question. Was it surprising to get transurative effusion in your second case, which also turned out to be Cox, where you had bilateral pleural effusion, pericardial effusion?
So we often find
Transurative.
transurative also.
Okay. How often is that often?
Many. Thank you, sir.
Thank you. Dr. Sarthak Verma. Dr. Sarthak Verma.
Good evening, everyone. I'm Dr. Sarthak, first year resident rheumatology from KIMS. I'm presenting a paper on cyclophosphamide is associated with reduced infection compared to the other immunosuppressants in connective tissue related interstitial lung disease. So as we all know that infection is a leading cause of mortality in patients with CTD-ILD, and we compared the risk of infection across the various immunosuppressants used to manage CTD-ILD. So our hypothesis was that the risk of infection in CTD-ILD differs in the various induction regime of immunosuppression. So in this, what we have done that we have included the diagnosed CTD-ILD cases who are on immunosuppression, and we have checked the incidence of serious infections retrospectively. In serious infections, considering that any infection requiring admission or IV antibiotics during hospitalization. And this was further analyzed by using infection-free survival, Kaplan-Meier curve, log-rank test, and Cox proportionate regression. In the results, we have a total 86 patients, out of which 46 were systemic sclerosis, 21 mixed MCTD, and 10 were IPAF, 5 dermatomyositis, 3 Sjogren's, and 1 SLE patient. All of them had median age of 45 years, and 88.4% were females. And median disease duration at presentation was 4 years. So all of these patients, 46 patients have received mycophenolate mofetil, and 22 patients received cyclophosphamide monthly pulse, 20 patients received rituximab, 9 azathioprine, 3 tocilizumab, 3 tofacitinib, and 2 patients received IV IG. And antifibrotics, nintedanib were also given in 32 of the patients. So out of these, 36 patients were on single immunosuppressants, and 22 patients were found to have 2 immunosuppressant exposure, and 16 patients, they have more than 2 immunosuppressants during the duration of our study. And the vaccination status, it was up to date for 41 patients. So means 47.7% patients were vaccinated against influenza and pneumococcus. So our mean duration of follow-up was 308.5, around 11 months, in which we have encountered 57 serious infections in 36 individuals. It means one or more than one infection can be in a single individual also were recorded. So out of these, there were 3 infection-related mortality. So this is the infection-free survival shown by the Kaplan-Meier curve. Here the cyclophosphamide was found to be associated with infection-free survival when it is compared with the other immunosuppressants, in which mycophenolate and rituximab were not associated with infection-free survival. And even this, it is evident in hazard ratio, which is shown by Cox proportionate regression. Here it is also seen that cyclophosphamide has hazard ratio of 0.34 for infections, whereas other immunosuppressants did not reach the statistical significance of hazard ratio. And we have done the subgroup analysis in systemic sclerosis, where it is found that infection-free survival of systemic sclerosis ILD was also associated with cyclophosphamide, and the hazard ratio with cyclophosphamide was 0.2. And whereas in MCTD, the infection-free survival was not found significant, and there no other subgroup analysis were done further because other subgroups were very lower in numbers. So in conclusion, we have made that cyclophosphamide was associated with lower infection risk in CTD-ILD, and similar association we have seen in a subgroup analysis of systemic sclerosis related ILD. And also the important thing we have seen in this, that vaccination against influenza and pneumococcal was not associated with infection-free survival. As this was the duration of 11 months, the mean duration we have done. So there are some confounding factors also possible, but this is the study showing that cyclophosphamide has better association, means lesser infection risk as compared to other immunosuppressants. And as such, we cannot comment that vaccination is associated with infection-free survival by this. Thank you.
Good presentation. Just one question. So how will you analyze a case who's had infection twice? How will you put that case in your Kaplan-Meier analysis? Suppose one patient has had treatment twice, and you're looking at infection-free survival. So what do you do? What did you do? Because you had at least 30 odd patients with 2 infections or more. The second question is that did you control for, as you said, confounding by severity? That means that by the, let's say, the forced vital capacity at baseline, because it may be that you were giving rituximab or cyclophosphamide to the less severe, rituximab to the more
Yes, sir,
severe,
this was the factor.
and therefore the more the severity of ILD, probably more infections.
So first, answer to the first, that if we are encountering a CS infection, like one patient during our study encountered infection, we have taken the course of hospitalization and added into the curve that this patient was having this infection. And during the end of the study, if that patient got again admitted with the severe that infection, that will be counted as new infection, that episode of new infection in the total survival curve. And second, that whether to count the that vaccination part. So we have to do subgroup analysis of those 41 patients, those who we have given vaccination, and we can check that whether the disease severity was more in them or whether they have received more than 2 immunosuppression. So by this we can found the good correlation and better results.
The answers, what I feel is that number one, you'll count it as an event. The first event is counted, and after that the patient is censored. And the answer to the second would be that you would do a multivariate analysis where you would put the severity at baseline as one of the predictor factors.
Okay, sir. Thank you, sir.
Thank you. Dr. Kanhu Charan Nayak.
Good afternoon, respected judges. I, Dr. Kanhu Charan Nayak, PG resident from Department of Respiratory Medicine, going to present a study we have done regarding the clinical radiological profile of connective tissue disease associated interstitial lung disease and its correlation with bronchoalveolar lavage analysis.
Excuse me, what's your name, please?
Dr. Kanhu Charan Nayak. Dr. Kanhu Charan Nayak, SCB Medical College. ILD is a group of disorder characterized by different degrees of lung parenchymal fibrosis and inflammation, sharing some similarities in clinical, radiological, physiological, and pathological features. It has been documented in up to 15% of cases with CTD. According to ILD India Registry, CTD-ILD is the second most common ILD, and according to PGI Registry, it is the third most common ILD. Rheumatoid arthritis and scleroderma are the most common CTD associated with ILD. There are some extrapulmonary manifestations like skin tightening, malar rash, arthalgia, those indicative of ILD associated with CTD. Routine investigation as well as autoantibody testing is required to diagnose a case of connective tissue disease. HRCT thorax is the primary diagnostic test for identifying and diagnosing ILD. UIP is the most common CT pattern in rheumatoid arthritis, and NSIP is the most common in systemic sclerosis. 3 radiography findings suggestive of CTD-ILD are anterior upper lobe sign, exuberant honeycombing, and straight edge sign. PFT usually shows restrictive ventilatory defect. Our aim is to study the clinical radiological presentation of CTD-ILD and to correlate the BAL cytology with the CT pattern. In this study, we have conducted among the 22 patients with CTD-ILD admitted to chest ward, extensive history, thorough clinical examination, routine investigation, chest radiography, HRCT chest and spirometry were performed. Bronchoscopy has been performed in all patients and BAL fluid has been obtained and sent for analysis. In our study, most of them were female and majority of them were of age group of 41 to 60 years. Shortness of breath is the most common pulmonary manifestation, followed by cough, which is present in around 70% of cases, and joint pain is seen in around 32% of cases. On examination, pallor is the most common finding, seen in 50% of cases, followed by cutaneous manifestations, seen in around 32% of cases. On auscultation, all patients are having inspiratory fine crepitations. In our study, we found that rheumatoid arthritis is the most common connective tissue disease, seen in 32% of cases, followed by mixed connective tissue disease, seen in 27% of cases. Reticular pattern is the most common chest X-ray finding, present in 77% of cases in our study. ECG is normal in most of the patients, and sinus tachycardia is seen in 18% of cases. On 2D echo, we found pulmonary hypertension in 18% of cases. Restrictive pattern is most commonly seen on spirometry in 82% of cases in our study. On HRCT, UIP is the most common pattern, seen in around 50% of cases, followed by NSIP in 40% of cases. Lower lobes are predominantly involved in our study group. This slide you can see that UIP is the most common pattern seen in rheumatoid arthritis, and NSIP is the most common pattern seen in MCTD. All patients were undergone bronchoscopy, and BAL fluid is clear in 50% of cases, and in rest it was turbid and hemorrhagic. BAL cytology is inflammatory in all patients with mixed cellularity is most commonly seen around 45% of cases. Here you can see that BAL mixed cellularity is most commonly seen in around all CTD patients, in all types of CTD patients. This slide shows the correlation of the CT pattern with the BAL cytology. Here we can see the patients with UIP pattern on the HRCT has BAL cellularity, mixed pattern of BAL cellularity seen most commonly. There were 5 patients where we saw the BAL culture shows bacterial growth, and the BAL cytology of all of them were neutrophilic, and 1 patient's BAL CB0 was positive. This chest X-ray shows diffuse reticular shadows over the mid and lower zone, and it is a CT of the same patient shows honeycombing and septal thickening, suggestive of UIP pattern. This is a CT of MCTD patient showing ground lashing, septal thickening, giving a crazy-covering appearance in bilateral upper and lower lobe. This is a photomicrograph showing the BAL fluid cytology smear, showing the plenty of neutrophils in flashlight, and plenty of lymphocytes are also seen in the second slide. Summarizing my case, there are 22 patients of CTD-ILD we have taken for study. Rheumatoid arthritis was the most common CTD. Most common pulmonary manifestation was shortness of breath, and joint pain was the most common extrapulmonary symptoms. Bivascular fine crepitations were found in all patients. UIP is the most common CT pattern. Bronchoalveolar lavage cytology was inflammatory in all the patients. Additionally, there were 5 patients with BAL culture showing bacterial growth, and 1 patient's BAL CB0 was positive. Concluding the case, BAL cytology was inflammatory in all patients. BAL alone is not diagnostic. BAL was helpful to rule out infection, especially the TB, as the patient were on immunosuppressive therapy, and also ruling out infection is important since these are the more common reason for flaring up of disease. My limitation of study is a small sample size and single center study. There might be discrepancy in BAL finding due to interoperability and interpersonal variation. Handling of sample and time taken to lab both might have a significant impact on result. Thank you.
So, irrespective of whether you are suspecting infection or not, you are performing BAL on all patients of ILD in your hospital?
Sir, When we are suspecting an infection, then at that time we are doing the bowel fluid analysis, bronchoscopy to rule out the infection.
Okay. Not in your routine patients of ILD where.
Routine patients are not doing, sir.
So probably then that means in these subset of patients you were suspecting infection, only 5 turned out to be of infective etiology.
Sir, bowel fluid is inflammatory in all the patients, but the culture shows some growth of bacteria in 5 patients. And one patient we have got that bowel seminite is positive. In that patient, sputum may be seminite was negative.
Any correlation between extent of ILD involvement on CT and bowel pleocytosis?
So if the bowel neutrophil is more,
in your study?
sir, neutrophilic bowel sample suggests that the prognosis is disease extends more and the progression of disease is more, and bowel lymphocytosis suggests that there is a chance of therapeutic responsiveness.
Thank you. Dr. Surya Teja Meksa.
Good evening to all the respected dignitaries. I am Dr. Surya, PG resident from Department of Respiratory Medicine, KIMS. My topic is prevalence of latent tuberculosis infection in CTD-ILD patients. Tuberculosis caused by Mycobacterium tuberculosis remains a significant global public health challenge. Latent tuberculosis infection does not produce any disease manifestations, but it results in persistent immune response against the Mycobacterium tuberculosis antigens. And it's estimated that approximately a quarter of the world's population is estimated to be infected with MTB. However, most of the infected individuals do not develop active disease, but there is about 10 to 15% lifetime risk of progressing into active TB. And India has the highest burden of LTBI globally, with nearly 40 crore of population having LTBI, of which 26 lakh are estimated to develop active TB disease annually. And CTD-ILD patients encompass a group of chronic lung conditions associated with CTD, such as systemic sclerosis, rheumatoid arthritis, Sjogren syndrome. And ILD affects approximately 40 to 50% of the patients with CTDs and can result in severe respiratory impairment. And pathogenesis of ILD in CTD patients involves a combination of autoimmune inflammation and fibrosis of the lung. And the autoimmune nature of CTDs themselves may predispose patients to infections. And immunosuppressive agents such as corticosteroids, cyclophosphamide, methotrexate, MMF, and biologics like rituximab are commonly used to manage CTD-ILD, which aim to reduce the inflammation and slow down the disease progression. Many patients with CTD-ILD benefit from the immunosuppressive therapy. However, these treatments also suppress the immune system, increasing the susceptibility to infections, including TB. Hence, screening these patients for LTBI for timely action and intervention is of highest priority. The tests currently recommended for LTBI are tuberculin skin test and IGRA. TST detects reaction to the purified protein derivative of Mycobacterium, whereas IGRA measures the amount of interferon gamma released in vitro by white blood cells when mixed with MTB antigens. For the diagnosis of TB, the active TB should be ruled out, and then tuberculosis preventive treatment should be provided to this high-risk group of individuals as per NTP guidelines to prevent the risk of progression into active TB. The aim of the study is to determine the prevalence of LTBI in CTD-ILD patients receiving immunosuppressive therapy. Inclusion criteria are patients diagnosed with CTD and ILD and receiving immunosuppressive therapy for at least a duration of 3 months. Patients of greater than above 18 years are included. HIV patients, CKD patients, ILD patients other than CTD-ILD, and patients on steroid monotherapy were excluded. It was a cross-sectional observational study conducted over a period of 2 years, and 67 consecutive patients were included, and after ruling out active TB disease, quantiferon TB Gold and Mantoux tests were administered. Of the 67 patients included in the study, the mean age of the participants was 45 The majority of of the patients were aged between 40 to 60 years, and majority of them were females, which is around 80%. And the main signs and symptoms were cough and dyspnea, and polyarthralgia, Raynaud's, and sclerodactyly being the signs. Mean duration of the disease was 4.39 years, and the mean duration of treatment was 2.94 years, with the mean FVC being 53.67. And the systemic sclerosis ILD was the most prevalent subtype, accounting for about 36% of the patients, followed by RALD and followed by MCTD ILD. And the most common comorbidity observed in the study is GRD, followed by hypertension and diabetes and hypothyroidism. The drugs used in the treatment, corticosteroids were the most commonly used treatment, administered to 55 patients, which is 82%. MMF followed by MMF in 50% of the patients, methotrexate in 24 patients, rituximab in 17 patients, cyclophosphamide was used by 13 patients. When we found the prevalence of latent tuberculosis infection, considering either positive IGRA or TST, as indicative of LTBI, to be around 29.85%, which is around 20 patients of the 67. And according to IGRA, 22% of the patients tested positive, that is 15 individuals, and according to Mantux, 24% of patients, that is 16 individuals, tested positive, with TST results taken above 5 mm above was taken as cutoff. And the concordance between both IGRA and TST was 86.6%, and the discordance rate was 13.4 among the tests. These are the various combinations. Both IGRA and TST positive are in 11 patients, which is 16.4%, and both were negative in 47 patients, which is 70.1%. This is the prevalence across each CTD ILD and across each drug group. It was seen highest in systemic sclerosis ILD, RALD 25 and 33%, Sjogren's ILD 75%, but the total Sjogren's patients were only 4. And among the drugs, it was seen highest among corticosteroids, that is 32.72%, followed by methotrexate, and then MMF. Conclusion, our study found a LTBI prevalence of approximately 30% among CTD ILD patients on immunosuppressive therapy, which is notably higher than the global prevalence of 25%. This elevated prevalence highlights the increased risk of progression to active tuberculosis in this vulnerable population. Given the significant risk of reactivations in regions with high LTBI prevalence like India, prompt initiation of TPT, tuberculosis preventive therapy, upon early diagnosis is essential for reducing the TB burden and enhancing the patient's quality of life. Thank you.
Good presentation, thank you. My first question is that what is the dose of dose and type of TST did you use in MAN2? Which one did you use? Did you use tween 20?
No, sir. PPD, 5 tuberculin units of PPD 23 was used.
Okay, and how many units? 5.
5 tuberculin units.
Okay, you took a cutoff of 5.
5
that
units.
is based on which criteria?
For immunocompromised and high-risk groups, they take it as 5 mm, so that we have taken.
Okay, my second question is, suppose you have to prove that immunosuppressive therapy led to lower LTBI detection. How would a case control study help?
Yes, maybe if we take age-matched controls, age and sex-matched controls, it would be helpful.
That's right.
And did any of these patients had past history of TB, or that was in the exclusion criteria?
It was not in the exclusion criteria, sir, but these patients didn't have any past history.
And as some of these patients were already on biologics, they must have been screened for TB previously, I suppose, by doing an PPD.
Yes.
So there are chances that if they have been screened, tested for PPD within a year, the recall reaction...
It might boost.
So what's that? Did you check for that?
Yes, sir. We didn't find anything significant like that. Very less number of patients, and that patients we didn't find positivity as such.
Yeah. That's... Yes.
Yes, history was taken, sir. Yes, sir.
Okay.
Among these patients, how many were tested for LTBI before initiating any therapy. They were treatment naive, and we did the LTBI to know whether they harbor any latent infections. And how many were on therapy and you did LTBI, and on therapy, why you did it? What was the need of it?
All these patients we have taken after starting treatment with a minimum duration of 3 months. Previously also they were tested at exact, but not within the 1 year period. Thanks.
Thank you very much. So by the time our oral presentations are being estimated, I would like to request our organizing secretary, Dr. Jyotiranjan Parida, to please come on the stage and give the valedictory function.
So thank you all for being with us till the last. I think you are sitting here continuously from morning 9:30. Now I think this is 6 o'clock, 6:15. So I think you can clap for yourself because you deserve a big clap. And I think as we are discussing, the medical teaching is dying because today it's very easy to organize a conference, but very difficult to find devoted people like you who wants to learn, who want to participate, and because of your participation, actually we get motivated to conduct such conferences. So we are really overall and sincere thanks from ORFT, Odisha Arthritis Rheumatology Foundation Trust, for being here with us till the last. I also thank our guests. Already finished? Okay. So by the time we'll announce result, because this is the last event, by the time we'll announce, I know that you are itching to go. I request all our senior members at least to tell something, one line about the function, how they have felt, and what is the lesson for us.
Thank you, Professor Jyoti. Really, it has also inspired us. Being single-handedly, you conducted such a conference, beautiful conference, and organizing all the quiz, paper presentation, poster presentation in a beautiful venue. We really appreciate you, and a big hand of applause to you and your team. Please. Hope in our next conference, you will also give some time for us. Thank you.
Always welcome, sir.
Thank you. Thank you very much for this wonderful opportunity, and it has really been wonderful since morning, and we are listening a really very good topic. The topic selection has been fine. The presenters have been selected across the country, and I hope all of you have enjoyed it. I have really enjoyed it, and this kind of interdisciplinary interactions is really way forward to look for. Thank you very much for this opportunity.
Thank you. This is an exceptional presentation by OARC Update, and there is a cross communication from different speakers from all over the country, and so many subjects on the breathing deep into lung rheumatology, a new concept, and the association of the rheumatologist and the pulmonologist has given a rare combination, and also there are a lot of things to learn by everybody, by the participants, by the speakers, and by the postgraduates who have come forward with so many poster presentations and oral presentations, and they have stayed since the morning and enjoyed the show. That's the exceptional academic excellence by Dr. Jyotiranjan Parida. Congratulate him for his exceptional endeavor with his wife. So both should be there in the dais so that we congratulate them very much. Thank you very much, and the next endeavor will be soon, and within 3 months or 6 months. Every year he must do 3/4 to engage all the postgraduates in the study of rheumatology in addition to their studies. Thank you very much.
One request with your permission. Madam, I request please go to the dais. Let we give a big hand of applause to Madam Jyoti Parida for helping here Dr. Jyoti throughout the day. I think since perhaps she might have helped you throughout your conference.
Actually, if it is going to be a family affair, I think the maximum amount of effort has been done by a single person. My brother, Smruti Ranjan Parida, he is there.
Come, please come.
Actually, the souvenir that you are seeing, we have not taken the help of any professionals. He has done the designing, he has done the all editing, and he has made it possible within 3-4 days.
Great.
And all other arrangements is from the morning behind the scene. So, we can put
ठीक है वाइफ को प्रशंसा करो ज्योति हे कोरोना व्हाट इज दिस एटा कोटा करो
करी की लाभ नहीं ना okay it's actually if there is no family member support, I think you cannot do anything, because throughout the day we are so busy, all doctors I think, and because of all our wives I think we are surviving. So you tell or don't tell, I think that is the truth. So I think before that, all of us will at last we'll have a group photograph, right? So let me tell about the results, because you all are waiting for that. So the quiz we already know. The third position, the winners, they will come here for the taking the prize. Sir, you can give the first prize. Yeah. So, yes. So bring the prizes. Bring the prizes. You call, sir.
For quiz, the third prize goes to Gyanendra Kumar Nanda and Roshan Kumar from SCB Medical College.
So I invite Dr. S.N. Swain sir and Dr. Jyoti Patnaik madam to give the prizes for the quizzes. You tell this is a cash prize of 1,000 rupees with a certificate.
It's a cash prize of 1,000 rupees with certificate and memento. Second prize goes to Rakesh Kumar Behra, Shanti Swarup Sahu, MKCG Medical College. It's a cash prize of 2,000 with the certificate and memento. The first prize goes to Siddhant Sahu and Chandan Kumar Sahu, SCB Medical College.
So this is 2,000 and 2,000. So 4,000 rupees for the team. इतने सारा प्राइस It's 3,000, 3,000, 6,000.
The cash price is 3,000 per head and a certificate and memento.
ये ले लो. First prize के लिए.
First prize Siddhant Sahu and Chandan Kumar Sahu. Next for poster presentation. Third prize goes to Tanushri Sanghi, IMS in Som Hospital.
Poster.
Tanushri Sanghi, IMS in Som Hospital. Second prize, Dr. Gyanendra Kumar Nanda, SCB Medical College. Group photo. Second prize, Dr. Gyanendra Kumar Nanda, SCB Medical College. And first prize is Israrul Haq, IPG MER, Kolkata.
Now I invite Manoranjan Bhai and Manoj Bhai, please come to the stage for the next round of prize. Thank you, ma'am. Thank you. So this is for the oral
presentation. For oral presentation, third prize goes to Dr. Subarna Acharya.
Which medical college?
It's not written.
AIMS. So Subarna is from AIMS.
AIMS Bhubaneswar. Second prize goes to Dr. Vrushal Kale. He's from Hinduja Hospital.
PD Hinduja Hospital, Mumbai. So please.
And the first prize goes to Dr. Sarthak Verma. From KIMS Bhubaneswar. KIMS Bhubaneswar.
KIMS got the first prize.
May I request all the winners to please come up on the stage for a group photograph.
All the winners. All the winners,
with your
please stay.
prizes, with your certificates, with your trophy and certificate.
Thanks. Valediction. I'll request our scientific chair, Dr. Ranjan Gupta, please come. This is all your hard work. Yes, आपको साथ में रहना है उनका. उनका कर लेते हैं फिर हम लोग. करो. आगे. ये लाइन में आ जाओ. ये लाइन में आ जाओ. बस. नहीं प्राइस फोटो So every good thing comes to an end. So at the outset, I think two prizes actually left actually. Two DM students from pulmonary medicine from SCB. Actually in the prelims of the quiz, actually they have scored the highest mark. Just because of we have categorized into MD medicine and MD pulmonary medicine. So we couldn't include those two I think, who are they? Those who are from DM Pulmonary Medicine, who have scored highest mark. I think they deserve a certificate of appreciation. So please come forward. Please come forward. I think they have got the highest, because there is so much of difference. We have to exclude them because they are outliers. Excellent. Please come. So I'll do that honor, I think. So they are from AIDS, Pulmonary Medicine. Yes. So, at last, the most difficult job of Thanksgiving, because I think first you have to thank your planetary positions, because without that, nothing can be possible in this universe. Maybe this crowd at 6:30 p.m. is because somewhere our planetary positions are in the right position. First, I think we'll start from the reverse, because it is all the audience or the delegates, they define the success of a function. Whatever good speakers you have, whatever best arrangement you have, whatever the best hospitality you give, until otherwise there is a good amount of delegates who are really dedicated for the purpose are not there, I think any medical conference or any educational conference is incomplete. So thank you all for being with us. Our sincere thanks to our esteemed speakers who have come from so far. Just because nowadays to have one extra day in your curriculum is so difficult, and whoever I have approached, I am very thankful to them. Nobody has denied me. Whatever topic I have given or we have given, they have all agreed. And I think you have all shown the what a display they have done. That is, it's a full day of academic. I think this was a marathon. You cannot leave your seat. So a big thanks to them. A big thanks to all our societies that were involved actually, because only OARC actually cannot make anything happen, because we don't have students. So I'll first thank Professor Dr. Manoranjan Das Bhai. Please give a big hand of applause, because of him, he not only made sure that people will come from SCV Medical College Pulmonary Department, he made sure that people will also come from some hospital pulmonary medicine. He also ensured that people will come from high-tech medical college. He called me and ensured that all will register as a single place. So we have just sent some person, they have registered at their pulmonary meetings. So we had an extra stall for OARC update. So I think because of his sincere efforts, whatever you are seeing is possible. Thank you, Bhai. I thank our API chairman, sir, Dr. S.N. Swai, sir, because he is the man sitting here. He is already 70. Can you believe? So please give a clap for this young old man. Thank you, sir, for being with us. Jyoti Patnaik ma'am is with us. Dr. Barundir from PGI, he is with us. Still, till the last, he is judging. He is still energetic. Abhinas is still young. He can be energetic. Ranjan was actually, he was having viral fever yesterday, so he told me not to cancel. He told me just postpone my flight ticket for 6 hours, I'll be all right. And today morning 3 o'clock, he boarded the flight, 5 o'clock he boarded the flight and reached here before I reached the venue. So please, that amount of dedication, please give a big round of applause. I think we'll have a group photo till the last, please, another 2 minutes. Dr. Saurabh Mittal, because his session is over since morning, but he is still there cheering for us. So thank you, Dr. Saurabh Mittal. And I think IRA, Indian Rheumatology Association, both President and Secretary, Dr. Chandrasekhar sir and Dr. Binod Rabindran sir, they have all conveyed their messages, because personally they are not here. But they categorically told any help, whenever I have approached that we want your logo, we want your collaboration, they immediately agreed. So I must thank them for their cooperation. And there are so many people who have actually worked day in and out. Manoj from IPCA. Manoj is actually, we had not hired any event people, no scientific people. I think Manoj had sat behind me from He had an office actually at ORC for last 1 month, who is doing all this mail and everything and all these arrangements, because so much from tickets to everything I think he has done and his team has done. And I think no such events is successful without the involvement of the pharma people. Before that, Saroji kahan hai? I think, please, he is the man behind this Mayfair show, because I have never come to Mayfair. In the last 1 month, I have never come because our association has become so strong. मुझे सिर्फ उनको बोलना है कि हमको इस बार ORC अपडेट इसी डेट में करना है. बाकी कहाँ होटल होगा, कैसे स्टे होगा, he is taking care of everything. Even we have not seen the menu of the food that we have eaten today. Today morning only I called. अरे आपने हमको तो मेनू नहीं दिखाया. उन्होंने बोला कोई मेनू देखने की जरूरत नहीं है. We will take care. So please give a big hand actually. Because of him actually I am able to do this. Without a team you cannot have anything. And he is associated with us for the last 3 years. I think at last I will tell all the pharma people present here, because actually in a medical conference you people are the main cornerstone actually, because without your help these mega events are not possible. Whatever said and done, it is you people actually behind the scene, you contribute a lot, so a lot of thanks to you. I think we have prizes for them. There is I think I can call the participation certificate, please. One by one we can call and give them the participation certificate. I think before that, if you are getting late, or we can wait for 5 minutes. We can wait for 5 minutes. Please. I think you can come with your team and take the certificate. First is Pharmed Limited, please. Anybody from Pharmed? Anybody from MSN? Please come quick. Anybody from Torrent? Please come with your group. Yes. Torrent.
MSN Laboratories.
MSN, anybody from MSN? Sorry, next.
Hetero Healthcare.
Anybody from Hetero? Come, anybody come. Come fast.
Overseas Pharma.
Sir.
Intas Pharma. Intas. Nobody?
Intas.
RPG Life Science.
RPG.
Pfizer.
Pfizer is there. Intas.
RPG Life Sciences. MSN Laboratories. Sun Pharma. Nobody?
From Sun? Micro Labs.
Followed by Mankind. Next, Reliance Pharmaceuticals. Next, Sipla. Sipla. Doctor ready, Leo? Doctor ready? Nobody here seems.
One less, please come.
After Wallace, I would like to request Ajanta Pharma, followed by Vasu Organics. Pulse Pharmaceuticals. Next, Zydus. After Pulse. Zydus.
Health and अरे I think this is the team who was doing that photograph activities. I think just to give it a national level. And I think in rheumatology, because for every event you have a main sponsor. I think in rheumatology, no conference is complete without the support of IPCA, Activa and Actinova. This is with, I'll call the whole team of IPCA, please, the whole team. Because they have the greatest support in any rheumatological academic activity you do, any corner of the country. They are fast to support not only financially, manpower-wise, administration-wise. I think they have the whole team. So, I think there are many more behind the scene which I can't name them, but we all appreciate their support throughout our journey. And at last, I will invite everybody to have a group photograph and then we'll disperse. Thank you all once again.
So the rheumatologist has reached the lung parenchyma. Rheumatologists have reached the lung parenchyma.